पूर्वनन्दनं सुरारिगर्वचर्वणं प्रपञ्चनाशभीषणं धनञ्जयादिभूषणं कपोलदानवारणं भजे पुराणवारणं भजे पुराणवारणम् नितान्तकान्तदन्तकान्तमन्तकान्तकात्मजम् अचिन्त्यरूपमन्तहीनमन्तराय कृन्तनं रुदन्तरे निरन्तरं वसन्तमेव योगिना त्वमेव दन्तमेव तं विचिन्तयामि सन्ततम् विचिन्तयामि सन्ततम् विचिन्तयामि सन्ततम्.
On APRCON 2020.
Director of Southeastern Railway to come over and take over as the chairperson, and our Director General Sir Dr. Jagdish Chandra sir will be joining us soon. He is on the way to Vietnam. Over to the chairpersons.
Ma'am, we'll introduce.
Good morning, everybody. Today's first speaker is Dr. Shiv Kumar. He is from he is the head of the Department of Cardiology at Apollo Hospitals, and he is going to be talking to us virtually. And his topic is AI in cardiology. So, over to the screen. Our speaker is Dr. Suja. I stand corrected.
Gender.
I'm sorry. I'm sorry.
Morning, namaste everyone. It's such a pleasure and an honor to come today morning representing Apollo Hospitals and my mentor, Dr. Shiv Kumar sir, who could not be present here today because he's traveling, he's in US. So he wanted me to come and talk about the research that we have been doing together for the past 8 years. I am Dr. Sujoy Kaur, a physician by training. My specialty is infectious diseases. But I have been working with Apollo for past 21 years in different capacity. And we now have 3 labs which look at our data that we have been collecting longitudinally for the last 15, 16 years to build different clinical AI tools. And the story today that I have is of two of these tools, where we have gone the length of what we call as the design, development, and deployment of these tools. And I'll show you what is the impact that AI brings in clinical practice or in clinical application. I have been given about 20 minutes, and I know 10 minutes passed because of the fact that we were just had a glitch. So I will be as short as possible, but I promise that if there are interest in these areas, it would be wonderful to actually then go about and have this conversation ongoing. I am also aware of the fact that I am speaking in front of a very illustrious panel here, chairpersons who have, dedicated their life in the work for the community, in the cardiovascular practice and others. And these will be very basic in front of their eyes, but with all their permission and blessing, I'll just go about and show the work that we have been doing. So at Apollo, with the kind of the data that we have been collecting in the last 15 years, for all practical purpose, if you can shut these lights off, it would be easier. Otherwise, it's, I'm not an epileptic, but I might just get one. The theme is this, that then how do you go about in using the data that you have collected for about the last 15, 16 years. And we're talking here about a volume of data around 50 million patients. At Apollo, we have treated about close to 200 million people. But as the Chief Medical Information Officer of Apollo, if you ask me, do I have all the longitudinal records of all 200 million, I would be not stating you the fact. But yes, we do have about 50 million people's record. And those records longitudinally has helped us in building these tools. Now, these tools come in 4 different categories. Number 1 is on the disease progression. Can we look at someone who was 10 years, 15 years back, normal, had some comorbidities, but over the next 10 years developed cardiovascular illness, had an event, came into the hospital, and got treated. Similarly, look at it from the perspective of somebody who is a possible pre-diabetes or diabetes and their pathways. Liver fibrosis, we all know the entire MSLD pathway or MFLD pathway and how liver fibrosis are happening, CKD progression, hypertension, and others. Similarly, the vast of work that we have been doing on chest X-ray abnormalities, tuberculosis, one of our algorithms that we have is world's 2nd best algorithm published at Lancet Digital Health. Mirai, which is the prediction of breast cancer in next 5 years, is a joint work between our labs and MIT at Boston, where I was trained. So I went back to my professors and said if we could do some work on breast cancer, lung cancer, and also ECG, which I will be showing. Then there are some work that we have been doing on acute care, particularly in clinical deterioration at the hospital or selection of antibiotics, looking at pre-anesthesia and what are the outcomes from a surgical perspective. And then the whole generation work around the generative AI, where we can use productivity tools like discharge summaries or virtual tumor boards or the nurse documentation and others. And all of these have helped us in now having this, and as I speak, these are all what we call as certified tools. But today I'm going to just talk about the primary tool which Dr. Shiv Kumar sir helped us in design and develop, and now we have gone about. The whole purpose of this is that we know in India the problem is of silent heart attacks, which is happening in our gymnasiums, in our offices, in the ways that
I welcome our respected DG sir, Dr. Jagdish Chandra sir, to this August conference. And I would request DG sir to kindly please chair the session, sir.
Respected sir, I was just beginning our presentation, and I had just mentioned about how at Apollo we have been looking at the longitudinal data to build tools that are now clinical AI tools. And I was just talking about 20 different tools that we have, out of which the specific one where we have the maximum work on the cardiovascular and the longitudinal nature of the data that we have been able to do on a perspective. These are not something that you don't know. You already are aware of the silent heart attacks in young Indians. We are now seeing people dropping dead at gyms, at offices, at possibly every other places. And therefore, for us, it was very important to then go back and look at what are those predictive tools that are available in the different parts of the world in terms of Framingham risk or Q risk or WHO-ISH or ASCVD scores. And how do they then employ in Indian context? And then we found that their performance in Indian context was not that great, particularly in the population that we were studying. So we built a deep learning algorithm with the help of Microsoft way back in 2018-19, and then went about in publishing it, validation of that particular tool in several countries, including in Netherlands, in the Maastricht population, King George Medical University in Lucknow, and we found out that our tool was performing much better than the Framingham risk score, even in Caucasian population, which actually signifies when we give significant amount of data, plus when we are bringing in also technologies like deep learning, then it goes about in doing this. We now have patents. We have been recognized at Cardiology Society of India. We have several papers, including one at the PMJ, about how we went about in doing this. But the story is what happened after 2020 when we rolled this out in the community and we started looking at, we now have 3.5 million people who have gone about in taking this prospectively. And we in the communities in different parts of the world, we found that around 8 to 10% are the people who are at the high risk, and about 15 to 20% are at the moderate risk. It is about how we have deployed this across the different ecosystem at Apollo. And one of the things is then to do it at an outreach camp where we have minimal internet connectivity, and in somebody's smartphone we will be able to collect this data in 7 to 8 minutes and stratify the individual to say what is their cardiac risk score, and then follow a clinical pattern to say what would be the lab diagnosis, diagnostic imaging, referral to cardiologist, advice, repeat visits, and all that. Now, these are fantastic to know or do, or even look at in 3.5 population. But what is the impact it is bringing? Now we have a 5 years longitudinal study, which we are now validating and coming up in one of the publications at Lancet, where we have been able to tell them that people who were at the high risk, 44% of them have been able to lower their risk category. In the medium risk category, they have been able to bring it down to about 16.75. But all stories are not good stories. There are people who have moved on from lower risk categories or moderate risk categories to higher risk categories because of their behavior. But we are not again solving a rocket science, but then reinforcing what we already know in terms of glycemic control, in terms of control of blood pressure, weight loss, physical activity, and cessation of tobacco and smoking, which are all, by the way, very important factors for us. So we're getting now much better results in the prospective cohort than what we had in the retrospective cohort. We looked at the data when these patients, now, even if you are on a high risk or a moderate risk or a low risk, it does not prevent you having cardiovascular event. And when you have cardiovascular event, when you come to the hospital, when these patients come comes to the hospital, what happens then? And this is what we studied, and when we got the results, we were pretty alarmed. We asked an independent organization to come and audit us and to tell us, are we right? What we are finding out that their length of stay, mortality, ventilations, all are reduced in these cohorts that we are studying. And we are finding this in the way that 5-year follow-up of this with survivability pods. But what is standing out is, again, those chronic diseases like diabetes and hypertension and the impact that it has on cardiovascular health. We're now getting data not only from Apollo Systems and other Indian sites, but also from Indonesia, from Middle East, from Latin America, and we're beginning to now get data also from Europe as we do this prospective cohort and see in their community how this is. I'll switch on to very quickly the other work that we did on ECG, which was about predicting accuracy in categories, converting waveforms from your ECG images to XY coordinate. And we presented this to American Heart Association, published this in Circulation, and then went about in building our next model where we are taking almost 500,000 ECGs and using technologies like deep learning and generative AI to actually then see if we can read an ECG in an automation way. And we're getting some good results in this. Currently, if we use 12 lead ECGs, we are almost 100% with the way the cardiologists or senior cardiologists are looking at it. But if we do not get a proper ECG, we possibly are looking at about 84%. We're not 100% if somebody is scribbling over the ECG or putting a stamp and we looked at quite a significant numbers as we roll it out. I'll not go in the interest of time on all of these details, but I'm going to just show you a video of how this works. I hope the sound plays as well.
Welcome to the AI-powered ECG Assistant demo. This platform utilizes AI models for ECG interpretation, supported by 3 key components. Model 1, Instant ECG Image Interpretation. Model 2, Signal-based analysis with integrated Q&A. Model 3, Heart failure risk prediction. Clinicians can securely log in after accepting the terms, accessing a dashboard with analyzed ECG records. Patient cards are color-coded. Green for normal, red for abnormal, with review status labels like done or pending. To begin a new case.
Okay, I'll stop there. And the purpose of this presentation was to see how, when you have the data in your databases, how do you go about in design, develop, deploying these solutions after you have obtained appropriate certification. Many of our tools are now either FDA certified, and we're getting our CE by the end of this month, to actually then go about in seeing, how safely that you go about in doing this. Fundamental point is this, that all of these tools are the ones that aid the practice of patients rather than directly going and looking at and giving it to the patients, because we understand the risk of taking certain things like an cardiovascular risk analysis or even an ECG interpretation directly on the hands of patients. So first it has to go to the hands of the physician or the clinicians before we go about it in giving it to the patient. The patient-physician conversation has to be aided with the help of AI, not the vice versa. Thank you very much. I'll have this presentation sent out for you to have a look and see how we take it forward. Thank you very much.
Thank you so much, Dr. Sujay. We'll keep questions to the end of the session, so if anybody has any questions from the audience, they may call upon you.
Sure.
Thank you so much.
Thank you, sir. That was a wonderful, lucid presentation about AI and cardiology. Now, I would like to request the next speaker, Dr. G. Kondalrao, sir, to come and give his talk about heart failure and newer guidelines in treatment on heart failure. I request chairperson to kindly introduce
Our
the
next speaker is Dr. Kondal Rao. He is MD, DM in cardiology. He is a senior interventional cardiologist and is an expert in the field of cardiology. In fact, we are utilizing his services in our cath lab. He has done his MBBS from Kakatiya Medical College and his MD from Gandhi Medical College. His DM from Usmania. And he's currently working in Padmavati hospitals. Welcome, Dr. Kondal Rao.
Slide. Go to this one. Okay. Yeah, good morning, everyone. And it's my pleasure to speak before the dignitaries and DGM and other chairpersons and my colleagues, my friend Sai. And today my topic is heart failure, recent advances. And you know that as the aging population is increasing in India, the number of heart failure patients are increasing. If you see the statistics of the heart failure in India, it's about 4.5 million people are living with the heart failure. Every year, almost 500,000 to 1.5 million heart failures patients are added to this data. So why these heart failure patients are increasing day by day? Because aging of the population, number one. Number two is the increase in the risk factors like hypertension, obesity, and usually if you take the diabetes, India is the capital of the diabetes. That's why the number of patients with diabetes are increasing, obese patients are increasing. There is likely to increase the heart failure patient in future. So if you take the definition of the heart failure, usually there is a universal definition of the heart failure is there. This is the symptoms and signs of the heart disease caused by structural abnormality and supported by the evidence, objective evidence like echocardiography and NT-proBNP. These three factors are very important to diagnose the heart failure. So usually, previously we used to diagnose as a mild heart failure, moderate and severe heart failure. Now classification has changed to one is depends on the ejection fraction of the heart. This is depends on the echo findings of the heart. If you take the normal ejection fraction is around 60%, and how will you classify? If the EF is less than 40, we'll say as the severe. This is called heart failure with reduced EF. If it is between the EF is between the 40 to 50, we will say mildly reduced ejection fraction. Third one is we can say as the preserved EF, heart failure with preserved EF. Now if you take statistics in India, the heart failure deaths are increasing previously, but the last 5 to 7 years, advent of the newer medications like ARNI and DAPA, there is change in the reduction of the heart failure deaths, and hospitalization also reduced because of the advent of the modern medications and following the GDMT. And what are the risk factors for the heart failure? These are routine risk factors like hypertension, obesity, and diabetes, and coronary vascular disease. So broadly, you can divide into two classifications. One is heart failure induced by the ischemic heart disease or non-ischemic. Non-ischemic means it is the cardiomyopathies, rheumatic heart disease, endocrinal diseases, peripartum cardiomyopathy, and so on. So broadly, we can divide into ischemic and non-ischemic. Ischemic is most of the times it is preventable and curable, and if you recognize early, you can prevent the development of the heart failure. How do you diagnose the heart failure means it depends on the signs and symptoms of the heart failure. What are the signs? It is the breathlessness and generalized weakness. Clinically, you can see the rales in the lungs and pedal edema. And you can divide into right heart failure signs and left heart failure signs. And the basic investigations like echocardiography, electrocardiogram, ECG, and biomarkers like NT-proBNP very important to diagnose the heart failure. If you take this, if you are suspecting the heart failure, first what you have to do, you have to see the NT-proBNP or echocardiography. If EF is less than 50, you can diagnose as a heart failure with reduced EF. If the EF is normal, you can say heart failure with preserved EF. So what is the first Class 1 recommendation of the test for the heart failure patient? Basic investigations like X-ray and echocardiography, and if necessary, we have to go for the cardiac MRI to know whether there is treatable causes, any fibrosis of the heart, and so on. And class 2 indications are like going for the other like PET scans and all that. Depends on the clinical situation. Once you are diagnosed as a classified the heart failure, you can stage the heart failure also. One is the heart failure who are going to develop the heart failure, and you can recognize the pre-heart failure situations. And stage 3 is symptomatic heart failure, and stage D is the advanced heart failure. So what are the situations where you can diagnose as a pre-heart failure means there is no signs of the heart failure, but there is structural heart disease like rheumatic heart disease or cardiomyopathy, but there is evidence of the biomarkers like NT-proBNP, BNP, then you can classify it into stage B. And stage 3 is documented heart failure. If it is advanced heart failure, you have to go for the GDMT. And how will you treat these patients? Nowadays, we got the guidelines, that is GDMT. GDMT means guideline-directed medical treatment. Once you diagnose the patient with heart failure with reduced EF, then there is 4 pillars of the heart failure treatment. One is ARNI, second one is beta blockers, third one is MRA, fourth one is DAPA or empagliflozin. This is SGLT2 inhibitors. This is the breakthrough in the treatment of the heart failure. Then you classify. Once EF is less than 30, you see the QRS duration. If the QRS duration is more than 150 or less than 130, you can decide what mode of treatment you are going to give for these patients. Usually once you diagnose the heart failure, always every patient should receive the ARNI if there is no contraindications like hyperkalemia or angioedema, other clinical situations. And the QRS duration is very, very important. For example, LBBB is there. What mode of advanced treatment you are going to give? For example, QRS duration is more than 150 and EF is less than 30. That patient can go for the CRTD. And if the EF is less than 35, QRS is more than 130, I told you it is go for the CRTD. If the EF is more than 35, and maintain and continue with the GDMT. Yeah, what are the basic treatment is, I told you, ARNI. Second one is beta blockers. All patients should receive the beta blockers, especially carvedilol or metoprolol or bisoprolol. These are the three medications indicated in the heart failure patient if there is no contraindications for these medications. Always monitor the heart rate and see for the other symptoms like bronchospasm is there. If they are not tolerating, don't give the beta blockers. And third one is SGLT. This is the breakthrough treatment in the management of the heart failure. Why we will give the SGLT to not only controlling the sugars, even not, if patient doesn't have the diabetes also, we will try to give the SGLT2 inhibitors. What the basic mechanism? It increases the diuresis and it reduces the mortality and improves the quality of life, and it reduces the fibrosis of the heart also. Once patient is under this GDMT, if they are not under control, if for example heart rate is still more than 100, what medications you are going to add? You can add the ivabradine and other. Ivabradine is the 2A indication actually. And other medication, patients are not tolerating ARNI or ACE inhibitors or ARB, then you can go for the Versigard. And if refractory heart failure is there, you can add the digoxin. And sometimes the patient had the hyperkalemia, you can add the K binders. This is not working. Not working, see? Not moving. Yeah. So once you diagnose the treatment, started with the basic treatment and go for the second one. It depends, I told you that depends on the EF. EF is less than 30 and QRS is more than 130. Then you can either go for the CRTD or CRTP. P is the pacemaker, and all the patients with EF less than 30 and with the evidence of arrhythmias, they should receive the CRTD or CRTP. Sometimes patient can have the MR. Once the cardiac chambers are elevated, there is a chance of having the MR. Despite giving the best medications or GDMT, patient is not responding. See for the secondary causes like MR. If the severe MR is there, what you have to do? First, you have to assess and whether patient is fit for the surgery, then send for the mitral valve surgery, like valve replacement or repair of the mitral. If the anatomy is not favorable, high-risk patient is there, sometimes you can go for the transcatheter therapies like a TEER in subset of patients. Second category is the patients between the EF of 40 to 50. How you are going to this patient? What are the recommendations says is all patients should receive the diuretics, and there is limited evidence for the ARNI in this subset of patients, and ARNI ACE inhibitors. There is indication for the SLD2 inhibitors like DAPA or EMPA in this subset of patients. The studies favoring this are the EMPA preserve, another one is the DAPA HF preserve. These two trials indicate that there is definitely substantial improvement with the usage of this medication in this patient. In recent years, with the use of GDMT, there is increase in the prevalence of the heart failure patients with preserved EF. EF is normal, but there is signs and symptoms of heart failure. How you are going to treat this patient with this one? And this patient, they should reduce the diuretics, SGLT2 inhibitors, and limited role for the ARNI and ARB in this subset of patients. And despite giving the medications, patient advanced to decompensated heart failure and advanced heart failure. But the advanced heart failure definition is the patients with the EF of less than 30%, and the patient are not responding to the medications, and persistently elevated biomarkers like anti-proBNP and BNP. And repeated hospitalization, this patient can be categorized as advanced heart failure patient. And one more question is whether we have to restrict the fluids in the heart failure patients. Majority of the RC study shows that there is no benefit or in these patients restricting the fluid. But our experience is to restrict the fluids up to 1.5 to 2 liters, and daily measure the weight, whether patients are increasing weight, whether going for the failure. The simple measure, you have to check the weight of this patient. There is increase in the weight means you have to upgrade the diuretics for this patient, and restriction depends on the clinical situation and all that. And which patients requires the mechanical ventilator support or mechanical assist devices, left ventricular assist device, and a cardiac transplant. The patients who are not responding went into class 4, NHO class 4, and they are not responding, probably you should consider for the LVAD or cardiac transplant. If the old age population, you should go for the LVADs to prolong the life, or you can use it as a bridge for the cardiac transplant. As I told you, the only selected patients can be referred for the heart transplant, like young population, and we have the more life expectancy, and a major problem in this is availability of the organs. And one more thing is, patient is recurrent hospitalizations, decompensated heart failure, and you have to see for the precipitating causes, and evaluate the severity of the congestion, and assess the adequacy of the perfusion, optimize the volume intake, and address the reversible factors like infection or other reversible metabolic causes. As I told you, always monitor the fluid intake and output and weight measurement daily, and note down the signs and symptoms of the heart failure, and see the signs of the hypoperfusion, and supported by the laboratory investigations. After initial diuretics, how will you manage the diuretics if they are not responding? And you can give the IV infusion, and or you can give the increase the loop diuretics, add the other medications like dopamine or nephron block inhibitors like thiazides you can add. And other subset of patients, oncology, and another one, pregnant ladies, they may present with peripartum cardiomyopathy. Peripartum cardiomyopathy or postpartum cardiomyopathy, due to hormonal imbalances, they present with the heart failure signs, and you have to, most of the times these are reversible one. After delivery, they will reverse, and this subset of patients, you have to give the GDMT like ARNI, beta blockers, MRA, and mineralocorticoid antagonists, and DAPA if possible. If they are tolerating, you can give it. Another subset of patient, oncology patients who are on the cardiotoxic medications, doxorubicin or other medications, and monitor the echo. Every time you have to see the echo and whether EF is coming down or not, and then you categorize, and to prevent this you have to give the either ACE inhibitors, ARBs or ARNI beta blockers for this subset of patients. For the patients who are receiving the chemotherapy, always monitor the by echocardiography and biomarkers and clinically. If they are going to develop the heart failure, then you start the medications. Another subset is heart failure with pregnancy. So other subset is peripartum cardiomyopathy. In peripartum cardiomyopathy, counseling is very important for the second pregnancy, and you have to counsel them and say the pros and cons of the pregnancy in future, and defer the further conceptions in this patient, and advise the adequate treatment. So in brief, heart failure is very important. Clinically, you have to diagnose the heart failure by signs and symptoms. Take the help of the echocardiography. All patients with the signs of heart failure go for the echocardiography, and classify whether patient falls into the heart failure with reduced EF or preserved EF or reduced EF. And according to that, you can start the medications. These four treatment, these are the four basic pillars of the heart failure. Like I told you, the ARNI, beta blockers, MRA, and the SLD2 inhibitors. Another subset is as obesity population are increasing in India, and you have to go for the newer medications like semaglutide and tirzepatide. So there is possibility of reducing the heart failure in this patient, and you have to keep in mind, as you are all physicians, you should know how to treat that, especially diabetic population, obesity population, hypertension. Early diagnosis, treatment of this patient can prevent the heart failure, and by that you can prolong the life, give the quality life, and it is the message of this topic. Thank you.
Thank you, Dr. Kondal Rao.
That was an elaborative presentation on heart failure by Dr. Kondal Rao, sir. Now I would like to call upon our next speaker, Dr. NVB Kesai, who will be delivering a speech on time is muscle, reperfusion strategies in myocardial infarctions, and followed by a short talk about his journey in cath lab. I would request the chairpersons to kindly introduce the speaker.
It's my pleasure to introduce Dr. Sai. I think he's known to most of you, and he's the chief staff surgeon in Central Hospital, Lalaguda, and he has started a cath lab recently in Lalaguda, and they're doing excellent work there. He's from the 1994 IRHS batch, and he's now going to share his journey in the cath lab, as well as I think how he started it. Dr. Sai.
Thank you, madam. Respected DGRHS sir, respected PCMD madam, Dr. Nirmala madam, and Dr. Anjana madam, and my teacher, Dr. Sudarshana, all the PCMDs, dignitaries, all the delegates, ladies and gentlemen. Good morning. In the first 20 minutes of my presentation, I'll go through the topic of reperfusion strategies in acute myocardial infarction. Time is muscle, and time saved is life saved. And later on, in the next 8 minutes, I'll be briefly telling about my journey in installation of cardiac cath lab in Central Hospital, Lalaguda. The outline of the lecture is the burden and pathophysiology of acute MI. I'll be speaking a few words. Why reperfusion? And here it is time is muscle. The earlier you do the reperfusion, the earlier the patient receives the reperfusion in acute MI. And that is where we achieve major gains, lives are saved, and the muscle is not lost. And delay in reperfusion causes, even though the life is saved, we end up with left ventricular dysfunction. The primary PCI is the gold standard in ST elevation myocardial infarction. Then I'll be speaking about the fibrinolysis and the pharmaco-invasive strategy, adjunctive antithrombotic therapies, multivessel disease and complete revascularization in acute MI situations, cardiogenic shock complications, and the Indian context. So ladies and gentlemen, the global and Indian burden is 3 million, approximately 3 million STEMI events occur globally per year. And Indians are very peculiar that we have an earlier onset of STEMI, and 1 in 5 patients, Indian patients, the first MI, they are less than 40 years old. 30 to 40% of all cardiovascular deaths are attributable to acute myocardial infarction, and sadly in Indian situation, only less than 10% of eligible STEMI patients, that is ST elevation myocardial infarction patients, receive timely primary PCI in India. That is because of the logistical constraints, and not all the hospitals have cath lab. So coming to the pathophysiology, from plaque to necrosis, we have the plaque rupture, the thrombus formation, then we have the coronary occlusion, then the ischemic cascade sets in, and finally the myocardial necrosis. The key concept is the Raymer-Jennings wavefront phenomenon, wherein the necrosis spreads from the subendocardium over this 0 to 6 hours after coronary occlusion to the epicardium. So the faster the reperfusion is achieved, the more myocardium is salvaged, and beyond 12 hours, salvage is minimal. That's the reason even after 12 hours, if we are successful in doing a primary PCI and establishing the reperfusion, still the patient ends up with a left ventricular dysfunction. So time is muscle. This is the reperfusion imperative. As the time is wasted, as the window period is longer, the mortality rises. So the window period 0 to 1 hours, that is a golden hour of reperfusion. The mortality is as less as 3 to 4%, whereas if the window period is more than 12 hours, it's as high as 14% in acute ST elevation myocardial infarction. So coming to the guideline targets, less than 10 minutes should be the first medical contact to ECG. Less than 90 minutes should be the first medical contact to device or door to balloon time. Less than 120 minutes should be the first medical contact to device in transferred patients. So 90 minutes is the goal to be achieved in cases where primary PCI facilities are available, and 120 minutes in case of transferred patients to a PCI center. Less than 30 minutes door to needle time, we all know, for thrombofibrinolysis, and within 2 to 24 hours is the routine angiography after lysis. These are the recommended guidelines as on today. So coming to the reperfusion options decision tree, STEMI confirmed, symptom onset below 12 hours. We should ask ourselves first, can primary PCI be performed within 120 minutes of first medical contact? If the answer is yes, in all the cath lab centers, primary PCI is the first choice. And this is because it results in a higher TIMI3 patency, lower reinfarction and stroke, allows complete anatomical assessment, drug-eluting stents and thrombus suction if high thrombus burden, radial access preferred over femoral in cases of primary PCI, and it's the first option treatment if facilities are available. PAMI and PAMI stent trial, that is the primary angioplasty in myocardial infarction, primary angioplasty long back 1996 trials, these are landmark trials compared to fibrinolysis, showed that primary angioplasty results in more number of lives saved and lesser coronary occlusions. The primary PCI is the gold standard, as already told, and the access radial artery is preferred over femoral artery because femoral artery can lead to complications like femoral hematomas. And the stents, newer generation drug-eluting stents are class 1 indication. Thrombectomy, that is the thrombus suction, is used in high thrombus burdens, and anticoagulants commonly used are unfractionated heparin and bivalirudin rarely. In our center, we do not use bivalirudin. So adjuncts are DAPT loading, which Dr. Sishir will be telling, and also 2B3A rescue in rescue cases only if there is high thrombus burden. So coming to the fibrinolytic therapy, not all centers have PCIs facilities. So STEMI within 12 hours of symptom onset, and where there is an anticipated first medical contact to device delay of greater than 2 hours and no contraindications to thrombolysis, the greatest benefit occurs when it is given within 2 hours. And ideally pre-hospital settings also, pre-hospital fibrinolysis is also one of the upcoming strategies. Absolute contraindications, all of us know, prior intracranial hemorrhage, ischemic stroke within 3 months, known cerebrovascular lesion, active bleeding or bleeding diathesis, and suspected aortic dissection. So streptokinase was long back used. We know the dosage and all. Tenecteplase, now more and more patients are receiving tenecteplase, and I think all the railway hospitals in India are receiving, patients are receiving tenecteplase. It's a single weighted based IV bolus, and the fibrin specificity is very high with tenecteplase, and the patency in 90 minutes is about 70 to 80%, and then it is preferred but safety and for its safety and ease of hospital use. So coming to the tenecteplase and the STREAM trials, the STREAM 2 trial, the key findings were that the tenecteplase used in half the dose in elderly beyond 75 years of age reduced the mortality, reduced the incidence of intracranial hemorrhage. But still, intracranial hemorrhages do occur in this subgroup of patients also, and to reduce the intracranial hemorrhage, primary PCI is the best alternative. Now coming to the pharmaco-invasive strategy, 0 minutes, first medical contact plus STEMI, diagnosis on ECG. Within 30 minutes, we give tenecteplase, dual antiplatelet agents, clopidogrel or ticagrelor loading doses, and anticoagulation with heparin. 60 to 90 minutes, what we do is assess reperfusion by ST segment resolution and pain relief. And if it's a failed thrombolysis, immediate transfer for rescue PCI, and if it is successful, routine angiography 2 to 24 hours post-lysis. Why it matters in India? Because of our geographical and infrastructural barriers. STEMI India and Tamil Nadu STEMI hub and spoke model have done extensive trials and published results wherein the pharmaco-invasive approach has reduced mortality versus thrombolysis alone. Please do not get confused with facilitated angioplasty. Facilitated angioplasty is where you give half dose of thrombolysis in a primary PCI center and take up for PCI. This practice is no longer practiced because the trials have shown that the facilitated PCI results in increased mortality since you are doing primary PCI within 3 hours, and it is in the first 3 hours after giving thrombolysis that platelet reactivation takes place. So forget about facilitated PCI. Now we have only 2 options. Primary PCI is the first option if facilities are available. If facilities are not available, thrombolyze, pharmaco-invasive approach, and send them to a PCI center wherein angio and PCI will be performed within 3 to 24 hours. So rescue PCI, what is this? So in patients, we assess after thrombolysis, after 60 to 90 minutes after fibrinolytic bolus, whether ST segments have resolved more than 50% in the worst lead. If it is not, it is a failed thrombolysis. Persisting chest pain, it's a failed thrombolysis. Hemodynamic instability, it's a failed thrombolysis. Electrical instability, arrhythmias, it's a failed thrombolysis. So then rescue PCI is the only option. We take up the patient immediately for rescue, for angiogram, and do the culprit vessel PCI. And this rescue PCI has shown a lot of mortality improvement in these failed thrombolysis patients, lesser and lesser deaths. And then, in olden days, when I was doing my MD, they used to do repeat fibrinolysis. Now, it is no benefit, it is proved to be of no benefit, and if you do repeat fibrinolysis, it only results in more bleeding and more intracranial hemorrhages, hence this is abandoned. Now coming to adjunctive antithrombotic therapy, aspirin, we know the doses, ticagrelor, prasugrel, clopidogrel, all these alternatives are available. All of us are physicians here, and they're using these drugs day in and day out, so I'm not elaborating all the drug dosages and all. Coming to the anticoagulation, unfractured heparin, enoxaparin, bivalirudin, fondaparinux, and 2B3 inhibitors, epcizumab, tirofiban can be used. So multi-vessel disease and complete revascularization. So here we have, so many often what about in India, especially 50% of patients who undergo primary angioplasty, apart from the culprit vessel, there are other vessels involved. So what is the timing, whether we have to do revascularization for them, or what is the timing in which we have to do revascularization? These are all the issues addressed in the complete trial. The complete trial said that multi-vessel revascularization reduces the cardiovascular death, reduces the ischemia-driven revascularization, reduces the recurrent myocardial infarction. So the concept now is, if in stable patients with ST elevation myocardial infarction, if the patient is stable in the index procedure itself, you open up the culprit vessel and do the other vessels also. But in our center and many other centers, we do the index vessel, that is the culprit vessel PCI in the index procedure, and after 3 to 4 days after stabilization, the staged PCI for the remaining vessels. This is what is done. You can also discharge the patient, ask them to come back, and 19 to 45 days is the time limit prescribed to do this staged PCI. Now in cardiogenic shock, the reason for all these conferences regularly is every year and year the guidelines keep changing. When I was a student, they used to say that in cardiogenic shock, that is the only indication where you do a multi-vessel PCI as an index procedure. But now the guidelines have changed. Culprit vessel only PCI should be performed in cardiogenic shock. So avoid non-culprit PCI in cardiogenic shock. This is what the culprit shock trial has told us. It's not moving. Not moving. Slides. Okay, yeah. So coming to the reperfusion in cardiogenic shock, scary. The timer is scary really. So reperfusion in cardiogenic shock, 40 to 50% mortality. In hospital mortality of STEMI with cardiogenic shock, the shock trial has said that early revascularization remains the single most impactful intervention, the shock trial. So the revascularization culprit shock trial has clearly stated that in cardiogenic shock, the culprit only PCI is superior to immediate multivessel PCI. And CABG if PCI is not feasible and mechanical complications occur. If mechanical complications like a mitral regurgitation or a ventricular septal rupture is there, then CABG is a better option. Because then we have the mechanical support. IABP shock trial has said that adding up IABP in cardiac shock and doing the procedure, there is no mortality benefit. Whereas the danger shock trial of 2024, that is the microaxial pump, that is the impeller device, has shown the mortality benefit. Then VA ECMO trial showed that in refractory shock, bridge to recovery, ECMO can be used in refractory shock cases and as a bridge to recovery and decision. And then in the medical adjuncts, norepinephrine is the first-line vasopressor, and we add dobutamine or milrinone. We avoid beta blockers in cardiogenic shock and ACE inhibitor until stabilized. So complications, coming to the complications of reperfusion. Reperfusion arrhythmia is actually good. We feel that the reperfusion has occurred. It is usually an AVR. But rarely the AVR degenerates into a ventricular fibrillation. We all know in that cases we have to DC shock and revive the patient. No reflow phenomenon. This occurs after doing a PCI, after deploying a stent. We get a very good result, but unfortunately the TIMI-3 flow or the normal flow is not there. You have a TIMI-1 or a TIMI-2 flow. And then the distal embolization is also one of the cause for no reflow phenomenon, and all these lead into microvascular obstruction. You have a normal epicardial coronaries, but a microvascular obstruction, that is itself a big subject to be dealt in a half-an-hour session, not now. So now coming to stent thrombosis, acute less than 24 hours, stent thrombosis is a common complication, and then subacute thrombosis is between 1 to 30 days, and mitigate with optimal DAPT and IVUS-guided deployment. IVUS-guided, image-guided angioplasty reduces the incidence of stent thrombosis, because after putting the stent, we do the IVUS and see that the stent is well expanded, well embedded to the vessel. Then the contrast bleeding and ICH and intracranial hemorrhages occur with fibrinolytics, and this risk is reduced with a primary PCI. Contrast-induced AKI occurs after primary angioplasty. Adequate hydration, minimize the contrast volume, avoid nephrotoxins, and it has a higher risk in diabetes, elderly, and CKD. Special populations, elderly greater than 75 years with myocardial infarction, they have a high risk of intracranial hemorrhage. That is the reason the STREAM trial has said that if you give thrombolysis in these patients, give half the dose. Then complete revascularization is still beneficial as per the FIRE trial, and frailty assessment is very crucial. Then coming to women, often atypical presentations, greater treatment delays, higher bleeding risk on lytics, and equivalent benefit women receive as men from primary PCI. Diabetes, more diffuse vessel involvement is there, more of multi-vessel disease, higher 30-day mortality, strong benefit from complete revascularization. Drug-eluting stents are preferred over BMS. Nowadays, we are not having BMS. Most of the stents are drug-eluting stents. So chronic kidney disease, often undertreated. They minimize the contrast volume. Pre-procedure hydration is very important, and avoid nephrotoxic antibiotics, so on and so forth. So Indian reality, 68% of the STEMI patients present to non-PCI hospitals. So this is where more and more PCI hospital centers should come up. 6 hours is the medium symptom onset to reperfusion registry, create registry. This is where we have to improve, and 50% of patients still receive only fibrinolysis, and then only up to approximately 10% rate of timely primary PCI nationally. And the Indian registries like CREATE, Kerala ACS, Tamil Nadu STEMI program published in circulation. The Tamil Nadu STEMI program is an excellent program. It's a hub and spoke pharmacoinvasive model that produced a 3.4% absolute mortality reduction at 1 year. It's a landmark for Indian systems of care. Hub and spoke model means hub is the PCI center with cath lab, spokes are all the peripheral centers, health units, dispensaries, etc., or lower district hospitals, wherein they give fibrinolysis, they establish contact with the hub center and transfer the patients for pharmacoinvasive type of PCI. So coming to the National Interventional Council data, coronary interventions have increased from 2 lakhs in 2014 to 4 lakhs in 2018. Even our FDRs do not give so much interest probably. And 12.17% of coronary interventions performed in patients less than 40 years old. Data of PCIs, primary PCI 18.4, post-MI cases 28.9%, chronic stable angina 18%. So STEMI cases in India in 2018 were 30 lakhs and thrombolyzed were 12 lakhs. That means nearly 40 to 50% patients still undergo thrombolysis in India. And primary PCI is about 13.12%, whereas in USA it's about 60 to 70%. So coming to these guidelines, 2025 ACCHA guidelines, reperfusion timing class 1, I already told, FMC to device less than 90 minutes. Fibrinolysis, consider it if the delay is more than 120 minutes. Complete revascularization is a class 1 indication. DAPT duration for 12 months or more is a class 1 indication. Antiplatelets, ticagrelor or prasugrel are preferred over clopidogrel for primary PCI. This is a class 1 indication. Cardiac shock, Impella is useful in danger shock trial, that is class 2A indication. And lipid management nowadays after an MI, the ideal LDL is less than 70. To achieve this high intensity statin, as atorvastatin as high 80 milligrams, ezetimibe plus even evolocumab, inclisiran and all are being used to achieve a target LDL of less than 70. So coming to the reperfusion, take-home messages are time is muscle here, primary PCI is the gold standard, pharmacoinvasive strategy is the safety net in Indian considerations, complete the job, that is complete all the vessels within 45 days, and then reperfuse early and follow up forever. So I'm ahead of time, but I'll be utilizing it in my next presentation. This is a brief presentation on how we started the journey of cardiac cath lab in Central Hospital, Lalaguda, how we put the cardiac cath lab in Central Hospital, Lalaguda in the National Interventional Council by submitting our data. So it started quite some time back, planning the building. The journey from proposal to financial concurrence to tender was very hectic because our finance brothers and all, many of them did not understand, many of them did not for them. I explained them and somehow got their concurrences. And then procurement of hardware is another issue. I'm not going to talk now about constraints. In spite of all the constraints, hum ho gaye kaamyab is my theme. So then the constraints of freeze in manpower is there. That actually I feel that should be addressed at the highest level. And whenever a new asset starts, we should give some manpower. And generation of faith amongst the patient is one of the most important thing. And generation of faith, fortunately we have it in my hospital. We have worked here for a long time, and I'm very happy to say that my patients listen to me and they come to me. So coming to the cath lab. So I have been associated with right from the planning of the building, each room dimensions and all. And when the building was planned, there was one AEN by name Mr. Ravi Kishore, a very nice man. He told me, Dr. Saab, you will not understand if I tell this feet by this feet, 20 feet into 13 feet. You come to me with, you take me to cath labs in the other hospitals, we will see them. So we went to Apollo hospitals, we went to Yashoda, at least 10 hospitals in Hyderabad. We both went. He took a measuring tape, he measured, and today my cath lab is one of the best cath labs as per the planning in Hyderabad. And my consultant cardiologist, my friend, does agree that doing procedure years in my hospital lab. Lot of peace of mind is there. Lot of space is there. If a patient crashes also, there's lot of space to do adequate CPR. So this is what we installed the cath lab. That was, I think, Suji, when was it? 26th of June 2025, and all the armalas and all exactly where I wanted what to be placed, I got it like that done. And then this is the dedicated team. I would like to tell here that when Calcutta Cath Lab was started, some 60 manpower posts were created. Perambur, of course, came long back. Where Bombay was started, many manpower posts were created. But this is the Cath Lab wherein I have trained all the manpower with the existing manpower from ICCU. I sent the staff, very dedicated staff, to ESI Corporation Hospital in Sanat Nagar, and where Dr. Sadanand Reddy is the chief cardiologist, my friend. He trained them for 4 to 5 months and gave them back to us. They are doing a wonderful job today. They have picked up very well, and with the existing manpower, we have started this unit. Dr. Kondal Rao, my friend since 1994. When I was doing MD in Usmania Medical College, he was my senior. He was a DM cardiology student. We know each other very well. We are the best friends since those days, and he's also my teacher in interventional cardiology. Then we have a few cases I'll present now. 50 years old employee with inferior wall ST elevation myocardial infarction. This is the first angio, wherein the right coronary artery is showing a total cutoff on the right side picture. We hook the guide, we pass the wire, and 13 steps of angio. This is the final result. We got a very good result. Stent is very well deployed. We went home around 7 p.m. or 8 p.m. We went home only to get a call at 10 p.m. that the patient is again having chest pain with ST elevations in the inferior wall. Both of us, Dr. Kondal Rao and myself, rushed back to the hospital. We saw the patient. Definitely we have to open it up again. And this is the right side picture, shows that the stent is totally occluded, and the stent here it is. Again, we have done the procedure and ballooned it and got a very good result. Then what happened here was, we did not get the reports when we did, blood reports when we did the primary angioplasty, first angioplasty. By the time we went after stent thrombosis, that is at midnight, we got the blood reports. Hemoglobin was 20%. Now physicians, you should tell, polycythemia vera rubra is the diagnosis, and it's a high-risk case because polycythemia vera rubra will have high thrombotic tendency. That is the reason my we gave him good amount of IV fluids. Then we, during the second procedure that midnight, we aspirated we back-bleeded lot of blood as a phlebotomy, then started him of hydroxyurea. After 1 week, we did the staged procedure of LAD PTCA, and he's today fine, working back as an RPF employee. Now coming to this case, a 55-year-old antral STMI with primary angioplasty, LMCA to LAD crossover stenting we have done. You see that you see that here the LAD is totally cut off, and here it is totally opened. So this is what we got, an excellent result. Then we have the rescue angioplasty here, inferior wall myocardial infarction, major OM was totally occluded. We gave midnight, it was 3 a.m. the patient came on a Sunday morning. We thrombolized, but then the thrombolysis failed. Morning we came to the cath lab, we opened up and did the primary rescue PCI, and this is the open vessel. Now coming to left main stenting for ostial left main tight stenosis, 65-year-old IVUS guided angioplasty we have done. This is showing the very tight ostial left main lesion. It was so tight that as soon as we were engaging the EBU guide, the patient was developing ST elevations, the patient was developing angina. We had to disengage the guide, gently pass the guide wire, balloon the ostium LMCA, first stent the proximal LAD area, and then stent the ostial left main. Later on did adequate post-dilatation with ostial flaring, and then we had an IVUS guided angioplasty. We achieved an excellent left main area, which is 21.2, and with this area of left main post-stenting, an interventional cardiologist can go home happily, have little red wine and sleep off. Then this is the ASD closure. The 4 to 5 left main, we have done about 5 procedures in the past 10 months. Then this is the ASD closure. 4 to 5 devices we have put in the past 10 months. 55-year-old with an interval MI. This is the primary PCI we have done. Midnight case it was on 26th of January. I still remember the date. Here you can see that this is actually the lesion is there, but this is left circumflex. RCA also lesion is there. Triple vessel disease it is. But this patient, this is the where my arrow is showing here. That is the LAD. That is the occluded LAD. This is the occluded LAD. So the LAD is the culprit artery here, and we did our best. The extreme right shows a very good flow in spite of the calcific vessel and all after stent implantation. But then, alas, the wire that went wrong. See, distally to the LAD, there's a small perforation. The wire that went wrong, that small perforation has come. Interventional cardiology is not a child's play. Complications do occur, and when complications do occur, do not panic, hold your nerves and lead the team, stay with the patient and do your best. Good counseling is essential. And my consultant, Dr. Kondal Rao, and myself stayed back that night with the patient. We did a pericardicensis, and that too immediately after the procedure, pericardial effusion was not there. 2 hours later, the pericardial effusion came. And then patient, we did the pericardicensis, hemodynamics improved, patient survived, we gave protamine and all these things, and after 1 week we did an angiogram again. It showed what stent we had put there had got totally occluded. So it is a rightful triple vessel disease case. We sent for CABG, patient underwent nice CABG, he came back, he's happily working back in his workplace now. So coming to the CTO, we have done CTOs also. LAD CTO we have opened up. Just one, I'm finishing it. And anomalous origin of right coronary artery from LCS. This is one which gave us a lot of trouble. Abnormally, we had to engage the JL left catheter for the right and did it. I'm finishing. Calcium is an enemy of an interventional cardiologist, and we have done the first coronary IVL case in CH Lalaguda. Matrix IVL is now an Indian-made, Releases India. They are giving these Matrix IVL balloons. We could win over the calcium and win over our enemy in interventional cardiology. So cath lab procedures, I'm finishing, sir, just last slide. Coronary angiograms 528 in the past 10.5 months. Coronary angioplasty is 222, with primary angioplasty is 42, permanent pacemakers 11. We could have done more because of the procurement hurdles. We got these pacemakers late. ASCD 3, IVL 1, IVAS 15, IVAS guided angioplasties, ASD device closures 4, pericard census 2, permcath insertions, our nephrologist has done 26, renal angios 1. So total 831 procedures till yesterday. Cardiac 804 and nephro 24. The future is the EP unit, and CT surgery is coming up in a couple of months in my hospital. Tenders have gone for the heart-lung machine and all. And I propose a spoke and hub model for South Central Railway with Kazipet and Nanded as the spokes and Lalaguda as the hub model. And I suggest that the Association of Physicians of Railways start an acute MI registry. We should publish all over India what is happening to our acute MI patients. Then this is the Department of Medicine. Nice physicians we got. Aditya is a nephrologist. Dr. Cheligari is a CHD. Then the 3 lady physicians, wonderful physicians they are. And because of their support, I could do so many cases. And then thank you. Greetings from my wife also. Thank you so much.
Aarti, congratulations. This is not a joke to start a cath lab and sustaining it. You really, we have to, hats off to you. I worked in Perambur, where it is established cath lab. Still we find difficulties with so much of staff, so much of established base, theatre support, surgeon support. But really great of you. And I expect our DC and everyone to give you support, increase the manpower, doctors as well as nursing staff. And those who worked in railways only realize what we have. I worked in the private setup. The cath lab is so small. The recovery rooms are so small. The facilities are less. But they do so much. Why not we do? We can do with a little more support. Really hats off to you.
Thank you so much, madam. Your blessings always with us. Thank you so much.
Dr. Sai is really a wonderful presentation. I can add few words to your presentation, and just now our esteemed panelists, chairpersons stated about your achievements and various constants in railways, I simply say a few words that where there is a will, there is a way. Anywhere you can start anything, and particularly you have to take primary initiative to conceptualize and to set up in divisional setups as well. So we are here to support you in every initiative of yours, whether is it in cardiology or in other specialties. You must realize that you are the cream of the doctors in the central services, so you can do wonders, provided you just try to initiate it. So the sky is open to you, and I would definitely urge to our young colleagues to take up such initiatives and learn from our seniors that they have started with an idea, and you must have seen the pictures. He had not shown the ground from where these walls were erected, roof was laid, and room was constructed. He started with the machine getting installed in a room. So you can very well start as a greenfield project, and authorities are really willing to support you, provided you are sincere to your effort and you are looking in the interest of railway beneficiaries. And these diseases are common to all, whether it is an employee or officer. So this facility can be help to anyone. So nobody is trying to obstruct, or simply there are procedures, but in railways there are ways to tackle those so-called your obstacles. So there is no obstruction at all. So please just go ahead and plan for new things. Thank you very much.
Thank you, DG sir, for your kind words. I am sure all your suggestions will be taken in positive spirit by our upcoming doctors. After an excellent presentation by Dr. Sai sir about his about reperfusion strategies and his one inspiring journey in cath lab, I would like to request our next speaker, Dr. Shishil Rao sir, who will be giving a talk on dual antiplatelet post PCI. How long to continue? It's a question which always plagues the physicians, and guidelines keep changing. So I would like to welcome. I would like the chairperson to kindly introduce the speaker.
So our next speaker is Dr. Shishir Kumar Rao. He is MBBS, DNB Medicine, and Doctorate NB Cardiology, and he's a fellow of the European Society of Cardiology, and he is the head of the Department of Cardiology and the director of the cath lab at Jagjeevan Ram Hospital, Western Railway. We can see that he has a lot of achievements. Welcome, Dr. Shishir.
Thank you, ma'am.
Over to you.
Respected DG sir, respected chairs, respected all PCMD delegates, and my friends and my senior. At outset, I'm thankful to the organizer. This is really a interesting topic to go ahead with antiplatelet. Rather, I will go through like this. I'll take through the different objective. I'll go to how the normal thrombus or clot forms, the normal physiology, how the guideline stands here, so far as anticoagulant, antiplatelet in ACS patient concerned. How will they select my antiplatelet, and what duration in regards to the high risk, heavy risk patient and bleeding risk patient. And finally, I will have something about the anticoagulant so far as ACS is concerned. As Dr. Sai told, this is really alarming. The cardiovascular risk factor 1 in NV pro patient is due to cardiovascular disease, and most of them are due to ACS, that is acute coronary syndrome. And the worst thing what is happening to us is less than 40 or 45%, 1/4 of patients dying due to ACS. So how alarming we are now. So what is this acute coronary syndrome? This really touches the different versatile in the form of, it includes unstable angina, ST elevation MI, non-ST MI, and recently they have published, they have found that it's not an acute event. You have to have some chronic atherosclerotic disease in the form of plaque, which needs to rupture or needs to erode, or in some calcified nodule. Finally, it will present as acute coronary syndrome. So it is no more an acute event, rather acute over chronic, acute on chronic. Yes, when it ruptures or erodes, it can manifestation as white thrombus or red thrombus. When I am telling white, it is platelet plus fibrin. When I am taking up the red, it is RBC plus fibrin. But does every plaque rupture? Does everyone of sitting here do not have plaque in your coronary? Yes, we do have. Then which plaque rupture? And when you might be listening, when somebody is doing marathon, somebody doing the gym, got acute coronary, how does it happen? So here comes what is vulnerable plaque and what is non-vulnerable or stable plaque. So the vulnerability of the plaque depends upon many characteristics. You can see in the right of my, so when there is a thin fibrous cap, thin cap covering, high lipid core, high inflammation in the form of macrophage, neutrophil, calcium, is likely to rupture, and this thin in the sense there is a measurement less than 65 millimicron. That proves from the OCT and IVUS. We have imaging with us, we have advanced like anything, we have imaging to prove, even if a patient comes with a elevation MI, we do angio, sometimes we think it is not that amount of blockage which can give, the moment you do IVUS or OCT, you can definitely diagnose this is a vulnerable plaque. So we need to treat that. Then here comes why a patient does not get clot or thrombus in a normal vessels. So what is the role of normal endothelium? So when a patient is having normal endothelium, the smoothness, the glycocalyx, that is glycoprotein layer over the endothelium, repels the platelet, prevent the thrombus formation. And it does secrete the nitric oxide and the prostacyclin, which further dilates, and so platelet does not aggregate. And there is a thrombal modulating protein which produced by the endothelium. It binds with the thrombin, decreases the thrombin level. Thrombin is the last parameter, last agent which activates fibrinogen to fibrin. So if I am decreasing the thrombin, indirectly I am decreasing or inhibiting the clotting factor, coagulation pathway. And thrombin and thrombomodulin complex activate the protein C, which inactivate the factor 5th and 8th. So normal endothelium does many things to get your normal flow of vessel. If your endothelium is okay, you are okay. At the same time, antithrombin produced by the liver also decrease the thrombin level, and some of the fibrin which is forming in your body also decrease the thrombin level. And how does the heparin does? Heparin secreted from the basophil cell or mast cell also inactivate 9, 10, 11, 12. That is anticoagulant, that factor X. So finally, normal, everything on normal, the normal vessel does not get clot. Then what is the role of platelet? So, believe me, platelet does not have a nucleus, but it has everything. It can act as the whole cell. You have endoplasmic reticulum. It has mitochondria. It has a glycocalyx layer. It can secrete ADP, which is critical for everything, and various enzymes also. Last line you can see there is a glycoprotein layer, glycocalyx layer, which repels the normal endothelium. However, when the endothelium gets damaged, when something wrong occurs to the endothelium, it attaches to that vessels and gets activated. Here comes the endothelium and platelet. They are just like husband-wife. If everything wrong happens for endothelium, the platelet gets activated. So when the platelet gets activated, it behaves like anything. It's the shape changes. It becomes multiple pseudopodia. So it behaves abnormally. I'll go to that. So this is normal platelet. You have everything. You can see there is a glycocalyx layer over it. It repels the normal endothelium, but attached to the injured endothelium, you have granules, dense granules, which secretes ADP. We have alpha granules, secretes many clotting factor, and you have mitochondria and endoplasmic reticulum. At the same time, we have phospholipid also. So whenever platelet gets activated, it looks like this. You can see the normal blood vessel, the discoid platelet becomes abnormal, meaning by it swell up. Multiple pseudopodia, all the receptor what was inside gets activated, gets exposed, and the phospholipid layer, which is just below the glycocalyx, comes up. So we can lead to the arachidonic pathway, lead to the cyclooxygenase pathway, leading to thromboxane. So thromboxane further activates the platelet and further release the ADP, and finally this procedure goes on. The moment it gets activated, so there is a multiple receptor, P2Y2 receptor, ADP gets activated this and gets attached to this, then subsequently platelet further aggravate, and you can see GP23A, that is also get activated. It can attach other platelet. Finally, there is fibrin formation in the normal coagulation pathway. Now platelets comes in, so finally you get a platelet plug. Yeah, finally we got a thrombus. Yes, whenever there is endothelium injury, your collagen exposed, this is VM, the von Windberg factor will get secreted from the endothelium and platelet both. So it got attached to your platelet, then this platelet get activated, leading to all the exposure of this receptor what was inside this, and finally it leads to the further platelet aggregation with help of fibrin. So finally we got the platelet aggregation. So step 1, normal platelet attached, other end get discoid separate, activated the GP23B, ADP receptor, release of the thromboxane, that is cyclooxygenase, and finally get activated. So when there is multiple receptor, we should have multiple agents happens to hit our platelet. By whenever is secreted and attached to the P2, we have multiple anti-P2Y12 ADP receptor blocker in the form. We have clopidogrel, prasugrel, ticagrelor, cangrelor, so on so. And when thromboxane A2 phospholipid, so we have aspirin or old agent, so it further deactivated the platelet. And if we have a GP23B, that is one platelet gets attached to the platelet with help of fibrinogen, we have tirofiban, we have iptafibatide in the form of GP23 inhibitor, and finally we have phosphodiesterase inhibitor, and we have thrombin receptor, the PAR receptor, in the form of varapactor. So multiple agents to hit the platelet, to inactivate the platelet. So the aspirin, old and still it continues. Old is always gold. So aspirin still continues. Along with that, when we felt something wrong in our approach of platelet therapy, aspirin is not matching our everything that we want, then we go on researching, and finally the recent we got the cangrelor, that is IV immediately to block the Dr. acute thrombosis. When you have not enough time, you have to get your antiplatelet agent so you can get acute thrombosis, because the moment you put a stent in, the smoothness of the surface is gone. Your glycocalyx layer of the endothelium gone. So you have done some injury to your platelet cell. Now you are activating a thrombus. they found we should have something that is known as DAPT, because aspirin is not meeting anything, because they found their stent thrombosis, they found heart failure, arrhythmia, and so on. So DAPT tells they proved 1 year of dual antiplatelet is best. However, prolonging this 1 year to the 30 months, they are found there are multiple bleeding, there no clinical improvement of the MI stent thrombosis. So then what second agent should be along with aspirin? And they go on studying teicoplanin, clopidogrel, prasugrel, ticagrelor, so and so. Still it's going on. So they found something and they told you have aspirin, that is COX-1 inhibitor, the main pathway, clopidogrel, prasugrel, ticagrelor, and canagliflozin, they all inhibit the P2Y2, but they do have some advantages and some disadvantages also, because you can see the clopidogrel takes a lot of time and biovariability in the form of it has to go to 2 pathway to get activated. It's a pro-drug. Prasugrel is also a pro-drug. It takes some time to act, and at the same time we have 50% of the clopidogrel resistance. I'm meaning by their friends, clopidogrel. No. If you are writing clopidogrel, then you are killing the patient. You are now a killer of patient. So don't forget clopidogrel. I will tell when you should write clopidogrel. So going ahead, the clopidogrel, yes, inexpensive, old drug, but always I told many disadvantages. You are going to kill the patient. You are writing clopidogrel. Yes, prasugrel, rapidly acting, again is a pro-drug, but great efficiency STEMI. However, it does have own bleeding risks in the form of, if patient is less than 60 kg, 60, 80, yeah, 75 you can write. Patient is less than 60 kg and age is more than 75 and patient had history of TIA or stroke, no clopidogrel. 3 contraindication. Prasugrel. Prasugrel is the best drug. 60, less than 60, high chance of bleeding. More than 75, high bleeding. And if you are having TIA or infarct or stroke, do not write. Ticagrelor, okay, one of the finest drugs so far as cardiology concerned, yeah, PTC is concerned. However, it does have its own limitation in the form of, it causes higher degree of AV block. I mean to say, you can get, the moment, yesterday we got a patient, we just did angioplasty, and after giving the ticagrelor, we can develop to 2:1, 3:1 high degree AV block. We stopped the antiplatelet ticagrelor, loaded with prasugrel. I'll tell how to load. So, and dyspnea sometimes can lead to dyspnea. So, 2 contraindication, one is high degree AV block, dyspnea, platelet 3 contraindication. So whether we will go with prasugrel or Brilinta, prasugrel or ticagrelor. So they found that do study. I have many trials, but I am going to landmark trial only. That is Triton TIMI-3. What they did, 30,000 patients, all are high coronary syndrome, high risk. They found the clopidogrel reduces ischemic event with higher rate of bleeding. The clopidogrel, prasugrel that did the head-to-head trial found there is a stent thrombosis, there is a improvement in so far as cardiovascular expert is concerned. However, there is chance of bleeding. So, any patient, and second, they also found that if somebody is medically managed patient, for example, patient having a ST elevation or an anesthesia, however, you thought there is no significant blockage, let me put on medical management only. Never. So, prasugrel does not have any role if you are not going to any PTCA. Prasugrel. No PTCA, no prasugrel. Prasugrel does not provide benefit over medical treated patient in STEMI patient. So, medically management, no prasugrel. Invasive patient, PCI, no risk of bleeding, along with 60 mg loading, 10 mg. And if you are more than 75, less than 60 kilo, and TIA stroke, don't give prasugrel. So now, whether I should go with ticagrelor, that is ticagrelor, again they study with clopidogrel, because clopidogrel was widely used. They found ticagrelor reduces the ischemic event with no higher rate of bleeding. What the prasugrel was doing, bleeding, the ticagrelor is not doing. So great clopidogrel. You can see again they have high MI and having high risk diabetic patient again got a second MI over 2 years, multivessel CAD, chronic CKD. So what is, if patient is high, the chance of thrombosis is gone. Can we continue this ticagrelor further more than 1 year? Yes, they found you can continue, but the dose of continuation more than 1 year should be 60 mg PD, 60 mg twice. Prasugrel 10 mg once. Single dose, but Bilinta, ticagrelor has to give him twice dose. But after 1 year, if you continue, don't continue with 90 mg, continue with 60 mg BD. Again, you remember when you are giving prasugrel, you can give 150 mg of clopidogrel, aspirin, but when you are giving ticagrelor, you just give 75 because aspirin decreases the efficiency of ticagrelor. Repeat, take this sentence with you. Aspirin decreases the efficiency of ticagrelor. You are giving 150 aspirin along with, again you are decreasing the Brilinta efficacy. And they found, again you can think whether we should have any head-on-head trial with prasugrel and ticagrelor. Yes. Again we have a landmark trial, that is SARIAC 5. They found prasugrel was found superior to ticagrelor in preventing death, MI, stroke, without significant increase in bleeding. So my dear friends, prasugrel is the best. But remember 3 contraindications: weight, age, and history of TIA. So then what ACS stand? Any patient of IKIT, load with aspirin, you can give 300 mg aspirin and 75 dose. Higher doses of aspirin decreases cyclooxygenase pathway 2, which secretes prostaglandin, which is good for us. So aspirin, chance of GI bleeding because of this prostaglandin gets inhibited. So low dose cyclooxygenase pathway 1 inhibited, which is thrombogenic. And should you continue lifelong? No. There is many chance you can continue 1 year, 1 month only. You can stop after 4 weeks only. Again, the same time when patient is hypersensitive to aspirin, desensitize the patient. Otherwise, you have to give the dual P2Y2 with loading dose. Aspirin, and second, you see in NSTEMI MI and patient is going with having a stroke, then don't give your prasugrel. But any patient you are going for PCI, NSTEMI going for PCI, then you can give prasugrel or ticagrelor. Without, you are not going to prasugrel, not going for PCI, then only ticagrelor. Take this last sentence: clopidogrel is only recommended when it is contraindicated, not available, or is not tolerated. I think not available is not in railway. If not tolerated and if there is contraindication, I told you, Bilinta contraindication, I told you the prasugrel. 4 contraindicated, take it, then clopidogrel. And no, not available, if somebody telling, this is doing wrong practice there. And if patient getting STEMI, elevation MI, you are going for primary PCI, again we have prasugrel and Bilinta. And when you get thrombolysis, I will go to the, when you are placing, for example, in the primary, in the center where primary PCI center is not available, patient has thrombolytic, you have thrombolysis, give 300 mg of the clopidogrel. Not, remember, don't give 600 mg of clopidogrel. 300 mg clopidogrel, then thrombolyte, then send the patient. And if patient is having more than 75 years, then only 75, don't load with clopidogrel. And any patient of aspirin, as I told, 300, then 75. Prasugrel, again, loading just 65 mg, but if patient is having less than 60 kg and less than more than 75, don't load the patient only 10 mg. So thrombolysis, only clopidogrel best. If you, after thrombolysis you are going for intervention, you can load with clopidogrel. However, that has to pass 24 hours. So SES, you are going for ST-STEMI elevation, you are going for PCI, ticagrelor, prasugrel, you can give aspirin, aspirin is fixed. And CIBG, don't give prasugrel. Bleeding is more. And if you are not planning any intervention, again ticagrelor, not prasugrel, and fibrinolysis, clopidogrel is best. So then how to treat high bleeding risks? As I told, my left subset high bleeding and high thrombotic event. You can see this is the list, not I'm going to detail. There is some high bleeding risks, for example, anemia, old CKD, so and so. This is chance of high bleeding, and there is a DFPT score I will go to. And if there is ischemic event, for example, patient diabetic, recurrent MI, multivessel CAD, peripheral artery, CKD, this is chance of thrombosis is more. And for example, we have done stenting with more than 3 stents we have put, more than 3 lesions we have treated, or any bifurcation. So this is DFPT score. I will take 1 minute more. Don't ring the bell. So DFPT. This is the DFPT score we have. So if your DFPT score, it is a DFPT score, is less than 2, then stop DFPT. If it is more than 2, then prolong the DFPT. So this is the high bleeding risk. Okay, I will stop them. Then beside DFPT score, this is also anemia, WBC count, age, creatinine. If it is less than 25, then standard DFPT. The chance of bleeding is less. If it is more than 25, short the DFPT. Okay, then how short it is? So standard 12-month DFPT. If there is a bleeding risk there, aspirin, ticagrelor only 1 month. Only 1 month, then can you stop the aspirin, continue with ticagrelor. If there is a fatal fibrillation with PCI, you can continue only 1 week, then you can stop the aspirin, you continue with clopidogrel and monotherapy. So finally, a patient with SCS who have tolerated the DFPT with the ticagrelor, transitioning ticagrelor monotherapy at least 1 month after also. So that means give aspirin with ticagrelor, stop aspirin after 1 month. If a chance of bleeding is there, only ticagrelor continue. And same time also you can see any patient undergoing SCS PCI, de-acceleration the DFPT, you can continue switching ticagrelor to prasugrel or after 1 month. I mean to say, when you are switching, you can see this slide. Yeah, this is one more important slide and I will conclude. So you are a acute setting, when there is acute setting, so what is happening? When you are changing clopidogrel to ticagrelor, give 180 mg of ticagrelor irrespective of the clopidogrel dose, and we are changing clopidogrel to ticagrelor to clopidogrel, then clopidogrel 600 mg loading. So everything should be loaded. Prasugrel to ticagrelor load, ticagrelor to prasugrel again load, prasugrel to clopidogrel load with 600 mg, and it's just not happening in the chronic setup. Chronic setup without load you can have. So finally, dual antiplatelet, yes, prasugrel is better than tica, and clopidogrel you should not think of. Timing 12 months. By default, a balanced approach should be there because of the clinical situation, like time, dose, and duration depend upon the clinical situation of the patient. So optimization of the therapy DFPT is an art which totally depends upon clinical scenario of the patient. Thank you. Thank you also.
Thank you so much, Dr. Sishir.
Thank you, sir.
That was an excellent presentation. I hope all physicians now will be very careful in switching to ticagrelor or prasugrel. Especially in railways, we see a lot of clopid prescriptions. So I am sure this talk will now help us modify our prescriptions. Now, a small announcement. Dr. Kondo sir will be leaving shortly, so we will be facilitating him. I request Kondalrao sir to come and Dr. DG sir to kindly felicitate our speaker, Dr. Kondalrao sir. So after listening to initially intervention management of MIs, later on medical management of MIs, now let us go back to basics and listen to a beautiful lecture about risk stratification in acute myocardial infarction by Dr. S.B. Gupta sir. I would request the chairpersons to kindly introduce the speaker.
Former chairman of the railway chapter of API, past president of the Cardiological Society of India Mumbai branch. He is the first governor of the American College of Physicians India chapter, former governor of American College of HS Physicians West India. He belongs to IRHS batch 1979 and he's had experience in the railways. Dr. Gupta, please.
Good morning to all of you. At the outset, I would like to thank Dr. Sai for his kind invitation for this APRCON 2026. Respected DG sir and my three PCMDs, I'm happy to announce that I have worked with all the three PCMDs, Dr. Nirmala Rajaram at Baikla Hospital, Dr. Anjana at Southeastern Railway Garden Reach, and Dr. Sudarshana at Parambur Hospital. So I had a privilege to work with all the three PCMDs. And this is the third time the railway chapter of Association of Physicians of India is organizing the conference at South Central Railway. The earlier two conferences were known as APRCONs, and this is the third conference, which is APRCON 2026. And the topic which has been given to me is quite an interesting topic, and I think it's as mentioned by the MOC, that it's basically a basic topic more for the physicians who are working in ICCUs. And whenever you see a patient of acute MI, I think it's very prudent to risk stratify how this patient is going to behave in future as far as acute MI is concerned. So with that note, I'll just move forward. And these are the risk modifiers for acute, like age, sex, comorbid conditions, whether patient had prior MI, PVD or stroke, whether there is a delayed perfusion or failed thrombolysis, size of infarct, whether there is diminished ejection fraction, presence of congestive heart failure can be classified into CLIP class, whether patient had elevated biomarkers, patient had arrhythmias, and whether patient had proximal coronary occlusion at the time of admission. I think I'll be deliberating more on this proximal coronary occlusion, because in the ICCU, when you see a patient ECG of acute MI, I think seeing an ECG, you can think of whether patient has got what is the coronary anatomy of this patient. So age is a marker for the prognosis. More is the age, more is the death. So 80% of deaths due to acute MI occurs in the age over the age of 65 years, and almost 5 to 6 times higher in elderly patients as compared to the younger patients. Similarly, the sex has got connotations on the prognosis of acute MI, though the female sex has got lesser incidence of acute coronary syndromes, but when they have coronary syndrome or acute MI, the prognosis is bad as compared to the males are concerned. I have told you, whenever you are seeing a patient of acute MI, look for the signs of heart failure. If patient is in heart failure, again the prognosis is bad. You can classify the patient into CLIP classification. Higher the CLIP classification, more is the mortality. As I have mentioned, that mortality is 2.4%, 7% or 19% in class 1, 2 or 3 of the CLIP class, and almost 70% mortality is there when the patient comes in to CLIP class 4. I think there are so many patients of acute MI has got comorbid conditions, and these comorbid conditions play an important role as far as prognosis of acute MI is concerned. The highest is the diabetes. Patient is diabetic in having acute MI. Again, the mortality is higher in patients who are diabetics. And similarly, a patient has got chronic kidney disease. Again, the mortality is higher in such patient. And again, there are patients who have got stroke, COPD, anemia, dementia, or psychiatric disorders. The prognosis is worse in such scenario patients. I mentioned to you that ejection fraction is again a parameter to tell about the prognosis of acute MI. Lower the ejection fraction, higher is the mortality. And 1 year mortality rates have been observed at approximately 36% for severe dysfunction, 10% for mild to moderate dysfunction, and 4% for preserved function. And for those with LVF of less than 40%, the hazard of mortality can be increased by approximately 26% every 5% further decrease in ejection fraction. I told you about the biomarkers, especially the TROP-I, the HSCRP, or the anti-proBNP. These markers, if they are elevated, again, that tells you about the bad prognosis in acute MI. Elevated CRP, BNP levels after an acute MI indicates a poor prognosis. High sensitivity HSCRP level above 10 milligram per liter are associated with significantly higher risk of in hospital mortality, reinfarction, and angina. Similarly, a BNP level of 80 picogram per ml, particularly over 400 picogram per ml at presentation, is associated with almost increased tenfold higher risk of death. And patients with higher level of both markers have got highest risk of mortality and adverse outcomes. Patients who present with arrhythmias in acute phase of MI, again, they fare worse outcomes. Even a simple tachycardia or bradycardia, patient who have got normal heart rate and patient who are having higher heart rate or lower heart rate will have more worse outcomes as compared to the people who have got normal heart rate. The cardiac arrhythmias are an extremely common complication of acute MI, occurring almost in 90% of the patient during or immediately after the event. The ventricular fibrillation and ventricular tachycardia, if they occur in first 24 hours and if they are treated adequately, I don't think they decrease the morbidity or mortality in acute MI. But people who develop secondary ventricular fibrillation after 24 hours of MI or arrhythmias after 24 hours MI, they carry more worse prognosis. And one of the rhythm one is called as AIVR, which denotes successful reperfusion. A patient after successful thrombolysis developed AVIR, then a better prognosis. And VPCs are pretty common, but we shall not try to suppress the VPCs because suppression of VPCs may not improve the mortality. Even supraventricular arrhythmias are quite common. I told you about the sinus tachycardia, frequently seen in almost up to 40% of people. Persistent tachycardia is associated with larger infarct size and higher 30-day mortality. Patients who develop conduction blocks like AV blocks or the left bundle branch or right bundle branch block, especially V blocks are quite common in patients with inferior wall MI, and they resolve 2 to 4 weeks after the MI, and they do not carry worse prognosis. But in patients of acute anterior wall MI, if they develop either bundle branch blocks or right bundle branch block or AV blocks, they indicate fairly big size of infarct and carry high mortality. I think Dr. Sai also mentioned about the delayed revascularization or failed thrombolysis, and if the patient has got undergone, because he also mentioned, I think most of our hospitals, not every hospital is now, I think a lot of hospitals have come with the cath labs, but still there are so many divisional hospitals or even headquarter hospital, they do not have the cath lab facility. So most of the patients, they go for thrombolysis. A patient undergoes thrombolysis, and if it's a failed thrombolysis, which is denoted by which is non-resolving chest pain, and the ST elevation which has not come down more than 50%, tells about the failed thrombolysis, and I think these patients should be sent to a PSA center at the earliest to have the intervention. Now I think I'll be talking about maybe about 8 to 10 minutes about how to identify proximal coronary occlusion by just seeing ECG, and why it's important to know whether LAD, because we have got 3 arteries, left anterior descending artery, left circumflex artery, and the right coronary artery, and why it's crucial to know whether the LAD is occluded proximally, because there will be higher chances of left ventricular failure, much higher mortality, 15% versus 5%, and much higher chances of patient developing right bundle branch block or AV blocks. The anterior wall MI, usually the culprit vessel is single vessel is LAD, and the diagnosis of occlusion is done by the chest leads, showing ST elevation, MI, ST elevation in anterior lead from V1 to V6. That tells you that it's acute anterior wall MI, and the culprit vessel is LAD. And site of LAD occlusion, whether it's occluded proximally or distally, will be told by from the limb leads. This is a cartoon showing if there is a proximal coronary occlusion of LAD. There are two, I do not know whether we got a marker here. Can oh no. Sorry. So I'll just show there is a occlusion is shown. There are 2 arteries, which is one is septal artery, other is diagonal artery, and before that is the occlusion, which is a proximal occlusion. If the artery is occluded very proximally, the base of the heart is at jeopardy. So when the base of the heart is at jeopardy, the vector of ST segment elevation is proximally. That is, we are seeing ST elevation in AVR or AVL, and if the occlusion is in between the diagonal or septal, depending upon whether the diagonal is coming first or the septal is coming first, then the ST segment elevation is seen in AVL or AVR, and if the occlusion is distally, then the vector of myocardial necrosis is towards the inferior leads, and simultaneously, apart from ST segment elevation you see in anterior leads, you will also see the ST segment elevation in inferior leads. You may say it's a very bad occlusion, but no, I think the patient has got better prognosis if there is ST segment elevation is there in inferior leads also. So if the occlusion is proximal to S1, there is more than or equal to 3 millimeter ST segment elevation in V1, ST elevation in AVR, and also associated right bundle branch block. This is one example of anterior wall MI where you are seeing ST segment elevation from V2, V3 and V4, even in V5, V6. Also you are seeing an ST segment elevation in lead 2, 3 and AVF. That tells you that the lesion is distal to diagonal or septal artery. It's a mid-LAD occlusion, and patient has got a better prognosis. This is one, again, an ECG of anterior wall MI, where you are seeing ST segment elevation from V1 to V6. Also, you are seeing in right bundle branch block. The right bundle branch and the left bundle branch is supplied by LAD artery. So, right bundle branch block and left LAFB, left anterior fascicle blocks are quite commonly seen with LAD involvement, proximal LAD involvement, and this ECG shows that this is LAD proximal. And this is one angiography showing LAD proximal block. The inferior wall MI, the culprit vessel is usually RCA, right coronary artery, in 75%, left circumflex in 25% cases, and I have told you that mid-LAD occlusion can cause ST segment elevation in inferior leads also. The culprit vessel can be identified, I think, fairly reliably using ST segment pattern, RV involvement, and AV blocks. The AV node is supplied by the right coronary artery in about 75%, and 25% it is supplied by left circumflex. So in inferior wall MI, the AV blocks are quite common in inferior wall MI. And this is the right coronary artery involvement is involved. Then the ST segment elevation is more in lead 3 as compared to lead 2. While if it is the left circumflex artery is involved, then ST elevation is more in lead 2 as compared to lead 3. And ST segment depression is there in lead 1 and AVL. It tells about, again, left circumflex artery involvement. So I told you lead 3 more than lead 2 RCA, T wave, depth of T wave more than lead 3 than lead 2 RCA. And normally whenever we are seeing a patient of inferior wall MI, we must do a V4 lead, also the right side lead, also to see whether there is involvement of right ventricle is there or not. The inferior wall MI leads to, because it's caused by the right coronary artery mainly, it causes ischemia of sinus or AV node, so it leads to sinus bradycardias or AV blocks. There is ischemia of papillary muscle, can lead to papillary muscle dysfunction and MR. There is right ventricular involvement. Almost 30% of the cases of inferior wall MI has got right ventricular wall involvement, and there are more tachyarrhythmias in inferior wall MI. This is one ECG showing ST segment elevation in lead 2, 3 and AVF, and ST segment elevation is more in lead 3 as compared to lead 2. That is showing, that tells about the right coronary artery involvement. And then on the left side of the panel, again an inferior wall MI, but lead 2 is showing more ST segment elevation as compared to lead 3. That tells you about this is a circumflex artery involvement. Once we take a V4R lead in acute inferior wall MI, again, if there is a ST segment elevation of more than or equal to 1 millimeter, it tells you about the proximal occlusion of RCA. If there is no ST segment elevation, it tells you distal occlusion. If there is a negative, it tells you it's a circumflex occlusion. Why is it important to know whether RCA is occluded proximally or not? Again, if the RCA is occluded proximally, it implicates that there is a likelihood of right ventricular wall MI. There is increased incidence of cardiogenic shock. There is increased incidence of chronic ischia-related VT, and very high chances of AV block. Again, the right coronary artery is sometimes it's a non-dominant, sometimes it's dominant, sometimes it's a super-dominant right coronary artery, and that can also be told if there is no ST segment elevation in V5, V6, it's a non-dominant RCA. If there is a ST segment elevation in V5, V6, which we call as inferolateral wall MI, but the ST segment elevation is less than 2 millimeter, it is a dominant RCA, and if the ST segment elevation is equal to or more than 2 millimeter in lateral leads, then it is a super dominant RCA. And proximal circumflex occlusion leads to ST segment elevation in lead 1 and AVL. There is sinus bradycardia and more chances of atrial fibrillation. And again in inferior wall MI, from the chest lead changes, if the ST segment depression is there from V4 to V6, it has got poor prognosis. It tells about the triple vessel disease. If the ST segment depression is there from V1 to V6, but if it is a decreasing pattern, then it's a better than the first scenario. And V1 to V3, if the ST segment depression is there, usually it tells about the reciprocal changes. The diagnosis of left main occlusion, I think left main where from the left LAD and circumflex is arising, and the ST deviation, because it's a very proximal, again it's the base of the heart, so ST deviation factor is in the frontal plane, points to the AVR, and in the horizontal plane of V1. So there will be ST segment elevation in AVR and V1. Often wrongly, if we are not concentrating on these two leads, we may diagnose as a non-ST elevation depression MI, and this is one ECG where you are seeing an ST segment depression from V2 to V6, and if you do not see an AVR and V1, you may label it as NST MI, and this will be I think biggest mistake, because we call it as a widowmaker lesions. Sometimes we do not deal with this artery, then patient may die all of a sudden. So this has to be identified very acutely. So just to conclude, it's important to risk stratify the patients of acute MI to judge the prognosis and the planning of early revascularization. The risk stratification depends upon age, sex, comorbid condition, size of infarct, ejection fraction, presence of heart failure, clip class, level of biomarkers, arrhythmias and site of coronary blockage, and the extent of the coronary artery disease and early and complete revascularization. Thanks. Thank you very much. I think I have got 1 minute and 40 seconds left. I'll just narrate you an incidence of failed thrombolysis. It's not a really failed thrombolysis. I think most of you people may not be knowing that after the Perambur Hospital, Central Railway Hospital, Baikla did 7 coronary angiography. The second hospital in the Indian Railways who performed coronary angiography on a mobile cath lab. This was the second hospital, but unfortunately, the Central Railway Hospital, Baikla, has not seen the cath lab so far. That was my dream when I was working at then DG Dr. K. Suresh. He even sanctioned the cath lab. We got the sanction money. So, but then the project got fired. Still, it remains my dream, even after my retirement, that Central Railway Hospital shall get a cath lab, and we also be on the same platform as other headquarter hospital. So that's my dream. Thank you very much. I think because DG is here, so I thought let me put this word in front of the DG. Thank you very much.
Thank you, Dr. Gupta, for that excellent presentation. We've always known you as a bedside clinician connected to the patients from your early days in Southeastern. And I think questions will be taken together at the end of the session. Thank you very much.
Thank you, sir. That was a very detailed presentations about the basics of MI, which every physician and every doctor working in the emergency ward should know. An announcement, dear delegates, tea and coffee is being served downstairs. There will be, you can have it throughout the day, it will be served. You can have it at your leisure. There will be, we are not breaking in for any tea break due to paucity of time. Now I would like to request the next speaker, Dr. C. Raghu sir, who will be talking about pacing in heart failure and improving synchrony and outcomes. I would request the chairpersons to kindly introduce the speaker, please.
So it's my pleasure to introduce Dr. C. Raghu, who's a senior interventional cardiologist attached to Yashoda Hospital in Bangalore. In Hyderabad, and he's done his MBBS, MD and DM from I think he did his MD from AIMS New Delhi and his DM cardiology again from NIMS Hyderabad. So over to you, Dr. Raghu.
Yeah, we will. Shall I take my laptop? Reach it now. Yeah, there are some images, so it's taking a moment to get loaded. Thank you, the South Central Railway team. My respects to the senior cardiologist, Dr. Sudarshana, and senior officers like the DG of Railway Health Services. Thank you, Dr. Sai, for giving me this opportunity to present about pacing in heart failure. Before we go into the presentation, before it is getting downloaded, so heart failure is a very common problem. Compared to coronary artery disease, where the therapies are very easy, managing heart failure, we need to know the reason for the heart failure, how to treat it. So it is not a homogeneous entity like a coronary artery disease where you have a clarity of, like Dr. Gupta was teaching us, how to identify the infarct-related artery and all. But in heart failure, you need to really think what is the problem for the patient. So that's what we are looking at. So there is a subset of patients. Normally, when we have a patient with heart failure, we always think that, okay, this is the end of the road for the patient. But nowadays, with a lot of advances in the medical therapies and also advances in the electrical therapies, we are able to save the patients. This topic I am going to only focus upon how to improve the heart failure by using the pacemaker. So I think it's okay. We'll just go forward. Yeah, thank you. Can we see the slide? Yeah, thank you. Okay, thank you very much. So whenever this is the from the sinoatrial node, somewhere at the junction of this sinus SVC and the right atrium, the sinoatrial node will be there, and this is the atrioventricular node, and that goes and bifurcates on the left bundle into anterior, posterior and middle fascicles. So what is happening is, we have seen just now that there is a left bundle branch block or a right bundle branch block in an MI. There is more problem for the patient. Similarly, if there is a left bundle branch block for the patient, these are the patients who are going to do badly. So there are two types of left bundle branch block which we should differentiate. In the left bundle branch block, you have got a true left bundle branch block and a left bundle branch block like pattern. So if you can identify on the ECG in L1, AVL, V5 and V6, if you can see that there is a notching, I am sure all of you can identify the notching on the L1 and AVL. If you can identify the notch, that indicates that there is a true left bundle branch block. And this group of patients, if you do a pacemaker, these are the patients who are going to get better. In I would not say contrast, in comparison, you can see that in this LBB, even though it fulfills the broad QRS, there is no notching on the L1 and AVL. So that means it is an LBB-like pattern that is due to the dilatation of the left ventricle rather than a conduction system problem. So the foundational thing is, you have to identify, once you start recognizing this, you will pick up a lot of patients. 30% of our heart failure patients are due to LBB associated cardiomyopathy. So it's a very common entity. If you identify, you are going to make a difference in the life of the patient. So what were we used to treat it? In the past, we used to treat by a biventricular pacing. That means we used to pace the left ventricle and right ventricle simultaneously so that the heart's conduction system is restored naturally. But nowadays, what we do is we pace the His bundle directly. You have seen in the previous picture that this is the His bundle. So at this point, you can pace, and then you will be able to get a narrow QRS and a native conduction. In contrast, when you pace from the ventricular, you are pacing the myocardium, not the electrical conduction system. You can also pace in the left bundle area, like you can see here, multiple areas where you can pace the left bundle. So you have one more type of pacemaker, there is a left bundle branch area pacing. Now there are a lot of ways in which you can pace the heart physiologically. All these advances have happened in the last 4 to 5 years. So you can see all the references are in the last 2-3 years only. So you have a cardiac resynchronization therapy where you can do a biventricular, or you can do a conduction system. In this conduction system, we can do a pacing of the His bundle, we can do the left bundle branch pacing, or we can do a hybrid pacing modality also. So if you go into this ECG, you can see we are pacing only the His bundle. Otherwise, we can pace the left bundle. The advantage is the left bundle is a broader area, whereas his bundle is a localized area. So pacing the left bundle is much more easier. So this is the left bundle pacing. These two are the physiological pacing. Alternately, traditionally what we used to do was put a lead at the RV apex and one in the coronary sinus. That is what we call the biventricular pacing. But nowadays what we do is we do a his bundle plus a coronary sinus or a left bundle plus a coronary sinus. These are the hybrid modalities, what we call as the hot CRT and the lot CRT. I will just show you some cases to make you understand who are these patients, how can we identify them, what we can see. For example, this is a patient who has a complete heart block, normal left ventricular function and presented for pacemaker. So normally what we do, we put the pacing at the right ventricular apex. So you create a left bundle branch block which is iatrogenic. So this iatrogenic left bundle branch block leads to a LV dysfunction in up to 40 to 50% of the cases, but usually in about 15 to 20% of the cases. So the chances of the person to develop left ventricular dysfunction because of this iatrogenic left bundle branch block depends upon how frequently the heart is requiring pacing. If it is more than 20% pacing, the risk of PACM or the pacing induced cardiomyopathy is high. If it is more than 40% pacing, it is almost threefold higher risk of developing the pacing induced cardiomyopathy. So RV pacing, it was easy, it was there for the past 5 decades, but nowadays we need to pace at alternate ways. So one of the ways, as I was showing you, is if you do a his bundle pacing, you can see that the QRS is quite narrow. And in the recent trials, as we have seen in the MELOS trial, with those bradycardia patients, 93% of the patients had a successful implant, and those patients who had a conduction system versus a right ventricular pacing, the pacing induced cardiomyopathy is much higher in the RV apical pacing. This is a patient whom we had done in our hospital early part of our career about 2 years ago, or 2.5 years ago, where you can see this might be passed away as a normal ECG unless we see the pacing spike or the presence of a small R prime in the lead V1. So this is for an AV block. We paced the left bundle branch block. So left bundle branch area. So we can pace for a AV block at the apex of the RV, at the his bundle, left bundle, or biv. Biv if there is a left ventricular dysfunction, that is EF less than 50%. So what has happened now in the last 2-3 years is, for all the AV block patients, the first line of pacing is a conduction system pacing, and his bundle pacing, because of its increased thresholds over time, we prefer to do a left bundle pacing. And in a study which has studied about 3,000 patients randomized to RV pacing with left bundle pacing has improved the mortality. So this has also been published quite recently, showing that if you pace the left bundle, the mortality is better whenever you have a left bundle branch block. Now let's say if that is for the AV block. Now let's go to the left bundle branch block. If the patient has got LBB and LV dysfunction, this is an 82-year-old male. We think that elderly people, they are not good for therapy. No. So this patient was on all the GDMT for heart failure. EF is 28% and he has got a moderate MR, multiple hospitalizations in the hospital. So what can we do for these patients? Because I will show you the ECG also. So we did this patient a biv CRT. That means one lead in the coronary sinus, one lead in the left bundle. That is actually for this patient we did a lot CRT, because if you see the QRS duration for this patient, it is quite broad. So for those patients with left bundle branch block, there is an altered ventricular activation regurgitation. So this altered ventricular activation leads to mitral regurgitation, and this mitral regurgitation plus delayed ventricular activation leads to heart failure. You give them lot of GDMT, they don't get better. And if you delay the implantation of a pacemaker for these patients, the recent data shows that there is a higher mortality also. So we should do these treatments quite early. And then one more very important thing is women with LBB and heart failure, they respond much better at a much shorter QRSD duration compared to the men. So this is a new, this is a very good way to treat these patients. So for example, this is a textbook example of a left bundle. You can see a broad QRS in LY, V5, V6 you have got a notching, and once we did the left bundle pacing, it became completely normal, and you can see the QRSD reduced from 140 to 85. I will show you the patient whom we were discussing. This was the ECG where the patient presented with, you can see in AVL there is a notching of the R wave, and also there is a broad QRS of around 148 or 150 milliseconds. So once we did a lot CRT, you can see that the QRS became narrow, and you can see the left ventricular forces became very prominent compared to the previous ECG. And then you can see this case we did in February 24 February 25, and by August 25 the ejection fraction improved from 28 to 40, and yesterday he came for follow-up, so his ejection fraction became normal in about 1 year 2 months time. Most of the improvement in the left ventricular ejection fraction gets better in the first 2 to 3 months only. The other scenario which is quite common is patients who have got atrial fibrillation. Those patients with atrial fibrillation, you have got very fast rates around 130, 140. You give these medications, the patients do not tolerate the medication, and eventually the left ventricular ejection fraction falls. They can either have a left bundle branch block, or even without a left bundle branch block, these patients continue to be in heart failure. So what we have is, this is a landmark study which was published 2 years ago, which shows that those patients with atrial fibrillation and a narrow QRS with heart failure and symptoms, they did an ablation with a cardiac resynchronization, and the other group they gave drugs. You can see with a 140 patient recruitment, they could show a significant improvement in the mortality in the studies, indicating that for permanent AF, narrow QRS, heart failure, we can do a BIV CRT. That was done in 2021. But whereas in the recent study which was presented in the EHRA last week, it shows that even BIV CRT versus left bundle branch area pacing, both are equivalent. So patients with AFib, I will show you a case which we have done. This is an AFib, very irregular heart rate, and then patient continues to be in heart failure. She is also around 84-year-old lady, and then once we did the pacing, you can see we did a BIV CRT for her. We did not ablate the AV node, but with that the ventricular rate became very stable, and this is what we can, this patient we did an RV apical plus a left bundle. So we did a BIV with a intraventricular synchrony achievement. Then the fourth case I wanted to show is where we can do a left bundle plus a coronary sinus, that is left bundle and a coronary sinus. So once we do, this is a lot CRT. So for those patients who have got a very broad QRS, like let's say 160, 170 milliseconds, this would be probably a better strategy. Around 140, 150 milliseconds, a normal left bundle area pacing could be working. But if it is a very large QRS, broad QRS, then lot CRT will be useful, where we pace the left bundle and also the coronary sinus. What is important is those patients who have got a large myocardial infarction, they are not very great candidates for this type of therapy. For non-ischemic cardiomyopathy, this is a very beautiful type of a therapy. Now let's go to one more entity, what is called as the pacing-induced cardiomyopathy, where after putting the pacemaker, the left ventricular function goes down. So this is a 73-year-old man who underwent a pacemaker in 2021 for sick sinus syndrome. Baseline EF is 62. In the last 4 years, he never slept supine. All this while he was lying, he was always sitting and sleeping, and his ejection fraction dropped from 60 to 35. He was consulting multiple doctors, and he was mostly under the treatment of pulmonologists because they said your pacemaker is working well. But the pacemaker is working well, but it was responsible for his cardiac problem. So that is what we call as the pacing-induced cardiomyopathy. So what is pacing-induced cardiomyopathy? If the EF falls to less than 50, or compared to the baseline, if the EF reduction is more than 10%, then we can say that there is a pacing-induced cardiomyopathy. In this patient, 62% to 35% EF drop is a classical textbook PACM. So what did we do for this patient? So what we did is, he already has an RV apical lead. So what we did was, we put one more left bundle lead for this gentleman, and then this patient got better. I will show the ECGs in a moment. But going back to the data, you have got a lot of recent trials published in the last 2 years indicating that for pacing-induced cardiomyopathy, instead of putting 2 leads, one in the CS and one in the RV, we can do a pacing in the left bundle only. So this patient, that 73-year-old gentleman, correspondent of a school, you can see a very broad left bundle with a notching. This is all a pacing-induced cardiomyopathy. Once we did the left bundle lead, you can see the QRS has become completely narrow. And you will not believe, in the next 2-3 days, he became all right. What he was unwell for 4 years, he could get better in the next 2-3 days. And he refused to go back home because he was not sure that how can he get all right so fast. Finally, one more entity where there is a right bundle branch block with heart failure. Previously, when we used to do a bi-V CRT, these patients were not doing well. But with the availability of a lot CRT, or the not the lot CRT, with the availability of a left bundle branch area pacing, like in this patient, this gentleman underwent a aortic wall replacement, surgical AVR, plus a single chamber pacing. And you can see he has got a right bundle branch block and a very broad QRS. And he presented with heart failure and end of life replacement indication. We were not very sure whether the LV dysfunction is caused by a recurrence of aortic stenosis, because the aortic valve also having a patient process mismatch. So we were not sure. So what we did is, first simpler therapy, instead of going for a TAVR, we just put a pacemaker for him. You can see that the right bundle branch block which was there has disappeared, and the QRS became narrow, and this patient became asymptomatic, and the aortic wall gradients also means the LV dysfunction has improved completely, and this is about 2 years since we performed the procedure. Now, having said that such a complex type of a topic, I just wanted to share with you some quick takeaways for the physicians when they go back home. Left bundle branch block means the LV gets activated late. So this late activation leads to LV dysynchrony, LV-RV dysynchrony, and also intra-LV dysynchrony also will be there, and that leads to ventricular dilatation, that leads to functional mitral regurgitation. If your QRS is more than 130 milliseconds, always consider this patient could be a candidate for a CRTP, or the left bundle branch area pacing, or a conduction system pacing. How do you suspect these patients? Low EF, wide QRS, and symptomatic despite medicines. So this is what we have to understand. Then who is not suitable? If there is a broad QRS and LBB, definitely useful, but less than 130, sometimes we might not be a very good candidate for us to treat these patients. For those patients like permanent AFib, what I shown you, those are not the ideal patients when we start the therapies, but as we gain experience, we know how to treat these patients and get better. And these patients should have a reasonably good longevity, but I can promise you that most of these patients do extremely well once we put these patients on pacemaker. So what are the complications which we can follow up during the follow-up? We can have a lead dislodgement, we can have a pocket hematoma, device infection, pneumothorax, phrenic nerve pacing if we are doing especially a coronary sinus lead, and coronary sinus dissection, which we manage in the cath lab. So that is what I thought that I will I will show one more important thing is, whenever we are giving medications for these patients, because we put the patient on pacemaker, do not stop the GDMT. In fact, when you put the pacemaker, that gives you an opportunity to step up the GDMT and go upper and upper to the maximally tolerated doses or the highest possible doses. So CRT plus GDMT is the combo, and that is the best working, and not CRT and GDMT are not mutually exclusive therapies. Then we have to avoid certain drugs like NSAIDs, class 1C antiarrhythmic drugs, and then especially most of these patients have paroxysmal atrial fibrillation. So whenever you stop the anticoagulation, please contact the cardiologist to identify this patient. So ladies and gentlemen, my dear friends, we can identify patients who can benefit from pacemaker if their EF is low, if they have got a left bundle branch block, if they are on GDMT, please refer to a good cardiologist who can find and treat these patients. All these patients should be on a good GDMT to start with, and following the device we can look for the complication which we have mentioned, and you should not suggest these patients for less than 130 QRSD, and renal dysfunction is quite common, so we should always look at that, and anticoagulation also we need to understand these therapies. With this, I think I will leave this for some questions, and thank you very much once again Dr. Sai and his team for asking me to present on this topic. Thank you.
Thank you, Raghu, for this excellent presentation. And you have taken us step by step what to do and a clear picture about the pacing in heart failure patients. One thing I could tell is, in olden days, in 70s and 80s, when they were doing single chamber pacemaker, RV pacing, and we followed the cases in the 90s, we used to see a lot of heart failure.
Yes.
Then atrial pacing came. Then DDD has become routine. From that, we have advanced so much, and to take care of heart failure patients. Really, it is a very excellent presentation, and anyone has questions, they can do. And to see, he has conducted a LBBP and workshop recently.
Yes, madam.
It was excellent. I couldn't attend due to personal reasons, but I keep getting information.
Thank you, madam.
Very nice.
Thank you. With all your blessings, madam. Thank you.
Any questions regarding this heart failure? This
Yeah.
One more list.
Okay.
Thank you.
Thank you, madam. Thank you.
So that brings us to the end of the cardiology talks. There is a small talk left, but that was an excellent session detailing about the pacing methods in heart failure. So this goes with the theme of the conference. We are covering all the latest innovations which are taking place. I am sure all the physicians will be taking notes and sending required patients to pacing specialists. A small announcement, ladies and gentlemen, kindly note that the first aid booth located near the entrance for any medical assistance. The travel desk, emergency quota counter and assistant counter are located downstairs for your convenience. Restrooms are also available downstairs. Kindly contact the help desk team for any further assistance. Thank you. Now I would like to call upon Dr. Anjana Malhotra ma'am for delivering a short talk about her experience in developing a tertiary care center in hospital. This will be a very useful topic for all the budding railway physicians.
Dr. Anjana Malhotra is PCMD of Southeastern Railway. She is also the head of the Department of Plastic Surgery at Southeastern Railway Central Hospital. She started Eastern India's only doctorate in National Board program in 2019. She has worked for West Bengal chapter of APSI in various positions, including presidency. She has organized multiple live workshops and CMEs to train junior surgeons in plastic surgery. And she is a trustee of the Mission Smile. And she has numerous publications in her name, and she is the brand ambassador of AE Search 2026. She belongs to IRHS batch 1987. Dr. Anjana Malhotra, please.
Thank you, Madam, for those kind words. I'd like to thank Dr. Nirmala and her team and Dr. Sai for giving me this opportunity to just continue as what Dr. Sai told you. I'm not a physician, but just for the juniors to show how you can start units in the railways. It may be a lot of trouble, but there is help. So I finished my MCH in 1998, and what happened then was that the MD said, we don't need a plastic surgeon, you go and work in the casualty. There were no beds or OTs allotted, and whenever I used to sit in the OPD also, what we used to get was that only women used to come to me, those with bleeding PR and breast lumps who didn't want to show a male surgeon. And there was no awareness about plastic surgery or what a plastic surgeon does. But you often have people who help you along the way. This gentleman, Dr. G. Hariharan, who was then a PCMD, he recognized the need for a plastic surgeon. He sent me to Stanley Medical College for training in hand surgery, we being an industrial setup. And he procured the operating microscope, which was essential for the development of plastic surgery in out-of-turn basis. And then he made me start the hand surgery unit for industrial accidents. So when I joined, we had just these two instruments, one Humvee's knife and this measure. And then I decided to launch the core services, wound management, basic reconstructive procedures, trauma reconstruction, burns care, and hand surgery. So these were some craniofacial. Craniofacial needs a lot of work, very dependent on ancillary services like dental, maxillofacial. So I decided to branch out into microsurgery. There were very few centers providing training in India then, but thanks to the administration, I went on to Ganga Hospital, Coimbatore, my training, and then Changung Hospital, Taiwan. And then we started by using the microscope, the Appaswamy microscope, which the eye department had. So these are some of the cases done then in 2001. Boy came just with this nevus. We reconstructed the radial forearm flap, one of the earliest free flaps in the city, I think. This is another man whom I thought I should ampute. Whether should I reconstruct? We reconstructed his foot, and you can see him back in 2023, and you can see that he's walking on that foot 20 years down the line. So then we went on to the fibula flap. This is my had the injury, bullet gunshot injury. Was an RPF who's fired his gun through the floor of his mouth. Not a very good reconstruction, and we evolved, and you can see shape and able to give some years down the line. Again, this patient came to us with this traumatic amputation of the penis. We did a penile reconstruction for him. Subsequently got married and had a child. Some again cancer cases which we have reconstructed. And again some synchronous cancers where we did 2 flaps to reconstruct the patient. And we have done maxillectomies, reconstruction also. And then we started collaborating with Howrah Orthopedic Hospital. All their trauma which needed soft tissue reconstruction started coming to us. So these are some of the newer flaps, like the medial sural artery perforator flap, which we started doing for the smaller defects. We got the advanced Zeiss microscope in 2015, and then this is a patient who came from Howrah with, he lost his thumb in the workshop, and we have been able, he came in at 5 p.m. We did the surgery through the night, and you can now see him, he's gone back to his job with his amputated thumb totally reconstructed. And then we went on to do thinner flaps, as we did learn from the masters in the world. So this is again a anterolateral thigh flap, which was super thinned. And this lady was a teacher. She had burns and she wanted to go back to what she was. And you can see her now. She's back to her job as a teacher. Again, as we evolved, we started doing CAD-CAM reconstruction. So you can see this man had an ameloblastoma, where we have reconstructed him with the CAD-CAM technology and even given him teeth. Another boy, again from Eastern Railway, we have reconstructed using the CAD-CAM technology, used the fibula to reconstruct the mandible. And then came the second phase of development, expansion into Center of Excellence. We started the Regional Burn Center and tried to become the trauma reconstruction hub for the Eastern Zone. So this is the burn unit. Yeah, just let me. Yeah. So just a few more minutes. So this is the burn center. This is the 8 beds dedicated burns ICU. And we started early burn wound excision with cadaveric skin grafting taken from the National Skin Bank at Airoli. So this is how the cadaveric skin comes and it's helped. So these are national tie-ups with the National Burn Center, Bombay, and the Masina Hospital. And we use the railway network to do burn public awareness in all stations across Eastern, Northeastern, and Northern railways. And these are some of the posters we put up pre-Diwali in all the stations. And then we became a referral center for complex trauma. Again, this gateman who had this chopper injury, we've reconstructed him. Other fractures like this frontal sinus fracture. And again, for orthopedic trauma, as I said, with the Howrah Orthopedics, this boy had a road traffic accident, and we've done multiple flaps to get him walking. Again, all these ulcers, the major trauma, this is a monkey bite with loss of all tendons and vessels in the posterior part of the leg. And then we did national collaborations with Mission Smile, where we've been doing training and cleft palate surgeries all across the country. And also in our hospital, we've done around 3,000 patients till now. So these are some of our results. And then at present, I think Dr. Prasad is here. I didn't know you would be here, sir. And I really salute you, because when you visited us in 2013, you gave me the post of 2 senior residents. I had to run around in Delhi and met you many times and was able to get it. And then in 2019, we started the only department in Eastern India, not even railways, of DRNB in plastic surgery. And so we believe in ethical clinical practices, intensive academics, and the finest research facilities. And today we have all the equipment which is needed in a modern plastic surgery department, including lasers. And these are some of, even we have the ICG camera for studying flap flow. And these are some of the national and international workshops we've had across the years, the Plastic Day celebration. And we have gone on to train the state youngsters. And these are the surgery training workshops we hold regularly in our hospital. And during COVID, we had lots of webinars across the world. And we had the ISAPS 2019 course. It was the first time in the world that ISAPS had a live operative workshop, which was beamed to 63 countries, and it was all done at our hospital. And these are some of the research and publications which are ongoing in our department. So I'd like to thank you for giving me this time. And alone we can do so little, but together we can do so much. Thank you so much.
Thank you, ma'am. So that was the second wonderful, inspiring story of the morning. So I'm sure all of the budding physicians must take heart and try to develop their units in their respective places. With this, we come to the end of the first session. I would like to request chairpersons for their comments.
Any questions from the audience?
Next.
Madam's presentation was excellent. Really shows how we can do anything in the ways. Hariharan, like her mentor, he was also a mentor for me to get into the cardiology. So I am very happy to see his picture. Another thing we started, what will be the content? They should give manpower so that it continually will be there, because we have to retire. You cannot give us extra years of service in railways, because 60 we have to retire. So the continuity should be built up. It should not be, Sai is doing so much of work. After Sai retires, who will do? So we have to build up the next line. That's what Hariharan used to do in railways, because I worked with him in Southern Railway in various capacities under him. So that should be continued. This is out of a scientific aspect. The one thing is about DPT therapy, I thought there was a deviation about the topic. The adapted duration after interventions was the topic given here, but I think it was a miscommunication. He has told about the molecules and all in depth. Anyhow, it was very excellent presentation. And any questions about Dr. Raghu's presentation, which is, it was crystal clear. I don't think anyone will have thing. And guidelines presented for all of us, we are basically clinicians. When patient comes, we have to examine the patient, approach. Clinical classification comes first, then the intervention. How fast you recognize? Diagnosis is the most important thing. Once we diagnose only the interventions, everything will come. Suppose we miss the diagnosis, we can't do anything to the patient. So the clinical aspect, always we have to keep it in mind. And Dr. Sai's presentation was very good and point relevant, very good. And about the AI presentation, how much we can implement in our day-to-day practice. Though they have done us as a study, it is not that. It takes long way. So still we have to keep our clinical acumen and ECG reading, everything. The time we get those machines and the algorithms, it may take time to percolate into the lower level. It may be in the big institutions and all, still it is possible. And we expect that. But for me, I think it is far-fetched in our setup, where starting from health unit to the divisional to headquarters hospital we are doing with our limited things. All that staff also necessary, not that AI is doing, we have to have the backup things. This is my personal opinion. Anyone has any questions, you can ask.
And I'd like to answer one query you raised. So, Dr. Avinash is there. He's IRHS who's going to continue the unit. We have managed to get him posted as.
Any questions from the audience for the speakers? Right. So with that, we would conclude the first session. I would request the honorable chairpersons to kindly felicitate the speakers. Sir DG sir, and CMD madam, Anjana madam, and Sudarshana madam, kindly we welcome all the speakers, Dr. Sai sir, Dr. Shishil Rao sir, Dr. S.B. Gupta sir, Dr. C. Raghu sir, to kindly come to the stage.
Lights. Then the lights on.
I invite Dr. Sai sir. Sir will be felicitated by our respected DG sir. Next, I know. Next, I would like to invite Dr. Shishil Rao sir. Dr. Shishil Rao sir will also be felicitated by our DG sir. Dr. S.B. Gupta, sir. Sir will be felicitated by respected DG, sir. Next, I invite Dr. C. Raghu, sir. Sir will also be felicitated by DG, sir, and team. With this, we conclude the felicitation of the speakers. Now it's time to felicitate our esteemed chairpersons. I would like to invite Dr. NVPK Sai sir to felicitate our chairperson, DG sir. So, our DG sir is Dr. Jagdish Chandra sir. He joined Indian Railway Services in October 1987 at Perambur Hospital as senior resident. He was transferred to Allahabad Division in 1988. Post that, he was working in Northern Railway in Lucknow in 2000 and served as a specialist in radiology. And there he established an advanced radiology department at Lucknow, including digital X-ray, ultrasound, and the first 128-slice CT scan in 2020. Sir was later on promoted as CMS during COVID period and served at MP Hospital. And thereafter transferred in 2021 as CMS Northern Railway Lucknow Division. He was promoted to HAG in April 23 and joined as PCMD ECR. And thereupon he was transferred and joined as PCMD NR in December 2024. And finally on 16th June 2025, he was elevated to the apex level post of PCR. Sir is an alumni of KGSU and has completed his postgraduate radiology and is a radiologist of the. We are happy to have you here, sir.
Now I call upon Dr. Sushma Martin, PCMD, Northeastern Railway, to felicitate our PCMD Madam, Dr. Nirmala Rajaram. Dr. Nirmala Rajaram is a PCMD of South Central Railway and she is a gold medalist and past DNP from JRH Railway in 2000 and she has been instrumental in developing a DNP program in our hospital and her areas of interest is infertility and gynec endocrinology. Welcome. I call upon Dr. Krishna Kumar. I call upon Dr. Krishna Kumar, PCMD Northwestern Railway, to please felicitate our chairperson, Dr. Ranjana Malhotra, Madam.
Dr. Ranjana Malhotra Madam is PCMD SER and HOD of Plastic Surgery at SER Central Hospital. She started Eastern India's only DRMD program in 2019 and has worked for West Bengal chapter of APSI in various presidents, including presidency. She organized multiple live workshops and CMEs to train junior surgeons. She is a trustee of Mission Smile and has numerous publications in her name. And she is a brand ambassador of AE Search 2026, a member of 1987 IRSS batch. Also was the speaker, so she will be receiving the speaker memento too.
Next I call upon Dr. BP Deka, MD, Central Hospital, North NF Railway, to felicitate our chairperson, Dr. Sudarshana Madam.
Ma'am is a retired cardiologist of repute and was working in Southern Railway, Perambur. So with this, we conclude the first session of the morning, and
Yes, madam. We'll add this tonight.
Madam, ID card. So after completing the first session, which was dedicated to cardiology, we come to the iconic moment of the APRCON, the most awaited Dr. Fanidar oration, which will be delivered by Dr. D.V. Srinivas sir, is a consultant gastroenterologist and is also our visiting gastroenterologist. He will be giving Fanidar oration about advances in diagnostic and therapeutic endoscopies, its impact and management. To chair this session, I call upon the chairpersons, Dr. Susma Mate ma'am. She is the PCMD NER, Dr. Krishna Kumar, PCMD NWR, and Dr. BP Deka sir, MD NEFR. May I request the chairpersons to kindly come and occupy the seats. Once again, a reminder, tea and coffee is being served downstairs. We are not formally breaking for any tea break due to paucity of time. We would like to maintain our time schedules.
Picture photograph of Dr. Fanidar sir, please.
Yes, ma'am.
Meanwhile, I'll read about this oration. This oration was instituted in the memory of late Dr. Fanidar, who was instrumental in setting up the gastroenterology center and making Jagjivan Ram Hospital, that is the Central Railway Hospital of Western Railway, one of the best hospitals in Indian Railways. Having done his master's in internal medicine from KGMC Lucknow, he worked at AIMS and KGMC for short periods, and then he chose gastroenterology as the field of special interest. And to pursue the same, he was trained in various institutes in United States of America, including Harvard and Massachusetts and Boston University School of Medicine. He joined Indian Railway Medical Services in December 1973. He served Western Railway for many years in various capacities like MS, ACMO, CHS and CMD. He became the DG RHS in 1995 and framed the IRMS mission statement, we call it IRHS now, and the mission statement which we follow all over Indian Railways, that was framed by Phanidhar sir. He remained in that position till he superannuated in the year 2000, and his great soul departed from this world following a tragic road accident a year after his superannuation. During his tenure in Western Railway, his unique style of functioning, his clinical acumen, and the command over administrative matters were widely appreciated. He was instrumental in setting up Gastroenterology Center in Jagjeevan Ram Hospital and initiating the postdoctoral course of DNB Gastroenterology. And he also authored numerous scientific papers in national and international journals and contributed chapters in textbooks of gastroenterology and nutrition. Over a period of time, the Gastroenterology Center has progressed by leaps and bounds. Since its initial accreditation by the National Board of Examination in 1994, the department has been reviewed 5 times following inspection and by the board, and approximately 60 scientific papers have been presented and published at national and international conferences and journals, and some of which have also won the awards. Today, it is one of the best equipped department of gastroenterology in Mumbai. Every year, APRCON, now APRCON, conduct an oration on gastroenterology to honor and remember him. This year, the oration is presented by Dr. D.S. Srinivas, and sir will be having his presentation on the advances in diagnostic and therapeutic endoscopies, its impact in management. Dr. Srinivas, please.
Respected Chairperson and dear colleagues, first thank the organization for inviting me for this oration. I am a small soldier in gastroenterology. It is an honor to represent the gastroenterology fraternity here. So I have been associated with Railway Hospital for nearly 15 years, and I learned a lot from this organization, patients, and improved my skills. Yeah, the journey of endoscopy is really fascinating. When a first endoscope was performed in 1868 by Kussmaul, I remember it was done with a rigid endoscopy without anesthesia, and the agony the patients had for nearly 90 years. Rigid endoscope without anesthesia, examining the upper GI tract. 1958, we had the first semi-flexible endoscope, and that was a fiber optic endoscope. In 70s, it was a miniaturized, and where the first pediatric endoscopy was done in 1970s. We all learned our initial endoscopy with a fiber optic endoscope till 1990s, when first video endoscope, that is the CCD-based video endoscope, was invented. After that, the journey has been so fascinating and fast that we have been in the process of learning all these years, and we are learning even today. So initial endoscopy was just a diagnostic tool. Gastroenterologists were known for diagnosing the disease and hand it over to the surgeons or any other team. Now with the advances in endoscopy, we can characterize the lesion more clearly. We can confirm the lesion. We can almost give the diagnosis on endoscope and do the therapeutic endoscopic work in the same setting. So the chroma endoscopy, this is a dye-based endoscopy where you have to spray the dye over the lesion to delineate the margins of the lesion so that you can excise that part of the lesion very clearly. But further advances in it, that is an NBI endoscope that is given as an edge wherein with white light endoscopy you remove the red color of this source and filter the red color in the source and clearly delineate the lesion by magnifying it. You can see once the white light is removed, red light is removed from the WLI, you can clearly blue and green make the surface of the lesion very clear and the vasculature very clear. Added to that was the magnification endoscopes and high definition monitors which further improved our visibility of the lesion. So with the availability of NBI, we are able to characterize the polyps. There are different classifications for the polyp. Each unit uses its own classification. JNet classification is one of the simplest. One here you could see the lesion in white light and on NBI. You can see that the mucosa is almost akin to the normal mucosa. You can say that this is an hyperplastic polyp. You don't have to biopsy a hyperplastic polyp, leave it there. You have a 2A lesion where you have a tubular or villus pattern here and the vasculature is very clear. You can see the continuity of the vasculature, that is regular vasculature here. This is a type 2A adenomatous polyp. Then you go to the type 2B adenomatous polyp where the surface is irregular, the vasculature is again irregular in distribution and irregular in caliber. This is adenomatous polyps with high-grade dysplasia and intramucosal spread. Whereas you have a type 3 polyp where there are loose vessels, the surface is amorphous, there are broken vessels. This is a clear-cut malignancy. So for an endoscopist, it helps in a way that type 2A and type 2B, you can endoscopically remove in the same sitting. We don't have to do a biopsy of the lesion and ask the patient to come back after 3 or 4 days to collect the biopsy report and then decide on the treatment. If the patient is ready, if the lesion is type 2A and 2B, you can endoscopically remove the lesion. To add to the diagnosis of histological diagnosis, we had a volumetric laser endoscopy called optical coherence tomography, which is used by ophthalmologists more often because they cannot take deep biopsies from the eye. The same technology was used in endoscopic evaluation, histological lesions, and then we had confocal laser endomicroscopy. Here the laser beams which are focused through the endoscope go into the deeper layers and histological diagnosis. Studies have shown that the dysplasia can be diagnosed to the extent of 95%. However, the few disadvantages of these confocal endomicroscopy is it requires a specialized equipment and training, and that's why it was limited to large academic centers. It could not be done routinely in all the smaller centers. However, the availability of endocytoscopy changed the way we look at the lesion. You spray the dye over the lesion, and the endocytoscopy, the lesion is magnified to the extent of 400 to 500 times so that you can go deeper into the mucosa and deeper layers of the mucosa. Here you could see that is a histopathological examination of the same lesion, and this is endocytoscopy evaluation of the same lesion. You could see this nuclear pattern is normal, and histologically it confirmed to be a tubular adenoma with a low-grade dysplasia. However, here we have another lesion where the histologically it is reported as well-differentiated adenocarcinoma, and endocytoscopy, you could see that the nuclear magnification, everything is there in cytology. So histologically, you don't have to take a biopsy with the present-day endocytoscopy. You can confirm the lesion on biopsy. But what you require is a histopathologist by your side, or a gastroenterologist should have the knowledge of histopathology, which becomes difficult. So addition of AI tool into the endocytoscopy further eased our diagnosis of histological lesions. And once the endocytoscopy with add-on AI is there, we don't have to take the biopsies. On table, we have the histology, and you can decide what mode of treatment patient would require. So what this has caused, earlier our endoscopic treatment was limited to the luminal gastroenterology. We were managing GI bleed, we were doing polypectomies, we were doing stricture management. Or at the most, the highest procedure that was considered was placing a endoluminal stent. Here you have a colonic malignancy where with an obstruction, where you placed a self-expanding metallic stent and relieve his obstruction. But now with the advancement of these accessories, you have accessories like endoscopic knives, clip devices, over the scope clips, as through the scope clips, and advanced electrocautery units, and endoscopic suturing devices, and advanced stents. These are called lamps, that is lumen opposing metal stents. With these availability of accessories, we are able to enter the second space, that is intraperitoneal space, notes of the procedure which was done, then go to the third space, that is submucosal space, then fourth space. This cholangioscopy and pancreatoscopy is called fourth space, and with the availability of EUS, you are able to go EUS guided procedures, which you can see the other organs through the stomach or colon and do some interventions. So, for example, here you have a large polyp. A few years back, maybe about 10 years back, we would not have ventured to touch these polyps because about 3 centimeters size, and there is always the risk of perforation and bleed in such polyp. We didn't have the accessories to control the bleed and perforation. Now, with the availability of accessories, we are daring enough to go ahead and remove these polyps and avoid surgery. You could see after removal of these polyps, the patient had a massive arterial spurt. But about 10 years back, we would have involved surgeon to control the bleed. But with the availability of accessories, we can control this bleed on table and avoid surgery. So these are the through the scope clips which we apply over these bleeding vessels and control the bleed. And in this patient, we could avoid surgery with the application of these clips. So this was a adenomatous polyps with high-grade dysplasia, but we could avoid surgery with endoscopic removal. So then I would show only a few videos because of lack of time. This was a patient with tracheoesophageal fistula following prolonged tracheostomy and intubation. Normal course, we would have sent this patient for surgery, and surgery, everyone knows of tracheoesophageal fistula closure surgery is a major one. With the availability of over-the-scope clips, we could close this fistula with the clips and avoid a surgery. This procedure is just a 5 to 10 minute procedure, requires conscious sedation, and avoiding surgery is a major advancement in this patient. So you apply the clip and close the fistula. Yeah. This procedure takes just 5 minutes. This is all because of the advanced accessories which we have now. We are able to do other advanced procedures like endoscopic submucosal dissection, endoscopic gastric resurfacing, duodenal mucosal resurfacing, etc., with the availability of accessories. Like early mucosal cancers can be removed by endoscopic submucosal dissection, wherein you inject saline or hyaluronic acid solution below the tumor, lift the tumor and dissect it all around and remove the tumor in toto endoscopically, thus avoiding surgery in these patients. These technologies can be applied even esophageal tumors, colonic tumors, as well as early gastric cancers. So this has been a major revolution because of the availability of the accessories. Other procedure which has been well accepted and a lot of publications are there is endoscopic gastric remodeling for obesity. There are a lot of studies now wherein with the availability of endosuturing devices, you suture the stomach from on the greater curvature side from the fundus to the antrum and reduce the size of stomach. This is almost equal to sleeve gastrectomy which the surgeons perform in obesity procedure. So this has been well established procedure for obesity, and this endoscopic suturing device is being used again in large hiatus hernia closures also. So even in larger perforations, one can use this endoscopic suturing device to close the perforation. However, one disease, type 2 diabetes is one disease where the lot of management changes occurred. Earlier, you were relying on sulfonylureas and other drugs, but now most of the medication are moved to DPP-4 inhibitors, GLP-1 agonists. All these mechanism occur through integrin mechanism, which are secreted in the duodenal third and fourth parts of duodenum. So duodenal mucosal surfacing is a procedure wherein the mucosa of the third and fourth part of duodenum is ablated using special devices, and there are some studies which show that after duodenal mucosal resurfacing, once the mucosa grows, their glucose levels come down, HbA1c comes down, their C-peptide levels comes down, fasting insulin levels, they come down. This is fasting insulin, it is supposed to be because of insulin resistance. HOMA-IR score, which indicates insulin resistance, also improves with duodenal mucosal resurfacing. So what we are waiting for is the availability of accessories which just can target the mucosa, and the burn should not go beyond the mucosal level, because duodenum third and fourth part is one of the most vital parts in the GI tract, and burning beyond the mucosa would result in other complications. This is a procedure which is likely to change the management of diabetes, obesity, as well as fatty liver, because all the three are related to insulin resistance. Small intestine evaluation was eluding us for so many decades. Nearly for 4 decades after initial colonoscopy, we could not do small intestine evaluation. We were going to operating theaters to do perioperative endoscopy if a lesion is seen on a CT scan or barium studies. But now with the availability of PillCam, which was introduced in 2001 and approved by FDA, and later double balloon enteroscope of Fusionon came into the picture in the same year. And single balloon of Olympus came in 2007. With the availability of enteroscope, we are able to detect, diagnose, and cure some of the lesions seen in small bowel also nowadays. So after conquering or maybe succeeding in a few procedures in the first phase, we tried to enter the second phase, that is intraluminal, intraperitoneal phase. NOTES is a natural orifice transluminal endoscopic surgery, and few gastroenterologists performed cholecystectomy, appendicectomy, creating an artificial hole in the rectum or stomach and remove the gallbladder and appendix. But it did not take off as expected due to more rapid progression in the laparoscopic as well as robotic surgery axis. NOTES axis couldn't pace the pace given by the laparoscopic axis, so it slowly faded away. However, we ventured into the third space procedure, and the most widely known third space procedure is POEMS procedure, that is perioperative per-oral endoscopic myotomy in achalasia. And in this, earlier achalasia was treated by balloon dilatation or by surgical myotomy. But now the present studies show that POEM's results are almost equal to laparoscopic LS myotomy. So here you create a tunnel 10 centimeters above the gastroesophageal junction. You dissect the submucosa and then and once the submucosa is dissected, even you can encounter major blood vessels on the way. You have the axaries to block these major blood vessels. The present electrocautery axaries, you can cauterize these blood vessels and go ahead. Once you dissect the submucosa and go 2 to 3 centimeters below the gastroesophageal junction, then you do a myotomy. You dissect the circular muscle of the esophagus and then close the defect. This is like a daycare or 24-hour procedure. Patient admitted on the day of the procedure, and next day you do a contrast esophagogram just to see if there is any leak is there, and then discharge him on the next day. So more than 4,000 achalasia procedures have been performed. POEM's procedure for achalasia have been performed in the last 10 years. It was first invented in 2008. So results of POEMs then made us more aggressive. We are performing G POEMs for gastroparesis, Z POEM for Junker's diverticulum, STIR procedure, that is submucosal transluminal endoscopic resection of submucosal polyp. Esophageal polyp are the ones which are mostly removed by surgeons earlier, but now smaller esophageal submucosal polyp like GIST lesions and all, even rectal lesions can be removed by STIR procedure. PREM procedure is done for rectal endoscopic myotomy for Hirschsprung disease. This is another procedure which is being done in few centers. So after in the third space, we are able to do G POEM procedure, Z POEM procedure, STIR procedure, and PREM procedure for Hirschsprung disease. Earlier, the fourth space, that is intraductal space of bile duct and pancreatic duct, was seen indirectly through CT scan, MRIs, or injecting contrast into the bile duct or pancreatic duct, which had its own complications. But with the advent of cholangioscope, now we are able to enter bile duct and pancreatic duct. Earlier, large bile duct stones, more than 15 millimeter, were handed over to the surgeons to go ahead with surgery. But now, with availability of laser lithotripsy and EHL, electrohydraulic lithotripsy, you can pulverize these stones and avoid surgery. One can use this technology for taking biopsy from bile duct and difficult biliary cannulations. When the stricture is very irregular and tight, you cannot see the lumen. With using a cholangioscope, you can pass the guide wire deeper and do a ERCP procedure later. Even radiofrequency ablation and photodynamic therapy for biliary malignancies can be done through cholangioscope to improve their survival. This is one of our patients wherein we did a cholangioscopy in a bile duct tumor, and histology confirmed the diagnosis of cholangiocarcinoma. The video is not playing, sorry for that. So after that, we had the era of endoscopic ultrasound, where we could study all the layers of the bowel very closely, and even could see beyond the bowel lumen. So through the stomach, you can evaluate pancreas. Through the rectum, you can see all the pelvic structures very closely. So like some of the endoscope EUS guided procedures that gained wide acceptance is EUS-guided pancreatic necrosectomy, wherein you have a wand here, you puncture the wand through the guide wire, with a needle, put a guide wire in, and place a lumen opposing metal stent. Lumen opposing metal stents keep both the cyst wall and stomach wall closed. You can pass an endoscope through this and remove all the necrotic debris. Otherwise, these patients would have required a major pancreatic surgery, which has a lot of morbidity and mortality. Then endoscopists try to venture to do biliary drainage procedures, especially in patients with hilar cholangio or hilar strictures, wherein a guide wire cannot be passed through an ERCP scope into the biliary radicals. One can puncture the left duct branches into the common hepatic duct or bile duct and place a fully covered metal stent across it. And one end of the stent being in the stomach and other end of the stent in the left hepatic ductal system. So thus obviating the need of percutaneous biliary drainage or surgery in these patients. So the other thing we could do is endoscopic treatment of gastric varix. Gastric varix bleed is a nightmare for the gastroenterologist because gastric varices bleed torrentially. Smaller gastric varices can be managed just by injection of glue, but larger gastric varices, you cannot inject more glue. The reason being the glue migrates into the pulmonary circulation and cause pulmonary embolism. So now we have the technology wherein you first inject coil into the gastric varix, which binds the glue and prevents it from causing embolization, and you can treat this. So this is one of our patients who had glue injection in the gastric varix. I won't show you the entire visit. You puncture the gastric varix, then pass the coils through the needle into the gastric varix. Coil size depends on the size of gastric varix. It's calculated about 1.6 times the size of the varix should be the coil. You're releasing the coil inside the gastric varix and then injecting the glue later. So this procedure obviates the need of major surgery for portal hypertension, because most of the causes of portal hypertension are cirrhosis liver, and if you do a surgery for portal hypertension and cirrhosis, it would be just taking care of portal hypertension and not the liver disease. TIPS is another procedure which can be done, which is done by the interventional radiologist, but you have to have an interventional radiologist in your system who can perform TIPS when a major gastric varix bleed occurs. But with the availability of endoscopic ultrasound, most of the gastroenterologists are able to do this procedure. So we can also do chemoablation for cystic pancreatic tumors endoscopically. Ideal is surgery for this patient, but because of the comorbidities or fitness level for these surgeries, some of these patients cannot go ahead with curative resection. Then we can inject chemoablating agents like paclitaxel and gemcitabine into the cyst and reduce the size of the neoplastic cyst. So in the last few years, gastroenterologists have added to the armamentarium, that is EUS gastrojejunostomy. For malignant gastric outlet obstruction, we used to place a stent in the antrum or duodenum, the self-expanding metallic stents, to create the lumen. But these self-expanding metallic stents had their own limitations, that after a few months, because of tumor ingrowth, these stents used to get blocked. But now with the EUS GJ, you can visualize the duodenum. You inject by placing a catheter in the jejunum, you visualize the jejunum, and through the stomach you puncture the jejunum and place a lumen opposing metal stent. This is like surgical GJ. One doesn't have to go for surgery, and GJ can be created by these endoluminal stents. So, ladies and gentlemen, you have seen that with the advancement in diagnostic as well as therapeutic armamentarium, we have moved from palliation to cure. We are able to cure some of these patients because the availability of knives, clips, FTRD devices, and radiofrequency ablation devices. Earlier, we are dilating the strictures and just placing self-expanding metal stents, but you were able to bypass the lesion by doing LAMS-assisted GJ and hepatic gastrojejunostomy. Now we are restoring the function by these suturing system. We are able to do curative procedures like for obesity, and so that these thermal ablative procedures to cure the early malignancies. So as a gastroenterologist, I like this slide very much. All diseases begin in the gut. I advise all of you to advise your patient to take care of their gut by nutrition, whatever it is. And I thank you all for the patient listening. Thank you.
Since this is an honorary oration, there will not be any questions in this. So there was an excellent presentation. You have taken us through the entire spectrum of diagnostic and therapeutic options in endoscopy. And the procedure is so patient-friendly and without the morbidity of invasive surgeries and long hospitalization periods. Thank you very much. I would request the audience to give him a round of applause, please.
That was truly a wonderful oration befitting the Fanidhar Memorial Oration by Dr. D.V. Srinivas sir. Now I would like to request the APRCON members, Dr. Sai sir and Dr. Sushma ma'am, to honor our Fanidhar oration speaker, Dr. D.V. Srinivas sir. Sir will be honored with a memoriam of 10,000 rupees from APRCON Society and a token of gratitude. About the speaker, sir. So, Dr. D.V. Srinivas sir is an MD in General Medicine from Andhra Medical College, Vizag, and has done his DM in gastroenterology from GB Pant Hospital, Maulana Azad Medical College, New Delhi. He further underwent therapeutic endoscopy training in GB Pant, New Delhi. He has 33 years of professional experience in gastroenterology and has 30 publications in various national and international journals. He has participated as teaching faculty in many national and international endoscopic workshops. So we are also privileged to have him as a visiting gastroenterologist in our SCR Railway Hospital. Sir's areas of interest include gastrointestinal diagnostic and therapeutic endoscopic procedures, ERCP procedures, UUS procedures, endoscopic procedures, and therapeutic endoscopy, including pediatric endoscopic procedures. No wonder, therefore, he could deliver us such a beautiful oration befitting this. Ladies and gentlemen, clap for the honorable Fanidhar oration. Yes. Yes, I'm announced. I request APRCON members, Dr. Sai sir and Sushma ma'am, to kindly honor our speaker.
Next, to felicitate the chairpersons, may I request the next chairpersons, Dr. Bharat Lal, PCMD Northern Railway, Dr. Chalagiri, CHD South Central Railway, and Dr. Mamta Sharma, PCMD Central Railway, to please come over to the stage. I request Dr. Bharatlal sir, PCMD Northern Railway, to please felicitate our chairperson, Dr. Sushma Mate madam. Dr. Sushma Mate madam is a PCMD Northeastern Railway. She received Railway Minister Award 2021 for the COVID work. She had been a guide for DNB medicine, and her areas of interest is public health, non-communicable diseases, and geriatric medicine.
She has been a guide for DNB General Medicine students at Baikola Hospital, and she was also the Secretary of API Mumbai branch 2015 to 2017 and Secretary APRCON 2022 to 2025. She belongs to 1991 IRSH batch.
Now I call upon Dr. Chalagiri sir, CHD South Central Railway, to felicitate our chairperson, Dr. Krishna Kumar sir. Dr. Krishna Kumar sir is a PCMD Northwestern Railway. He won Best Paper Award on 2 occasions at national level. He won the GMWR's Efficiency Shield for Health on 3 occasions. He is honored as Vadodara's Pride by Times of India Group for outstanding work during the COVID pandemic. He played a crucial role in Western Railway, winning the MR Efficiency Shield for 2024-25. He has got almost more than 3.5 decades of experience in railways. His areas of interest is healthcare management and community health education. Thank you, sir. Now I call upon Dr. Mamta Sharma, PCMD Central Railway, to felicitate our chairperson, Dr. BP Deka.
Dr. Vishnu Prasad Deka is an MD in General Medicine and is MD of CH in Northwestern Railway. He worked as ADMO DMO physician at BPP SDH NFR and was later working at CH MLG. Now he is MD Central Hospital since 2022, and he was DNB faculty of medicine and lifetime member of API and API Assam. He is the founder member of Guwahati branch API. He belongs to IRHS batch 1991. Thank you.
Lights on.
So, with that, we conclude the Fanidar oration session. Now, the next session will be on rheumatology. So, to facilitate the rheumatology session, the chairpersons are Dr. Bharatlal sir, Dr. H.G. Chalagiri sir, and Dr. Mamta Sharma ma'am. So, I would like to call upon our first speaker, Dr. Kirti Talari Bommakanti. She will be speaking about newer biologicals in rheumatology targeted treatment for better outcome. I request the chairpersons to kindly introduce our speaker.
Dr. Kirti Talari Bommakanti, she is MBBS from JIPMER, MD also from JIPMER, and DM Rheumatology from NIMS. So she has worked in various capacities, senior consultant rheumatologist at Yashoda Hospital, Secunderabad, associate editor of Oxford Medical Case Reports and Rheumatology Advances Practices, Indian Ambassador, Aplar Young Rheumatologist Forum, Executive Committee member of Indian Rheumatology Association, Editorial Board member, Indian Journal of Rheumatology. Her key achievements is Best Outgoing Student in JIPMER 2009, Best Outgoing PG General Medicine 2012, Topper in DM Final Examination NIMS. She has secured 26 medals in MBBS and MD. She got 33 publications in national and international journals, 16 book chapters, editors, and so many trials in rheumatology and associate. She is also editor, Bird's Eye View of Rheumatology, second best clinical research paper, Indian Journal of Rheumatology, 2016. And here is Dr. Kirti Talari.
Thank you, sir. Thank you for the kind introduction.
Thank you.
At the outset, I would like to thank the entire Department of Medicine, Central Hospital, Lalaguda, for inviting me for this talk. It's in fact a great pleasure and a great honor to be here always. For the personal association that I have with this organization, because my mother was working here, my aunt still works in this hospital, my husband was trained here, and I've been an honorary consultant for 5 years in this hospital. So it's a very personal connection that I have, and I'm very honored to be here. Thank you so much. So the topic that was given to me is newer biologics in rheumatology. So here we are talking about how have biologics evolved in rheumatology, and for somebody to understand this topic, it becomes very important to know the immune system as such. So what cytokine is being targeted or what cell is being targeted will be understood only when you know the immune pathway as such. So briefly, we all know that we have an innate immune system and an adaptive immune system. The innate immune system is primarily the NK cells, the macrophages, neutrophils, while the adaptive immune system is the B cells and the T cells. T cells again being Th1, Th2 cells. Th1 cells again activating the B cells, and the B cells in turn secreting autoantibodies which act at different tissue levels, either via complement dependent pathway or a complement independent pathway. This much if you know, you will be able to understand what I'm going to talk in the next 15 minutes. So basically the roadmap for today's talk would be like we would basically defining what are biologics, how are they manufactured, where are they placed in the course of disease modifying agents, a disease-wide snapshot of the different biologics that are available. So primarily I would be talking about rheumatoid arthritis, rheumatoid arthritis, spondyloarthritis, psoriatic arthritis, lupus, vasculitis, and IBD. There are a lot of other biologics also, but I would not be covering it today. What is the safety lens that you should actually be aware of, and the take-home messages? So when we start talking about biologics, the first thing that comes to everybody's mind is they're very costly drugs, because they are manufactured by genetic engineering methods and require cell lines to be manufactured wherein you actually introduce the gene for manufacturing that particular biologic into a cell line. Then they grow in small cultures, then they are transferred into bigger reactors, and then you get an antibody-rich liquid harvest, which goes through a lot of purification, because it is very important to maintain the similarity between batches. And that is why so many things about biologics, that if you start with the one particular brand, you actually can't switch to another brand. You can't do automatic substitution, because there could be change in the manufacturing process which in itself may make the biologic lose its efficacy. Then over time, we've developed other molecules which are small molecules which are called targeted synthetic disease modifying agents, which actually do not act at the level of biologic but at the level of the cytokine of the cell, but they act downstream on the molecules which are responsible for the cytokine to act, which are nothing but the tofacitinib, upadacitinib, which are being extensively used these days. So this is what I'm talking about. This is how a lab which manufactures smaller molecules would look like, where multiple molecules can be manufactured, as against a biologic manufacturing unit where you require multiple reactors and a lot of safety measures to be taken. So before prescribing a biologic, it is not like a basket term wherein if this patient requires biologic, it's always adalimumab or it is always rituximab. What is important to understand is the phenotype of the autoimmune disease is very important to understand. So you should be able to tell whether the patient has rheumatoid arthritis or spondyloarthritis or psoriatic arthritis or lupus or inflammatory bowel disease related arthritis. So just blanket arthritis not responding to disease modifying agents, start biologic is not how we should look at. Second thing is biologics cannot be given especially if there are active infections. So a lot of infective screen is required, including viral serologies, screening for latent tuberculosis, HIV as appropriate, and whenever required, vaccinations have to be given before starting biologics, especially live vaccines, because they cannot be taken during the course of biologic therapy. Next, the baseline labs, because certain biologics cannot be given for certain complications, like if a patient has heart failure or cardiomyopathy, we usually avoid TNF-alpha inhibitors. We look at immunoglobulin levels for individuals who are started on rituximab. So a lot of other labs would also be required. And within the disease itself, for example, if a patient of spondyloarthritis has predominant axial involvement and no peripheral arthritis, then the type of biologic we choose would be different. Even in psoriatic arthritis, if there's more of skin and nail involvement and less of joint involvement, the biologic we would choose is different. So it is actually very important to understand the phenotype of the individual before we start off any particular biologic. And in the future, we are actually progressing to beyond looking at phenotypes, where now research is going on endotypes, where they are actually looking at what cytokine is predominant in this individual, and you decide biologic based on that. And obviously, after that, you have to follow response objectively, because we cannot just rely on what the patient says. Because if you would have started a biologic in an individual with rheumatoid arthritis who already have damage, pain on follow-up also, so it becomes important to objectively assess the individual of arthritis before deciding on which whether you should continue the biologic or start tapering it off. So before I start, biologic is not a stronger steroid, not a stronger immunosuppression. We are actually targeting a single pathway when we are looking at biologic, understanding that that biologic pathway is what is active in that particular individual. So the approved biologic classes that we have as of now are the commonly used TNF-alpha inhibitors like infliximab, adalimumab, golimumab, certolizumab, etanercept. IL-6 inhibitors, which are more used in individuals with vasculitis like giant cell arteritis or Takayasu arteritis, like tocilizumab and sarilumab. Then we have anti-CD20 molecule, the classic rituximab that is used. Then we are also looking at anti-BAF, anti-BLIS. These are cytokines which are responsible for B cell survival, like belimumab, which is approved for lupus, not available in India, and obinutuzumab, which is also approved for lupus, not available in India. Then we have T cell co-stimulatory molecules. So basically, whenever a T cell has to activate a B cell, you require a co-stimulatory molecule also, which is the CD80-86 molecule. And now this molecule can be blocked so that the B cell activation can be blocked. And here we have abatacept, which was once upon a time very commonly used in rheumatoid arthritis, but has lost its grace to the other biologics which have been approved over time. And now it's primarily being used for prevention of rheumatoid arthritis because the risk of infection with abatacept is very low. Then we have IL-17 inhibitors, which primarily work at the level of skin and enthesis axis, especially in individuals with psoriatic arthritis. So here you have secukinumab, ixekizumab, and then a dual IL-17A and IL-17F inhibitor, which is bimekizumab. Then we have IL-23 axis, which is primarily for the gut. Previously, ustekinumab was a drug that was used for the IL-23 axis. Now we have better agents which target the P19 subunit of IL-23, which is guselkumab. Then we have interferon receptor blockers like anifrolumab, which is used for lupus. And here is where the endotypes actually start showing up. What they the type 1 interferon signature in individuals with lupus. And if they have a high type 1 interferon signature, these are the individuals for whom these antibodies are prescribed. Then there are others which are used in gastroenterology, vedolizumab. Yeah. Now I'm going to talk about individual diseases. So rheumatoid arthritis, basically the biological inhibitors. But look at the other drugs that have approved, which is the co-stimulatory blocker, rituximab, which is the anti-CD20 molecule, then IL-6 receptor blockers, followed by sarilumab, have also been approved for rheumatoid arthritis. And specifically, IL-1 inhibitor, anakinra, was approved, but it is no longer used. Abatacept is no longer used. So you have TNF inhibitors, IL-6 receptor blockers, and IL-1 B-cell depletion that is available. In individuals who are seropositive, that is rheumatoid factor or anti-CCP, are in high titers, rituximab works better over the other. It's not like better. Actually, among those individuals, rituximab works better. Usually, if it is negative, rituximab is avoided. how do we decide one over the other? It actually depends on the comorbidities, which I'll be talking about. Then coming to axial spondyloarthritis, again, originally it was always the TNF-alpha inhibitors that have been used. But over time, now it is IL-17 inhibitors have started playing a major role because they have good axial efficacy. However, they cannot be given in individuals who have inflammatory bowel disease. So comorbidity check is very, very important. So we have secukinumab, ixekizumab. So more or less, pretty much more or less, we are still at TNF-alpha inhibitors plus IL-17 inhibitors as far as axial spondyloarthritis is concerned. Other classes of drugs have not been found to be very effective for axial SP, and especially if there's an associated IBD, IL-17 inhibitors need to be avoided. When it comes to psoriatic arthritis, the armamentarium has become much broader. Initially, it was only TNF inhibitors. Then came the IL-12, IL-23 inhibitors, which target the P40 subunit, that is ustekinumab, which works very, very good for skin and enthesis, not very good for the joints specifically. Then came the IL-17 inhibitors, which work for the skin, joints, and enthesis. Abatacept was approved, but now it is no longer used for psoriatic arthritis again. Then now we have the P19 subunit inhibitors, guselkumab and risankizumab, both of which again work very well for the skin and enthesis. And the latest drug that has been approved in 2024 is bimekizumab, which targets both the IL-17A and IL-17F cytokines. Again, very good response for individuals who have skin, enthesial and axial involvement. What is the problem with IL-17 inhibitors? The risk of fungal infections is higher in individuals with IL-17 inhibitors. So that is one thing that we'll have to look at. Lupus is one disease where no biologic has been approved until 2011. And most of the drugs that we actually use in lupus, that is cyclophosphamide, mycophenolate mofetil, none of them are actually FDA approved for lupus. So the only FDA approval that has come over years for lupus is belimumab, which is an anti-BAF inhibitor, which is B-cell activating factor inhibitor. Then came the belimumab subcutaneous option also. Initially, belimumab was given only for non-severe lupus, means it cannot be given for individuals with lupus nephritis. Then came up trials in lupus nephritis where belimumab was given as an add-on therapy to the standard immunosuppression that we give. And this is currently not available in India. In fact, none of the biologics that are approved for lupus are not available in India. Then came the approval of anifrolumab, which was also given for non-severe lupus. It cannot be used for lupus nephritis or CNS lupus. Then came obinutuzumab, which is also anti-CD20, approved for lupus nephritis as an add-on agent to the current standard of therapy for lupus. Now, anifrolumab is available both as IV and subcutaneous. None of these biologics are available in India. They have not lost their patency yet. So, we still stick to rituximab as the only available biologic for individuals for lupus. Though it is not FDA approved, it is usually given off-label and it works pretty well for individuals, especially with hematologic and renal manifestations. Then we have vasculitis, which are, again, there are three major ANCA-associated vasculitis that we know of, that is GPA, EGPA and MPA. Then we have the large vessel vasculitis, GCA and Takayasu. Medium vessel vasculitis usually takes all the drugs, whatever we use in small vessel vasculitis is usually translated to medium vessel vasculitis because it's not very commonly seen. So in the small vessel vasculitis for GPA, that is Wegener's, and for MPA, that is microscopic polyangiitis, the most commonly used biologic for both induction and maintenance is rituximab. While when it comes to large vessel vasculitis like giant cell arteritis and Takayasu, it is usually IL-6 inhibitors or anti-TNF-alpha blockers. When it comes to EGPA, there are other options, that is eosinophilic granulomatous polyangiitis. There are other options like mepolizumab, benralizumab, which block the IL-5. C5a receptor antagonist avocapan was released as a small molecule as an alternative to steroids in individuals with small vessel vasculitis. Though it's not exactly a biologic, it is something like tofacitinib, so I'm talking about it here, but it has been withdrawn from the market for its safety concerns. Then coming to inflammatory bowel disease, Previously, it was anti-TNF alpha inhibitors. In fact, even today, predominant role is played by anti-TNF inhibitors. The newer drugs that have been approved are vedolizumab, ustekinumab, which acts via the IL-23 axis, but targets the P40 subunit, which is also a part of IL-12. So, P19 targeters like risankizumab, guselkumab are the newer IBD molecules that have been approved. IL-17 inhibitors specifically should not be given in individuals who have associated inflammatory bowel disease. So these are the different biologics. I know too many names, too much to absorb. So, but what is more important is before we start a biologic, as I said, screening before the first dose itself by doing a chest X-ray, screening for latent TB, doing HBV status by not just checking HBsAg but also looking at the anti-HBC, anti-HBs status, vaccination status also needs to be looked at. Then HCV, HIV by risk needs to be evaluated, and all the baseline investigations that need to be done. All vaccinations are to be given before starting the biologic, but if there's an emergency, you could also always give all the biologics, all the vaccinations after starting the biologic also, except live vaccines. If the patient is undergoing a major surgery, if the patient has serious infection, uncontrolled diabetes, sepsis, unexplained fevers, there's a doubt of active tuberculosis, neutropenia, or there is a significant risk of hepatitis reactivation, do not consider biologic at that point of time unless that particular situation is tided over. Then, depending on the biologic, the monitoring also changes. For TNF inhibitors, we always look for signs of tuberculosis. We look for, rarely demyelination can happen, and heart failure is one caution that has to be played with anti-TNF inhibitors. With IL-6 receptor blockers, that is tocilizumab, you have to primarily look at lipid profile, which is one thing which a lot of people do not do, and transaminitis, because once biologics start, a lot of people think that nothing will happen to the blood counts, creatinine, liver functions, unlike what happens with the conventional drugs, that is methotrexate, leflunomide, or other drugs. But tocilizumab is one drug which can cause transaminitis, acute liver failure, can cause hypercholesterolemia, so that has to be monitored. Rituximab again can cause severe neutropenias, can decrease the immunoglobulin levels. IL-17 inhibitors like secukinumab, as I said, can increase the risk of fungal infections and have to be very careful in individuals with IBD. So before, the most important point here is patient has to understand the caution that they need to take when they take biologics. They should understand that biologic is not the one-stop solution for their disease. Biologic is not a cure for autoimmune diseases. So many patients come to us telling us that there is a injection, if probably you start the injection, I will not have the disease anymore. So the most important thing that should be driven to them is biologics are something that are given in the long run. Yes, we can taper them over time, but withdrawing them sometimes may not be possible. And sometimes we may have to continue the conventional DMARDs despite giving the biologic. That is one point that has to be driven into the patient's head very, very clearly. And there are a lot of other new biologics that are being developed, like the ianalumab, which is being used for lupus nephritis, where our center is also a part of this trial. Litifilimab, which is again targeting the B cells. Then we have rosnilimab, which targets the T cells by making sure that the Th1 cells actually are killed earlier. So the activated Th1 cells are killed earlier. Then a lot of other antibodies in IBD and EGPA, which target the IL-5. What is more important is now we are moving from biologics to cell therapies also. So a lot of people would have heard about the CAR T cells, which are now successful in the oncology division. But they are also being tried for lupus and rheumatoid arthritis with positive responses, but also with long-term negative side effects. So that is something that we'll have to look at, because there's a huge difference between immunology and oncology, like where you're targeting a foreign cell versus where you're targeting your own cells. So genuinely what is new? Basically we are looking at targeting multiple pathways. We are looking at which organ needs to be looked at specifically. We are looking at how much we can reduce the steroids, cell therapies which I've spoken about, and accessibility is increasing because of the number of biosimilars that have come over. So these are the different biologics that have been approved over time. And so basically biologics are targeted proteins. They are not stronger immunosuppressive agents or just not stronger steroids. You have to choose by the disease domain according to which organ is involved. TNF inhibitors remain the foundation for a lot of diseases, but a lot of other cytokine pathways have also been targeted. Screen for infections, look for comorbidities, look for contraindications before you start. Know the specific complications of each biologic before you start a biologic. Though the pipeline is very exciting, not all of them have been approved. Safety issues are a major concern. Thank you. And having said this, I would just like to put a point for all the postgraduates that a lot of things are coming up where you do 3 months online fellowship in oncology, 3 months online fellowship in rheumatology. MBBS graduates can do fellowship in gynecology. Do not go for these shortcuts because medicine is only learnt by clinical training. Thank you.
So that was a very good session by Dr. Kirti ma'am about newer biologics in rheumatology. I should say it has made my job easy because now we have prepared for BAFF inhibitors. Tomorrow in lupus nephritis we will be discussing it in great detail. Now I would like to call upon the next speaker, Dr. Satish Pradhan sir. He will be delivering a speech about connective tissue disease and ILD autoimmunity that breathes beyond boundaries. I request the chairpersons to kindly introduce the speaker. Let us start.
Dr. Satish Chandra Pradhan, he is Medical Director, Central Hospital, East Coast Railway. He is trained in HIV medicine from Ruby Hall Clinic, Pune, infectious diseases from PD Hinduja Hospital, Mumbai, and rheumatology from Lucknow. He has received numerous awards, and one of them is for outstanding services in Indian Railways at different levels, from DRM, PCMDs, and GM. Twice he has got GM's award in 2003 and 2005, very close. Received Railway Minister's Award in 2008. He is a member of API, IRA, RSS, DI, and LAI. He is 1993 IRHS batch, and he has 33 years of rich clinical experience in railways. Dr. Satish, please.
Thank you, ma'am. Respected chairpersons, respected seniors, and my dear colleagues. At the outset, I thank Dr. Sai and his team for giving me this opportunity. So coming to ILD, ILD has been described since 1930s, but there was no clear-cut definitions for this disease. Even when we are undergraduate, even postgraduate in 1990s, we had only one disease we were coming across, that is idiopathic pulmonary fibrosis. There was no clear-cut definitions. The only in 2002, American Thoracic Society and European Respiratory Society, they standardized the ILD classifications. Then there has been a lot of change in this field. So if you look at the global burden, it was 52 per 1,000 population in 1990, which rose to almost 57 worldwide. Because in 1990, if you look at the Indian context, it was pre-1990, it was 10 to 20, which rose to almost 49 to 98. In Western countries, it was earlier detected because of widely availability of HRCT. But in India, HRCT came to us for thoracic or for respiratory disease late. Though CT scan was available, it was mostly for neurologic or CNS neurosurgical procedures. So that was the context. But now I think most of us, our physician must be dealing with ILD. If they are not dealing with, please look for this, because you have a year of suspicion. So out of all the ILDs, if you see, One of the most common cause of ILD is CTD related ILD, that is connective tissue disease related ILD. It is at 27%. But in India, hypersensitive pneumonitis is more because of pollution and other infections. But why you should detect when you have a ILD, why you should find out whether it is a CTD related ILD or not? Because if you look at this graph, the prognosis is much better if you diagnose and treat a CTD related ILD rather than a idiopathic interstitial pneumonia. So if you diagnose it lately, then you lose actually the period of giving him a life-saving immunomodulatory therapy. So in 2025, actually ERS and ATS has classified the CTD ILD or basically the ILD mostly based on the HRCT patterns. So it is no more only interstitial patterns, but you have alveolar filling patterns, mixed pattern and unclassifiable pattern. But mostly CTD ILD will have either a UIP pattern or a NSIP pattern and rarely a LIP pattern. So when you have a patterns you do a HRCT and you have a UIP or NSI pattern, you should have a very strong suspicion of CTD ILD and try to find out the disease. So these are mostly 5 autoimmune diseases which cause most of the ILDs. The most common is systemic sclerosis. Antisynthetase syndrome is a type of myopathy where 86% of them can develop ILD. In systemic sclerosis, 65% of them can have ILD. And polymyositis, dermatomyositis 43%, MCDD 40%, Sjogren's disease 25%, and RA 10%. RA we are getting off late because we have a better management strategy, so we are not getting more of ILD in RA. But thing is that in 92% of the cases, either when you diagnose ILD, then you look for CTD, it is there. But in 8% of the cases, ILD is diagnosed much before CTD, much before means almost 5 to 7.4 years. So when you are diagnosing a ILD, but you are not getting any clinical features or autoantibody of CTD, then regularly you have to do this follow-up and when you find it, because if you treat it in a immunomodulation, then you can give the benefit. So then how you suspect connective tissue disease in a case of ILD? Then skin is one of the most important examining finding or window. That if you get a Raynaud's phenomena, you can suspect a MCTD or a scleroderma. If you have sclerodactyly, you have scleroderma. Then see you have Gauton's papule, you suspect a dermatomyositis. If you have heliotrophus, you suspect dermatomyositis. Mechanic shunt, you suspect a antisynthetase syndrome. Then beside the skin, you can also examine the muscle for proximal myopathy. Joints, of course, arthralgia, polyarthralgia can occur across the connective tissue disease spectrum. Then if you have Zika symptoms, then you suspect Sjogren's disease or RA. Then this is an entity where actually you have a ILD, but you don't have a very clear-cut picture of connective disease, or you don't have a autoantibody for that. So this interstitial pneumonia with autoimmune feature was this EA was coined in 2015, where if you have a ILD but you don't have a very clear picture of a CTD, but if you have one or two features, like we have only mechanic shunt, then you have a serologic domain, only ANA is positive or only anti-DS DNA is positive, then you suspect that this may have a EA, because if you treat them also, the prognosis is much better than idiopathic pulmonary fibrosis. Though it is not better than CTD ILD, but you have a better prognosis than IPF. Then when you suspect it, what are the antibody you have to do? You have to do a ANA, then a extractable nucleic antigen like SCL70, Rho60, La, RNP, Smith, Jo1, rheumatoid factor, anti-CCP, anti-DS DNA. But if you have some disease, then you can extended panel, like sometimes myopathy, we have to do a myopathic specific antibodies like MDA5 and all those things. But anti-Rho52 is another antibody which can be positive in multiple diseases. It can be positive in RA, it can be positive in Sjogren's, it can be positive in myopathy. This does not, it is not a very diagnostic antibody, but it is a prognostic impact. Because if you have a Rho 52 positive in any of the CTD, then the prognosis is bad. So it gives a rather faster ILD progression, more severe and widespread lung disease, shorter lifespan and increased mortality. So in any of the disease, if your Rho 52 is positive, then you have to be careful. Then another is anti-MDA5, which is in myopathy specific antigen. This is found mostly in dermatomyositis. They have a phenotype of skin vasculopathy, ulceration. They have the mostly rapidly progressing ILD. If you get somebody MDA5, probably you have to be very careful and send him to a tertiary center because they may go bad in hours. Then you have MPO ANCA. Lot of time idiopathic pulmonary fibrosis we are diagnosing in an older case where you are not getting any other antibodies. But now they have find these people we are giving only antifibrotics, thinking that it is a IPF. But now they have found that if you do a MPO ANCA in these patients serially, sometimes you may get, then you have to treat them with immunomodulations. Then anti-ACL70, if it is positive in a scleroderma base, they are high risk for diffuse cutaneous systemic sclerosis as well as severe fibrotic ILD. So once you have diagnosed this is a CTD ILD, then how to monitor or how to approach them. But if you have an alternative diagnosis of ILD, then you can do a BAL to exclude any infection. But otherwise, you have to look at the clinical risk factors. Rheumatology is a branch where clinical science is very important. You may have anti-dsDNA negative lupus. You can have RA negative rheumatoid arthritis. So this is very important. So clinical risk factor is important. Then you do a lung function test because this is a restrictive type of lung disease. You have to do a DLCO along with FBC. Then you have to have the HRCT because the diagnosis of ILD is according to the HRCT. Then 6-minute walk test at oxygen desaturation is a bit in cases of CTD ILD because you may have arthritis and myopathy where the patient may not be able to walk properly. So then 6-minute walk test may not be very important. Then patient reported outcome measures. So when you have certain types of HRCT findings, then you suspect ILD. When you are doing because you are doing diagnosing a ILD from HRCT. So if you are finding certain features in HRCT, then you suspect that it may be a CTD ILD. One is called anterior upper lobe signs. Then exuberant honeycombing signs if it is more than 70% of the fibrotic area. Then there is a straight edge signs, that sharp geometric demarcation between fibrosis and normal lung at the bases. Then a supportive clue, if you have a dilated lower esophagus, it may give a clue to scleroderma. Then among the patterns actually, only RA gives a UIP pattern. Though we know that UIP pattern have a bad prognosis, but if you have a RA with UIP, it is better than IPF. Because IPF is the disease where you get the UIP pattern. Otherwise, all other diseases in CTD ILD, you will have a NSIP patterns. So, but if you are finding these things, particularly pneumomediastinum, this give a red alert, probably you are dealing with a case of anti-MDA5. So if you are getting this, you have to be very careful and upgrade your all the skills and So if you have, I am going back, if you diagnose a connective disease, in which cases you have to look for ILD and how to look for ILD. So if you have a systemic sclerosis or MCTD, at the outset you have to go for screening for ILD. If you have a myopathy, then if your risk factors are present, then you go for a screening. But I think if you have a myopathy, you go for all of them for screening with HRCT. If you have no risk factors, you don't do. In cases of rheumatoid arthritis and Sjogren's disease, there is a conditional recommendation. If you have a risk factors are there, they are high risk, then only you go for ILD screening. So what are the risk factors for ILD? In systemic sclerosis, if it is a longer disease duration, there is increased KL6. If the presence of ACL70 is there is a diffuse cutaneous scleroderma or higher modified Rodnan skin score, then these are the risk factors. They may go for ILD, though, then you have to screen for them. In rheumatoid arthritis, if it is a older age, male sex, there is smoking history, increased ESR, presence of anti-CCP and high titers of rheumatoid factor, and higher articular disease activity. In myopathy, older age, increased CRP, ESR, presence of anti-synthetase antibody, anti-MDA5, anti-Rho52. And anti-synthetase syndrome, if you have to look. In clinical homeopathic dermatomyositis, you have to be careful. They may not have any muscle weakness, but they can have only skin manifestation. In Sjogren's disease, if it is an older age, male sex, increased CRP, presence of anti-Rho52 and presence of extrapulmonary features. Because Sjogren's disease has become very common. If you are not looking for them, anybody, any female particularly coming with weakness, back complaints, if you screen them, you find a Sjogren's disease. Then this is the same slide here, but you have to be very careful of MDA5 phenotype. Then how to monitor? So monitoring is according to the disease and according to the risk. If you have a high risk or a low risk, high risks are mostly shorter duration here, then low risk will be here. So mostly you will monitor, you will do a lung function test, you do a HRCT, you do 6-minute walk test, and these are the three basically tests you have to do. So how frequently you have to do? If it is a high risk patient, mostly lung function you will do 3 to 6 months. If it is a low risk, 6 to 12 months. In HRCT, mostly at 1 year. But any time if there is a poor progression, if any time patient is deteriorating, at that time you have to do a HRCT or all these tests. Then this is the natural history. Some patients without even treatment, even with treatment, they will rapidly progress like I told anti-MDA5. But there will be some patients who will be responding to immunomodulation but not to the full extent. But there will be some patients who will be non-progressive. So you have to basically know the phenotype. So this is another classification. If you have diagnosed CTD fast, then if he does not have any symptoms or any HRCT features of ILD, then it is classified as CTD ILD 0. Then if you have only HRCT pictures but no clinical features, then CTD ILD A. But if it is a symptomatic like he is having dyspnea, even HRCT pictures are there, then CTD ILD B. But CTD ILD 0, if he is a connective disease, but there is no ILD features, what you will do? There is primary prevention. So smoking cessation, prevention exposure to pollutants, allergens, weight control and vaccination. Because obesity can increase basically ILD. So these you have to do even they don't have a ILD. Then if you have a CTD ILD A, then you have to control the primary disease. If you have a rheumatoid arthritis, you have to control the primary disease. If you have a Sjogren's disease, you have to control the primary disease. You don't have to give specific treatment for the ILD. But if you have a full-blown ILD, then you have to treat accordingly. So treatment is quite simple. So you see So glucocorticoids will be the backbone because they act very fast, except in cases of systemic sclerosis. You don't give high dose of glucocorticoids, that you have to know, because there is a chance of scleroderma renal crisis. So that is why you prevent that. Otherwise, across the board, you see mycophenolate is the drug of choice. Whether it is mofetil or mycophenolate sodium, then it doesn't matter actually. But in case of systemic sclerosis, if you have a lot of skin involvement, probably tocilizumab will come as a fast year. But still in India, we use mycophenolate in all of the EA. And conditional option will be nintedanib, azathioprine, JAK inhibitors. These will be secondary EA. So once you treat with both steroid and mycophenolate, if patient is responding, then go for a lower dose of steroid. Now rheumatology, the science of rheumatology, how low dose steroid we can go. So when to start antifibrotics? Because now we have a lot of exposure in antifibrotics after COVID. So when to start in cases of CTD ILD? Whether you should start upfront or you have to wait. So you have to basically know whether it is a progressive pulmonary fibrosis. Once you try treatment with mycophenolate and steroid, then you see whether the patient is progressing clinically or not. If there is a oceanic respiratory symptom, or there is a absolute decline in lung function like FVC more than 5% or DLCO more than 10%, or there is new or worsening imaging evidence in HRCT. This is the criteria for a progressive pulmonary fibrosis. If you have 2 out of 3 of them, then probably you have to uptitrate your treatment. So these are the criteria where you have to start antifibrotic at the outset. That is, if there is a significant fibrosis more than 10 to 20% of the lung volume on HRCT, then the patient is significant breathlessness with rapid decline in DLCO and a high likelihood of progressive course, or some cases of RA-ILD or SSC-ILD with severe predominantly fibrotic pictures. In this type of patient, you have to start antifibrotic from the beginning. So if you are not responding to your ideal treatment, like you have given glucocorticoids and mycophenolate up to 3 gram per day, then what you will do? If there is a progression in first line therapy, add or switch therapy. So normally what we do, probably in most of the ILD, we give rituximab as the second line of drug. It was, in fact, earlier it was given as the first line of drug in scleroderma, and here we give as a rituximab as a second line of drug, and addition of nintedanib. Rituximab has become very cheap. To railways it cost only 6,500, and you give only 2 doses 15 days apart. Then you decide after 6 months whether you have to give or not. Then nintedanib, in those cases you have to start if they have a particularly fibrotic phenotypes. Then if still patient is bad, probably you have to think of lung transplantation. But if it is a severely disease like rapidly progressive ILD, I told about anti-MDA5, then probably you have to start with 3 drugs, IV glucocorticoids, pulse of methylprednisolone, then with 2 additional therapy like rituximab. If patient is very bad, I will give IVIG. Then JAK inhibitor has this role in particularly in this set of patient as on date. Probably in future you will have more indication of JAK in other ILDs. But what is defining severe disease? FVC is less than 50%, DLCO is less than 40, 6-minute walk test less than 250. So in those cases and anti-MDA5, you have to start with 3 drugs. So this is the new drug which is not yet available in India. This is called nerandomilast. So in the Fibroneer IPF trial, this was the trial done for IPF, but in this cohort, actually 30% people are there with CTD-ILD, which showed actually definite benefit, because nerandomilast is not only antifibrotic, but it is also an immunomodulator. So it acts in dual way. So probably in next year it will be available in India. Then we have connection, gut microbiota is discussed in across all the diseases now. So you have also, there is altered gut microbiota in ILD, in CTD, ILD and DA. So, but we don't have any therapeutic target as on date. And no talk is over if you don't discuss about AI. So how AI helps in ILD solutions? Basically, they quantify the disease and the qualify or the patterns of the, like this picture I showed, some areas like greens are normal lung tissues, then reds will be fibrotic issues, somewhere will be honeycombings, or somewhere will be only ground glass opacity. So they will quantify how much it is embedded, and there will be algorithm way. If you give everything like your risk factors, clinical risk factors, you give your autoantibody titers and this thing, and your imaging yet, probably they will be able to tell how to manage the case. Thank you.
Connected to tissue disorders, and especially the interstitial lung diseases. These are the areas in clinical science in which most of the general clinician remains unaware. That way, Dr. Pradhan, you have given a very excellent presentation. It was well structured and clinically insightful. Thank you very much. And also, thank you very much, Dr. Kirti. You have given an excellent presentation on rheumatology. Thank you very much.
Just I want to add to Dr. Kirti's presentation. I really marvel the way she could pronounce all the umags. And actually in our railway hospitals also, we are like, there is intense research is going on. So daily, very frequently new molecules are coming. And as we know, we in railway setup, we give our AMIs, so annual medical indents. So 1 year before itself it is prepared, and sometimes the prescription patterns changes. So for all my physicians who are available here, that these drugs, we should talk to the material managers, and these drugs should be indented on procured on rate contract method, so that because Dr. Kirti has already told you, we are always grumbling why they are so costly. Now today you told that because of the peculiar processing they are very, very costly. So we should try to procure them on rate contract method, so that even if we have to switch on to the newer one, so it should not be that a stock of older one is already there, which is also very costly, and now we are going for a newer one. So this is my advice to all the physicians who are railway physicians who are present there. And your checklists were very good, so that they were very practical, so that everyone can implement them whenever rheumatologist is diagnosing and they are writing the drug. And for Dr. Satish, you have done like it was like from pathogenesis till AI. So everything was told, and in a very, very lucid manner. Thank you, sir.
Thank you, ma'am.
So any questions or comments from the audience, please?
Please pass the mic.
We investigate, all the investigations will be negative. So we send to some rheumatologists, all the physicians, whoever is available, or even the junior DNB PGs, they write left and right tofacitinib tablets and all. Patient also comes back, they are having very good relief and all. Whether proper investigations have been done, whether they know the side effects of all these things, I don't know. That is one thing. Second case, almost at 45 years with ankylosing spondylitis, where the joints have already been this thing, what is the need for a biological at that age? That I want an expert opinion from this, so that it will be useful for everyone.
So for the first question, sir, I personally call tofacitinib as being used like a toffee. Because it is one of the brand names also. So basically, tofacitinib is not the first-line therapy for arthritis as of date. It is given only after conventional synthetic DMARDs fail. And tofacitinib has a lot of side effects, like it requires a lot of screening, and we've seen patients who develop severe thrombotic complications. Beyond zoster, because zoster we see left, right and center with tofacitinib, but beyond that we've also seen pulmonary thromboembolism, arterial thrombosis with tofacitinib. So it is something that cannot be just prescribed like that. And I've also seen prescriptions where it is given like a steroid, tofacitinib 5 mg twice daily for 1 week, then 5 mg once daily, then stop. So that is not how it should be used. So ideally more knowledge is required on that. Coming to the second question, ankylosing spondylitis at 45 years, can they be given biologics? It actually again depends on the individuals. If the patient still has active inflammation, because though we say 15 to 40 years is the age of onset, inflammation can be progressive beyond 40 years also. So we decide completely based on the CRP, the ESR, patient's symptoms and how well they are responding to NSAIDs, because if it is only mechanical backache, actually they don't respond so well to NSAIDs. If the response is excellent, probably there's still an inflammatory component, where again still tofacitinib has taken over biologics here. So we initially start with tofacitinib if the comorbidities allow us to start, and then consider biologics as the next option.
Yeah, but
Thank
just
you, sir.
because tofacitinib sir told, I have seen these have become GPs, and I have seen sir is a orthopedician. I have seen more orthopedician writing tofacitinib. So because after people are afraid to all the people are afraid to give methotrexate, because methotrexate they have something like that. This is very toxic drug. What we use day in day out. Actually, then the next line of was basically biologics. So biologics were very costly, so nobody was writing. Now because tofacitinib is available very easily, people are starting with tofacitinib. But be careful, because what he told actually, in an elderly fellow with a diabetes, this type of where thrombotic chances are, or even atherosclerotic is there, you have to be very careful. And if you write tofacitinib and you have a zoster, then now you see the anti-zoster vaccine is very costly, like 10,000 rupees per dose. So it is very costly. And in APRCON, probably yes, tofacitinib has taken over. But if you have an elderly patient, then you have to. Because I have now 2 officers who have diagnosed at the age of 50. So you have to be, probably you have to give biologics here. And nowadays biologics have, because in railway hospital, if you have 3 or 4 biologics, it will suffice to treat most of the cases. If you have etanercept and adalimumab, then you have rituximab. These 3 or 4 will be sufficient. Guselkumab, and mostly it is basically a skin. If you have a skin domain, this is more beneficial. Otherwise, if you have basically arthritis, then probably anti-TNFs are still the best.
Yes.
Hello, sir. One question to you. Are there any isolated cases of mechanical hands, or it is always associated with ILD only?
Associated with?
ILD. As you said.
No. When mechanics hand are there, it is a very suggestive anti-synthesis syndrome. So in those cases, ILD is very required. Now recently I came across a patient who came with a cough of only 7 days. Luckily, my GP has done a chest X-ray. I suspected some shadows in the base of the lungs. When I did HRCT, it was ILD. When I asked him, he was being treated for skin ailment in AIMS Bhubaneswar for last almost 10 years. When he was taking steroid, his lesion was improving. Then he was. So now I suspected anti-synthesis. When I sent for a autoantibody, it was anti-synthesis positive. Now we have started mycophenolate and low dose of steroid. Now his skin lesion has gone and he is better.
Because I have seen cases with mechanical hand for 6 months, manifestation only for 6 months. Thereafter, for last 6 years, not having, and he has not even progressed to ILD also. So that's why I wanted to know whether it's...
no, it is mechanics hand. It is not a mechanical hand.
Mechanics
Please
hand.
don't confuse.
No, mechanics hand.
Mechanics hand is very specific lesions.
Okay, fine. Thank you.
Yes, sir. Further question.
Ma'am, I have just one question. It is basically practical. So when the patient is on biologics or immunosuppressants and they develop some serious infection, basically managing the ICU. So what is the guideline? Like how long will you stop and when will you restart, and how will tide over the infection state, and if the patient is having a disease actively?
Unfortunately, what happens is biologics usually have their effect for 5 T-halves. So if the patient has already taken adalimumab 1 week back, the effect of biologic would last during the episode of infection also. So usually only after the infection completely subsides. For example, for fungal infections, it takes a longer time to subside. Only then can we actually restart the biologic. But whatever said and done, infection exists during the time when you're treating the infection also.
So my question is by marker, blood test we have to do before establishing that the infection has completely subsided, just like that, or we can just okay, thank you.
One of my case, Central Hospital Hubli, 2016, sir. The patient used to come to dermatology OPD for exfoliative dermatitis. Almost he used to be in the sick list for 3 days in a week, 4 days in a week. Associated, he had a bronchial asthma also. To December 3rd of 2015, he was admitted in medical ward. So 2004, he came to the clinic. I got him investigated. So everything was normal except the ESR. ESR was 32 millimeter of mercury. So why the ESR is raised like that? I investigated. I asked him to go for ESG abdomen. When he went for ESG abdomen, renal cell carcinoma is turned up. Renal cell carcinoma, renal mass was there, middle of the right kidney. I took him to the surgeon. He said, unless otherwise disproved, it is a renal cell carcinoma. Then I consulted the parent, the wife and children. They were in Bangalore. I called them twice. I consulted them. Finally, they agreed for the nephrectomy. We did it on 14th December of 2015. Within 7 days, skin lesions disappeared automatically. Bronchial asthma also resolved. Within 21st or 22nd of December, he came to me. There were no skin lesions. Even they didn't have any asthmatic thing also. So one ESR gave me a clue that something is going wrong. So what I mean to say is that whenever you're investigating any patients, please give due importance for all the investigations, all the reports. Simple ESR as teach me a diagnosis and nephrectomy we did and patient survived. This was 54 years and workshop employee in Hubli. This is my experience. In that case, it happened in Central Hospital, Hubli.
But please don't do a panel.
Thank you, sir.
Okay. More yes. So now people go molybdenum, selenium, everything get checked. So
this is paraneoplastic syndrome. Finally, I presented this paper in my dermatology conference of Karnataka and international conference also I presented in Bangalore. This is an example of paraneoplastic syndrome.
Thank you, sir. Due to paucity of time, we are not taking any more questions. I would request the chairpersons to kindly felicitate our speakers for the session. Dr. Kirti and Dr. Satish Pradhan may please come onto the dais.
I request the chairperson to felicitate speaker, Dr. Kirti. working as gynecologist in different railway hospitals. Areas of interest is adolescent health certified trainer of Heartfulness Spirituality System since 2017. Welcome, madam.
Tertiary Care Hospital in International Journal of Life Sciences, Biotechnology and Pharma Research Efficacy and Safety Protocols. And her areas of interest are bone marrow failure syndromes, including aplastic anemia, MDS, myeloproliferative neoplasms, and bone marrow transplantation and bleeding disorders. Welcome, Dr. K.K. Radhika Garu.
Good afternoon. Thank you, ma'am, for the kind introduction. Thank you, organizers, for giving me this opportunity. It's indeed a privilege for me to be on this platform. So I'm a hematologist at Nizam's Institute of Medical Sciences. I'll be taking you through a short journey of quality of life in hemophilia in the next 15 to 20 minutes. We all know that some time back, the treatment is mainly focused on the treatment of the disease, the treatment of the symptoms. That was the past, but it's no more the future. The present and the future, it's not just enough that we treat the symptom, we treat the disease. It's also important that we address the quality of life of the patient and give him a life as normal as any other normal person. It applies for all fields and equally it applies in hemophilia too. So hemophilia is one of my favorite topics of hematology. So as we all know, the audience knew, I assume that the audience know what hemophilia is. Hemophilia is a congenital bleeding disorder where the blood does not clot because there is a deficiency of certain coagulation factors in the patient. The most common is the deficiency of factor 8 and factor 9, which we call as hemophilia A and hemophilia B respectively. The treatment of this condition is we replace the factor concentrates, whatever is missing in the patient. So in hemophilia A, the treatment is replacement of factor 8 concentrates, and in hemophilia B, it is replacement of factor 9 concentrates. Nothing has evolved in an overnight. A lot of developments, a lot of modifications and changes have happened, and then we have come to the near perfection regimens. The same hold for hemophilia too. So how did the treatment evolve over all these years? So it all started that back in 1950s, when a patient was harboring a bleeding disorder, he used to be treated with blood transfusions. Then they felt that why should I be giving the whole blood? My target is only to replace the factor concentrates. I don't need to give whole blood. I'd rather give only FFP and cryoprecipitate, which are rich in factor concentrates, and get away with the bleeding. Then the researchers, they realized, why should I be giving an FFP and cryoprecipitate and overload and fluid overload the patient? I'm interested only in the factor concentrates. Then came in the plasma-derived factor concentrates, which were extracted from the FFP and cryoprecipitate. They used to freeze-dried those factor concentrates and store in the refrigerator. So a small volume, 3 to 5 ml of small concentrate would suffice to curb the bleeding. When it started, the factor concentrates were available in the market. They realized that over a period of time, the patients were contacting blood-borne diseases because plasma-derived factor concentrates are human derivatives. Then came into the market the recombinant or technologically derived factor concentrates. So in 1992, the first generation recombinant factor 8 came into the market, which revolutionized the hemophilia care, and then it went on modified into a second generation, third generation, extended half-life molecules and all. Still, we are humans, we are never satisfied. Because these concentrates needs to be given frequently. They need to be given through intravenous route. They carry a risk of inhibitors. So there are some pitfalls with existing molecules. So then came in something called the non-factor replacement therapies like emicizumab. And then in future, still we are not happy with the whatever kind of advancements we have today. In future, we are looking forward for gene therapy where 1 or 2 injections into our body, into the body of the patient, and the patient is out of the disease and he's like a normal patient. So this is how the hemophilia care has evolved over the centuries and years. So with these all advancements, the lifespan of hemophilia patient over the years, where in 1900s patient used to live only 13 years, 1960s it went up to 20 years, and today in 2026 we are looking at a hemophilic patient with a normal lifespan, not only a normal lifespan, also a normal quality of life. So the present day, with the advancements in the hemophilia care, we are looking forward for a normal life expectancy as compared to 11 years in the past. In spite of all this advancement, with the existing factor concentrates available in the market, we still have challenges. We still have some unmet needs. What are these unmet needs? The unmet needs are, though we have the most advanced factors today available, still we are not into zero bleeds. Patients still do bleed. So there is still an inadequate protection against the bleeds. Multiple bleeds, recurrent bleeds, do damage the joint and affect the joint health. And when the joint health is damaged, obviously there's a physical burden on the patient. And overall, this leads to a generalized compromise of the general quality of life. And then also these have to be administered intravenously, and there is a burden of administration. So these are the kind of unmet needs what we have today, which overall impair the quality of life of the patient. So today I'm looking forward for a molecule which can address all these issues and make sure that the quality of life is, because our talk today is predominantly concentrated on the QAL. So patients with hemophilia, that is a bleeding disorder, experience many challenges throughout their life. The challenges are in terms of emotional, physical and logistical. What are the emotional challenges? Many patients with hemophilia have demanding treatment schedules that may disrupt their daily life because these patients have to come very frequently to the hospitals to take the injections. They are given intravenously. As a result, there is missing school, work, social and recreational opportunities. More can have a negative impact on their mental health and lead to feelings of social isolation. They experience negative impacts on their self-perception, social life and relationships because of the loss of this work, school, etc. The physical challenges include patients live with daily concerns about their levels of bleed protection and are often aware of their vulnerability to breakthrough bleeds. So even if he takes the injection, the patient always somewhere back of the mind, he lives with a fear that any time he may bleed in the deep of the sleep, or he may bleed during his journey tomorrow. So he always will be under a mental stress. Periodically, they experience varying degrees of pain during bleeding events. Logistical challenges, yes, there are logistical challenges also associated because like the products need to be refrigerated, the product needs to be given after reconstitution. So you need to have an IV access, you need to reconstitute the injection, you got to administer, and in order to store the factors, you need to have a refrigerator at home. So these are the kind of challenges the patient faces, the hemophilia patient feels, and when these challenges are addressed, only then we can overall overall address the quality of life of the patient. So these moving stories we heard brought a simple truth to light. Hemophilia management can have a daily impact on mental health, family life, and the ability to explore other aspects of their identity. So this is the patient's version. Gives a vague picture of how a quality of life of a patient is impaired. I was told, no playing sports, you should be bubble wrap. I'm afraid, holding my loved ones back. I'm embarrassed to call in sick because of a bleed. Not only patient, hemophilia also affects the caretakers. The caretakers also do take almost 50% of the burden what the patient takes. So from the perspective of a caretaker, what does the caretaker have to say here? One step forward, two steps back. It's a constant battle. I was defeated. As a caretaker, you often know more than the nurses and doctors. I became a huge advocate. I was overloaded and overwhelmed. I went into a panic mode. So these are the kind of versions the caretaker has. So this is not just a disease which is borne by the patient. This is a disease which is equally taken up or burdened by the caretaker too. So in order to curb all this, in order to address all these unmet needs, newer molecules came into the pipeline. Back sometime, how the hemophilia was managed, or the bleeding disorder was managed, was the patient used to come to me with a bleed. I would give a factor concentrates. I would curb the bleed. Again, next month the patient comes. Again, he has a bleed. Again, I would give a factor. So multiple times when the patient does bleed in his joints and I give factor, I'm able to curb the bleed. But over a period of time, the patient's joints get damaged and he becomes crippled. So I'm able to extend the lifespan of the patient, but his quality of life and his joint health is compromised. So that's not what I want, because today we are looking at giving a normal quality of life. In order for my patient to have a normal quality of life, I do not want any bleed. I want my joint to be preserved. What can I do to do all this? So then came in a concept called as prophylaxis. Prophylaxis is a small dose of factor VIII is periodically given so that a low level of factor levels are always maintained in the body so that the patient does not bleed. For a patient not to have a bleed, significant bleeds, you don't need to have 40% or 50% of factor VIII. Even anything more than 1% factor VIII in the body also is good enough to control the bleeds to 90%. So what if I give twice weekly a small dose of factor VIII so that I maintain a level of more than 1% in the body for the rest of his life? I'm likely to curb 90% of his bleeds. My joint is preserved. I'm able to give the best quality of life to the patient. So that is the concept of prophylaxis. So prophylaxis is a standard of care today which is recommended by the World Federation of Hemophilia in patients. So prophylaxis is given by two methodologies. One is through factor concentrates. So twice a week the patient comes to me. I infuse an IV small dose of factor VIII. The other way is there are some unmet needs by giving this, because for giving an IV factor VIII concentrates, I need to gain an IV access, which may not be a good option, especially when the patient is obese or in smaller infants and all. Second thing is prophylaxis has to begin twice a week or thrice a week. So the patient may have to come to the hospital 2 times or 3 times a week, which is not a feasible option. When I give too much of factor VIII, I'm likely to develop inhibitors, so that is not a good thing. So prophylaxis is good. It preserves my joint, it decreases my bleeds, but then it comes with its own pitfalls and drawbacks. In order to curb these unmet needs, there came a molecule. The newer molecules are being brought into the market. One of the molecules which proved as a breakthrough in hemophilia is emicizumab. Emicizumab is not for control of the bleed, it's a prophylaxis. It has to be continued indefinitely. So on February 27, 2018, the European Commission approved Roche product emicizumab for routine prophylaxis of bleeding episodes in patients with hemophilia A who harbor factor VIII inhibitors, which was later extended for approval even in non-inhibitors. So this is a molecule which is given for hemophilia patients with and without inhibitors as a prophylaxis and not for the treatment. So why is this a breakthrough molecule? Because one thing is it's a monoclonal antibody. It can be used in patients with and without inhibitors. Its half-life is prolonged. So unlike the factor concentrates, it can be given once a week, once in 2 weeks, or once in 4 weeks. It doesn't need an IV infusion. It can be given subcutaneously. And then it does not develop any inhibitors. It can be used in adults and in children and even in infants too. The mechanism of action, it's a monoclonal antibody, it's a bispecific, it binds a factor 9 and factor 10, it brings factor 9 and factor 10 together and then propagates or moves forward the coagulation cascade. So it acts in a place where the factor 8 was placed. So even in absence of factor 8, this molecule brings about the thrombus formation. Okay. Okay. So this is, I think the slide deck is changed, if I'm not mistaken. Okay. So this is a beautiful molecule. It has proved like extraordinary. The patients, previously the hemophilia patients used to have around probably the 0 bleeds. Annually, the number of patients who were not having any bleeds previously was somewhere around between 5 to 10%, but with this molecule, the number of patients with 0 bleeds is somewhere around 60 to 70%. That astonishing is this molecule. It works beautiful in pediatrics. Actually, it proved more surprising in pediatrics, where the 0 bleeds, that means the patients without any bleeds annually, was somewhere around 87%, in contradiction to around 10% or whatever with the previous regimens. So not only the bleeds, not only this emicizumab has curbed the bleeds and all, it has brought in a clinically meaningful improvements in the quality of life. So quality of life, the previous presentations in the past used to be like the reduction in the bleeds, the safety profile, etc., etc. But nowadays, all the presentation also includes the parameter of quality of life, and it has become one of our basic parameters to be analyzed. So even in this, the Haven trials are the trials which analyze the efficiency and safety profile of emicizumab. Even in Haven trials, this quality of life was assessed, and they found that emicizumab brought in clinically meaningful improvements in the quality of life. There were fewer hospitalization and fewer missed days of work in school because the number of bleeds were reduced. So number of hospitalizations of these patients, missed days of school, missed days of work were all significantly reduced. The health-related quality of life in hemophilia were as analyzed by different studies and all. So this is a HERO study where they analyze different parameters to assess the overall health-related quality of life, which includes lifestyle limitations, financial burden, pain and disability, mental health, impact on caregivers, and they found that all these parameters were significantly impoverished with usage of, were significantly compromised in hemophilia. And not only that, there were other studies too. The insights from the CHESS study, where they analyzed the health status, overall employment, impaired, and then impairment while working. They found that in hemophilia, these parameters were kind of significantly impaired. And also in the probe study, they found that the early retirement in hemophilia patients due to health was reported in 48%, and part-time working due to health was found in around 31.4%. So overall, what I want to say is the health-related quality of life is significantly compromised in hemophilia patients, and therefore it needs to be addressed. And the newer molecules, including the mimetics and the non-factor therapies, are significantly addressing this particular issue. So this is another survey where they showed that the children with hemophilia A have reduced physical and social activities. They missed the opportunity and feel frustrated. 58% of the children had reduced physical activity. 51% of the children had missed the opportunity. 58% have withdrawn from the social activity, and 55% felt frustration. And this was the analysis from one of the children's study. Okay, so not only that, there were multiple other studies also which have done on hemophilia, where they showed that the quality of life is compromised. And in concordance, there are other studies which were done with emicizumab, with Hemlibra, which showed how Hemlibra had proved to be beneficial, or how Hemlibra has improved the quality of life of patients and addressed all these unmet needs have been highlighted. There are multiple studies, though I have not highlighted here in order to shorten my presentation. There are also some of the Indian studies. There are studies which have been done from Kashmir, from Hyderabad or Nilofer Hospital. There are studies done from Assam, where They studied the role of emicizumab to showcase their efficacy, their safety profile, their health-related quality of life, and all these studies, all the abroad, the overseas studies, and also the Indian studies proved that emicizumab is a molecule which significantly addresses the health-related quality of life. So even in Nizam's Institute, we have an experience with this molecule. We have around 14 patients on this molecule, 7 patients with inhibitors, 7 patients without inhibitors. We have significant patients from the railway, CGHS, ESI, and other government organizations. And all these patients, none of the patients, 14 patients, after introduction of the emicizumab had any kind of breakthrough bleeds. So absolutely after I started the patient on this, I don't have any bleeds in these patients. They live in life as normal as a normal person. To the extent that they even forget that they have hemophilia, they live with a hemophilia-free mindset kind of mental status. So, since the introduction of these newer molecules, the prophylaxis, the newer non-factor therapies, and more comprehensive care, the life expectancy and quality of life of patients with hemophilia have increased significantly. So hemophilia is not just it's not just a disease which has to be tackled by a hematologist or a pediatrician. It is tackled by a comprehensive care where multiple specialties have to come together to address these patients. Like I'm privileged to be in an organization or institution where I can provide a comprehensive care because I have an in-house hematologist, physical therapist, physiotherapists, nurses, dentists, psychosocial workers, laboratory technicians, a well-established coagulation laboratory, and an orthopedician and a surgeon. All are available in the same roof, under the same roof in my institution, and therefore I'm privileged to provide the comprehensive care to the hemophilia to the extent that they have the best quality of life. And with this, probably I would like to end my presentation. So it's not just a job of a medical professional or a job of an institution to provide the support to this. In order for us to address the quality of life, and external factors also have to come into the play, which should include a strong support from the family, friends, and partners, which is a key factor in a patient's quality of life. With this, probably I would like to end my presentation. Thank you very much. Any questions I would like to take here at the end of the session? Fine, thanks. Thank you.
Hello. Yeah. Thank you very much for an enlightening talk on hemophilia. I just want to know what sort of patients do you treat? Whether it is severe hemophilia or moderate also you're taking up for this medical line of therapies?
The thing is like 90% occur only in severe hemophilia. It's the severe hemophilia who trouble us. Most of the times moderate and mild hemophilics, generally they don't come with any bleeding. They bleed only when they undergo some kind of surgeries. Moderate hemophilics, they bleed when they undergo some kind of trauma. So the game of hemophilia is in and all around the severe hemophilia.
Suppose a mild hemophilic patient wants to undergo an elective surgery, then what do you advise? Do you advise for these medications or no?
So suppose if a patient of moderate hemophilia comes to me with a factor VIII level of 4%, an elective surgery, it depends like, obviously the surgery has to be done under factor VIII coverage. So whether I want to give emicizumab, the newer molecule, the Hemlibra, or get away the surgery with a regular factor concentrates, is a call I will take based on his bleeding history.
Who will take the call, whether the physician or the hematologist?
The hematologist take the call. Hemophilia is managed with the hematologist when there is an in-house hematologist sitting there.
Right. Thank you very much.
Thanks.
Any questions from the floor?
Yes, sir. Yeah. So the costs go this way, sir. Now Roche has come up with some PAP program, patient assistance program, where they give 1+2. You buy one and then 2 are given. So if you include this PAP program, for a patient weighing 20 kgs, a 20 kgs child, the annual cost comes to around 7.2 lakh. If we take the MRP, it comes to around 9.5 lakh. So that's reasonable because the quality of life is improved to such an extent that 9.4, 7.2 is not a big deal, is my understanding. Yeah. Yeah. Generally, when we start a patient on emicizumab, the optimum levels are reached by around 3 weeks. So if at all I have to do a surgery for my patient next month, probably I would like to start a month prior because I know that by third week I'll reach a steady hemostasis. Then within the next week I'll take him up for a surgery. It has to be continued indefinitely because it is a prophylactic drug. It's not for the treatment per se.
Will it require additional treatment with factor VIII?
If the patient on emicizumab, he bleeds, he gets a breakthrough bleed, it has to be treated like any other hemophilia patient. So if the patient has inhibitors, you need to treat him with factor 7 or FIBA. Without inhibitors, he needs to be treated with factor 7. But the countrywide data is so beautiful that the breakthrough bleeds are kind of very, very minimal. The data is very good.
Is there any study on which says that the continuation of this drug will reduce the required dose of factor VIII?
If the patient does not have bleeds, we don't need a factor concentrates.
I mean to say that if the patient is on this drug, will the requirement for factor VIII in his subsequent span of life will be studied?
Not like that. Suppose if I have a patient on emicizumab and I have to do an elective surgery, suppose if I am to do a major surgery, if the patient not on emicizumab, I have to do a major surgery, I will give 100% correction for a major surgery for 14 days with a tapering whatever the levels. If my patient is already on emicizumab and I have to do the same elective surgery, probably I'll give half the required dose. I will not give a factor concentrates of 100% correction. I'll rather give 50% correction because I know that patient is on emicizumab. I have already reached half level of hemostasis. If a patient has to go a minor surgery like a dental extraction or a circumcision, my patient is already on emicizumab, probably I will not give any factor. Minor surgeries on emicizumab prophylaxis can be done unsupported. Major surgeries do require factor VIII support, but at half the dose of the non-emicizumab patients. Thank you, sir.
So that was an excellent session on hemophilia. I hope we have gained a good knowledge about the newer drug, and also there was a slight humanitarian touch to this near fatal disease. Now I would request the next speaker, Dr. Bharat A. Vaswani sir, to come and give his talk on advances in management of cancer and what a physician should know. I request the chairpersons to kindly introduce the speaker.
Good afternoon, all of you. It is my privilege to introduce Dr. Bharat Vaswani. He has done his MD General Medicine, DM Medical Oncology, MRCP in Medical Oncology. Presently, he is working as Senior Medical Oncologist and Hematologist in Yashoda Hospital, Secunderabad. He has received various awards like Vaidyaratna Award in the field of oncology in 2017, late Dr. Ajay Tapnikar Oration Award in 2022, late Chaya Sarode Oration Award in 23 and 24, Dr. APJ Abdul Kalam Health Award in 2023 and 24. He also received Times Icon of Health Care in 2023. He is a promising oncologist and 2024 in Times of India. So he has authored the chapter in Hematology Update in 2010 and 2015. He has got various national and international publications also. Now it is over to Dr. Bharat Vaswani.
Good afternoon, everyone. Sir, and I am a visiting consultant at South Central Railway also, added thing. So first let me thank the Physicians Association, All India Doctors. So in the next 20 minutes, I make sure that I make you laugh. Cancer is something which makes you depressed, but I am not the thing, and I'll see this at the end of my presentation. So what I am trying to tell in the next 18 to 20 minutes is, tomorrow if you see a patient of cancer in your hospital or in one of your practices, what are the new things that you should know and you should tell your patient? So when I started preparing for the topic, there were so many good things that I could have told, but in the 20 minutes, what I thought, मैं क्या करने आया था? So मैं क्या-क्या बता सकता हूँ उनको? Then I thought, let me make it a very simple talk with 5 to 7 new things that have occurred. In fact, with what is practice changing and what will change the practice in the future. So in a gathering, this is the only slide which will make you frightened. Why everybody should know about the cancer? Because if you see a single thing which is rising alarmingly, it is cancer. In fact, now the cancer is more or less, the mortality is as high or maybe more than what we get it from the cardiac disease. See the alarming picture. 1 in 5 will develop cancer in the lifetime, and the chances of death are 1 in 8 to 1 in 11. So it is imperative for us to know about the cancer and what is going on. So I am a Maharashtrian, but I practice in South India, and all of us, we believe about Janam Patri. So for a physician, what is the first thing that should come into your mind when you see a cancer patient? You should not think of Janam Patri. You should start thinking about what is Genome Patri. So what is the genes of the patient? What led to cancer? Because let me tell you, there are so many good injections and medicines, oral tablets that has come and that has changed the way. I'll be telling you one few of my example. From a survival of 6 months to 1 year, in a stage 4 we have 15-year survival, and that is not uncommon. That is something which is common all about. This is one of my last slides but my present, but I start with this slide with the famous quote of Socrates. The secret of change is to focus all your energies not on fighting the old but on building the new. So what is new? So the basic change that has occurred in the treatment armamentarium is use of precision medicine, accurate medicine. When two persons are not similar, how can cancer be similar in the 2%? So that is what the precision is all about. So can anybody tell me what is the best example of precision in real life? And that is car which stops and goes away with accurate 1 second here and there, and you rule the race. So this is what we are trying to get. Oncology in 2006, when you talk in South, you should have to remember Talaiva. You can forget, and when Vijay becomes the chief minister, Vijay sir, I can say. So you should always remember that our matinee God, that is why we always say. So what has changed now? Lot of advances. This is the most important thing. Concept of one treatment fits all has been replaced by individualized therapy, what we call as personalized therapy. From the era where cancer was practically incurable, now we have lots and lots of patients who are surviving for a long period of time. What I am trying to tell is, in a stage 4, I am trying to make my cancer as a chronic disease. So known case of diabetes, hypertension and cancer. That is the main aim for our thing. So the big thing first that has come in this year 2026. सब पूछते हैं कैंसर को रोक सकते हैं क्या? So can I give any tablet or can I reduce cancer recurrence by giving oral tablets? So this is music. So that came, a basic question is, can a drug reduces cancer incidence? And this is the biggest thing that came in this year is a good news for those who are diabetic or obese. GLP-1 agonist. The biggest data that has come till now for more than 3 lakhs patients, that was a data which compared GLP-1, so glucagon-like peptide agonist 1 versus ecospirin. What basically cancer comes is due to inflammation. So if you can reduce your inflammation, indirectly you can reduce the cell damage, ultimately leading to reduce in cancer. And that was published in the biggest conference in the world, that is APRCON, glucagon-like peptide receptor versus ecospirin. What they observed was, as compared to general population, those taking GLP-1 agonists had 36% reduction in the risk of cancer. And if you are high risk, that is comorbidity, it is 42%. So this is what we are trying now. Problem is randomized studies take 30 years. That was a retrospective 24 years analysis for more than 3 lakhs. And this is what now slowly guideline will start coming. Can I reduce my obesity, or indirectly can I reduce my cancer? In this 2 months, there will be a conference where 7 cancers, they are telling that it reduces the incidence. Now, I have already got a cancer. Can I reduce the cancer from coming back? So this study came in colorectal cancer. A simple drug, ecosprin, can be given. Can it reduce cancer? So this was, yes. You have to have this mutation, pick 3 mutation, and you need to give your ecosprin for 3 years. And it reduces your cancer incidence by 50% recurrence. The biggest publication, NEGM publication, low dose ecosprin. What it suggested is, it inhibits COX-2, so it reduces cyclooxygenase or prostaglandin E2, which is responsible for cancer. So should I give it in everyone? The answer is no. I have to do a simple NGS test. 40% will be positive, and I give this tablet, and the data suggests that it reduces the incidence recurrence by 50%. So our guideline suggests give ecosprin in colorectal cancer if you have this mutation positive. Simple drug but effective. So let me talk about what are advances in diagnosis, management, and the remaining thing. So all of us in the gathering, how do you diagnose a cancer? By doing a biopsy. So tissue biopsy still remains the gold standard, but what is new? So the new concept is a liquid biopsy. This is what the entire world is now going up to. You can't take out the tissue again and again. What we have realized is the same cancer that is present in any swelling is already present in the blood. वो फैल जाना already is there in the blood, but it is in microscopic amount. So now we have technology which picks up swelling. So how does it help? I diagnose cancer early, I tell you. I can tell earlier whether my patient is responding or not. So what is this principle? Tissue, even though localized, releases this ctDNA, circulating tumor DNA, which is analyzed. I can diagnose cancer early, as I'll tell you. And more importantly, am I fully cured? Tumor is not there. So I have a test in blood which says that if this ctDNA is negative, it will not come back. So the first thing, how do you diagnose a colon cancer? By doing a colonoscopy. So now there is a blood test which we can do instead of colonoscopy to diagnose cancer. Simple blood test. If it is positive, you will have a colon cancer, or then go ahead with the endoscopy. Do I have a data? So again, a NEGM publication which tells you that instead of colonoscopy, you can do a blood and you can diagnose a colon cancer. What about stool? So again, a test that has come. You can diagnose colon cancer by blood or stool with a sensitivity of 83%, specificity of 90, and more importantly, compliance to screening is 90. So the first thing is blood instead of tissue for colon. Now, I am a medical oncologist and hematologist, and the question I am being asked is, sir, I have removed a cancer. Why I should give you chemo? So I tell them that I remove micrometastasis. So if I have removed the cancer completely, why should I give in chemo post-op? So to prevent recurrence by killing micromets. So the million-dollar question is, how do I find out if there is micrometastasis? So we say in Hindi, tukka. So am I bluffing? So the answer is only 7 to 8% colon cancer in stage 2 and 25% in stage 3 really need a chemo. So now there is a new blood test called as Guardant Reveal. Simple blood test, turnaround time 4 weeks, and if in stage 2 it suggests there is no ctDNA, we have to avoid chemo. So now we have tests which tells us whether to give chemo, avoid chemo, whether the patient will relapse or not. The most important thing, a normal person in your clinic tells her, I am normal, can I develop a cancer? So now this is something that you need to remember. A test which has started in US and now coming to India is called as Galleri. Remember this, I'll go back. 50 cancers can be diagnosed just by a simple blood test, most of them in stage 1. Already FDA validated there, 63% is the positive predictive value, a multi-cancer detection test. So this test detects stage 1 cancers of liver, small intestine, uterus, and stage 2 cancers of pancreas, bone, earlier than any of the CT scan. So a new blood test, probably in India we have 2 tests, but this is more accurate than that. can I detect a breast cancer early only through blood? So again, we should be proud that there is an Indian thing, Datar, which has got a FDA approval. 5 ml of blood, 99% accurate. So blood to detect colon, to tell you to treat a chemo, to detect cancer early, breast cancer there. The most important thing. I have multiple members in my family who has cancer. The patient asks you, do I have a risk of developing a cancer? So now there is a blood test available now. Hereditary cancer genetic profile. Simple blood test. So the question that is being answered is, can you tell a person if cancer is due to any hereditary cancer mutation? A simple blood test called as, you remember this is the most important for your practice. The test name is hereditary cancer genetic profile. 152 genes, simple blood test, in one go you can find out. Simple blood test, 4 weeks is the turnaround time, cost is around 15 to 20,000, and it covers more than 150 gene causing hereditary cancer. So I can tell if there are 3 members, do this hereditary cancer test. If it is positive, at least you can find out or do more proper monitoring. These are available in India. So comes a $1 million question. Can we predict what may be the cause of cancer in a person? I'm talking about this. The answer is yes. So the question is how? By doing a simple molecular testing, cost of that test is 6,000 to 8,000 now. And the test name is wherever there is a fish or there is a mutation, it picks up. Looks simple, but now with lot of technology, the cost has come down. What is the name of that test? Next generation sequencing. Just you have to write. In fact, our pulmonologist, we never treat a patient of lung cancer until we do this test. NGS positive, only tablets. So the era of chemo has slowly been replaced by targeted therapy. So it is simple technique to know the sequence of DNA and RNA. And if we know the defect, we have a treatment. The commonest example for all physicians like lung. Lung now is not a single disease, but it is 10 different diseases based on mutation. A simple test we do to tell a disease. More importantly, we have tablets now available to treat a cancer. So you are making the treatment of your patient simple, and I can tell on day one how much time my patient will live. If it is EGFR positive, 5 years, ALK positive, 10 years. So you can predict on day one. Sabse important India mein, not for what is the cost of that test. So 8 to 20,000. So this is one of the example I always put. See in internet who she is, Miss World 1986. 2009 in my clinic, I was the junior most there. I started my career in. She came with altered sensorium to hospital. She is from Mumbai, but parents stay in Hyderabad. Drowsy, you can see multiple brain mets. How commonly predict she could survive? A stage 4 CA lung, 2009 where this technology was already just starting. Luckily, she turned out to be exon 19 EGFR mutation positive. 2018, she stopped treatment for after 8 years because she thought doctors are fooling me. 8 years, stage 4, never survived. The cancer came back again. Again, we started treatment. 2024, this was her PET scan. So a stage 4 lung cancer surviving for 16 years with a simple tablet is possible now. But you have to be good and you should know what are you treating. So this is common now. So the most important message for physician is never miss a targetable mutation. You may be a good physician, but you have to be intelligent. So are you surprised? No, I am never caught by surprise. This is something which is a norm here. Do your mutation test, treat it accordingly. Treat selectively, treat effectively. So the last part of my speech, 6.5 minutes. We have so many good things going on, and this is commonly available, but you should know. So what are things I am looking in future? This is something which we have started doing everywhere. Mumbai it started, Hyderabad we are doing it. So there comes to, have anybody seen this movie Family Man? I don't think so anybody might have seen because nobody seen. Even I saw when I was preparing for this presentation. I'll tell you a video. Tell me what it is. It is a famous. Awaaz aana chahiye, nahi to awaaz nahi aa raha hai. So this is a thing, Anupam Kher.
Your son's initial
response to chemo is less than encouraging. This is Gerard Butler, meaning what?
We should
still discuss options still available to us. Still available? Still?
Gene therapy. using viruses to alter Ryan's T cells and attack the cancer. I've had excellent success in a handful of cases.
What is he talking about? This is 2016 family, and this technology came in India in 2000. This is the way oncology is future. What is he talking in 2016? The patients, Gerard Butler's son had an ALL which had failed everything. And he was talking, what he was talking about was a gene therapy which is available in India now. The name of that gene therapy is chimeric antigen receptor therapy. This was the first initial patient in 2009. 9 lines of ALL failed and then came with this Emily Whitefield. First pediatric patient to see CAR T therapy, cured now for post 9th line of chemotherapy. In India, we have our own CAR T therapy now, which was launched 2 years ago by our respected president, and it was in collaboration with IIT Bombay and Tata Memorial. So this is our surgical strike against cancer. What do we do? The simplest treatment without any complication, any age. You remove blood from a cancer patient. There is a lab in Mumbai who inserts CAR T in the lab. They grow it and they give us this CAR and we infuse in the blood. Simple one-day infusion. Cost started with 3 crores. It came down to 16 lakh. Now the cost is 18 lakhs. So this is something we should know. Has it made a difference? So ALL failed, try this. Lymphoma failed, try this. Myeloma failed, try this. In fact, in most of the solid cancer, we have started doing it. And the results are not, I think so, but in leukemias, if you have a patient who is failing chemo, think of CAR T cell therapy. The older concept was chemotherapy, and the now concept is called as targeted therapy. So what exactly is target? It is like in Mahabharata, Arjun was asked, what are you seeing? So the eye. So this is eye which we are trying to care about it. It is a game changer, and this is a new kid in the block. So the most important advances for a physician is immunotherapy. That is immune checkpoint inhibitor. Simple. When your body has infection, your immune system takes over. Cancer is also not normal. So why is your immune system not working? So because your own T cells have become energetic. So this drug simply removes that inhibition. So see, T cells is inhibited from killing a tumor cell by the brake, and this drug prevents this T cell from binding to that. So your T cells become activated and it starts killing tumor cells. The 2% who got a Nobel Prize for this, Tashaku Honjo, James Allison. Why I am telling you to all? Because this guy is married to Indian. So behind every man there is a woman. Behind every person there is always an Indian. Or an Indian's contribution is there for immunotherapy. A Chennai lady who is 24 years junior to her, married at 68, got a Nobel Prize at 69. The most important thing is, this guy, if you see, runs a harmonica. His band's name is Checkmate. So all our immunotherapy style starts with the word checkmate. This is called as dedication to passion. He's old. So 2 drugs available. We are using it now with generic nivolumab, pembrolizumab, and ipilimumab. So now immuno is a drug of choice for liver cancer, kidney cancer, melanoma, urothelial cancer, and multiple cancers now. This is something a physician should know. When our chemo may not work, or on first line, we are adding up with chemo or we are substituting with chemo. So immuno is a word you should know. So gene therapy, immunotherapy is a big yes. The last part of my presentation. This is a responsibility as a physician or as a doctor. Can you prevent a cancer? Now, tell me which is the commonest cancer in female in India? Breast. What is the second common cancer? Cervix. So now we have a vaccine available, and it is effective because I personally have supervised more than 10,000 people. Cervarix, Gardasil, and now there is a nanovalent Gardasil 9. Now look at schedules. So three doses at 0 to 6. As I will be telling you, that is outdated now. Can anybody tell me what is the recent guideline of cervical vaccine? I will be telling you. The main problem in India is the cost. So for a normal person, the Indian version has come from Serum Institute. Cost is 500 to 1200. So the most important update is you should have to vaccinate males also. It is not female vaccine, because it reduces your anal cancer, vagina, vulva, and cervix, plus a warts also. So it is not the guide. This is a version that is given girls and males also. So do I need to give 3 doses in a gathering? So that has been changed. Only single dose required now. The WHO update in 2022 tells us that if you are 9 to 20, only single dose of HPV. And if you are more than 21, so myth is 3 doses, fact is 1 dose if you are less than 21. So a single dose of HPV vaccination is as effective as 3 doses. So 5 new things, CAR, immuno, this is what to remember. So I have 10 seconds. Who is the most important person here? So the most important person is you people. I'm not here. The arrow is to you. You have to decide how you want to treat a patient, because this is a way. If you decide, everything will be good. So as a medical oncologist and hematologist, my motto is hum honge kamyab, because I see a lot of stage 4 cases. You could never be pessimistic. And because I am living in South India, a tribute to 2 most famous movies which tells us how. What is this movie? Kantara. So what is Kantara? Curse. Cancer is not a curse, remember. And the tribute to, for me, the most famous movie, for me, nobody can beat, is Pushpa. What does Pushpa tell you? मैं झुकेगा नहीं साला. So we should never go down to cancer. So I made everybody laugh. So the tribute is 4 rights can never be wrong. What are these 4 rights? Right treatment at the right time in a right person will give you a right result. This is not right. My punchline is right treatment at the right time in a right person will always give you a right result. Always is my punchline. So if I end my talk, iska aap photo nikaliye. This is a take-home message. My favorite movie of all time, Satte Pe Satta. So there is a blood test available for screening cancer for breast and colon. There is a blood test which will tell you to give chemo or not. There is a blood test for detecting cancer in asymptomatic patient. There is a blood test which tells you whether cancer is due to hereditary mutation. Now we have a molecular test which costs only 8,000, next generation sequencing. CAR T-cell therapy, immunotherapy, AI-guided therapy. These are the future, and this is where the oncology you will see rapid advance. And now, last but not the least, prevention is better than cure. So cervical vaccine, single dose, good enough. Please vaccinate all your employees, all the people you come across. And if I have to summarize, with the better understanding of this biology, we have increasing targets, but we should know about this. Recent advances as cancer has made this more personalized. And with the discovery of all these newer drugs, monoclonal antibodies, immunotherapy tablets, more and more patients will be treated effectively. And as a medical oncologist, I am optimistic. So there is always a cure. And I end my talk with what I started. The secret of change is to focus all your energies, not on fighting the old, but on building the new. I thank you all for a patient hearing. Some questions there, please.
Thank you, sir, for nice presentation. And one more thing, the prevention of cancer is not only physician, it is each and every doctor responsibility to prevent this, because some of the diseases are we can prevent. Only thing, if we concentrate on the cost of the vaccine, naturally, even if we prevent 1% of the patient, it goes in a long way. And not only that, the agony and the cost of the treatment of cancer is also equally important. So instead of the suffering, better to prevent. Thank you, one and all.
Hello. Good afternoon, sir. Very nice talk, sir. I have got one query. I have seen Dr. Thomas Seyfried, whether you have heard him or not.
Yeah.
He says that the cancer metabolism, in spite of the available oxygen, it is all anaerobic.
Very cool. Sir, this is the
Auto-Warburg theory.
autophagy or everything. Sir, basically what they suggest...
My question is that can we prevent this by stopping carbohydrate or ketogenic diet as well as DAMS, which he is that. So whether it is preventable by changing diet?
Sir, first let me thank you. Good question. This is something which I have been asked a lot of times now. Sir, basically, cancer cells are different from normal cells because they don't need, it is what we call as glycolysis, what we say. So what you say, phenomena of autophagy, where you fast for some hours and do it. Sir, the concept is tempting, but you don't have a proper data to say that it really helps. But what I can always tell is, what causes cancer? Basically, a single reason is fats. or obesity. That is what GLP-1 did. So there are a lot of concepts. It is not concept that oxygen-free radicals coming from fat can damage cell over a long period of time. So the autophagy is a good thing and probably may help in making it a better health. Sir, whether it can prevent cancer per se, we don't have a proper data, but it improves our health because it causes better consumption of all the metabolites. That has been proven. In fact, I tried to look for it in one of the interviews somebody asked. But this is a good concept, but whether it prevents cancer or whether it reduces, you don't know. But saying this, lot of things like, I could not put because 20 minutes, now we have a data that exercising 30 minutes post recovery from cancer reduces your cancer by 50% with a phase 3 data. So 10 METs they say. So this is what, because I had 20 minutes, so I could not cover everything. But now there is, in colon, there was a phase 3 data which says that 30 minutes exercise post completion of treatment reduces recurrence because it improves your insulin sensitivity. It reduces your fat. So that is what GLP does. And probably in future you will see people will start using it as a prevention also because the first data in 1.5 lakhs has come up now.
Anything you want to say about ketogenic diet?
Sir, this is thing in terms of whether it prevents it, no comments I can say, but yes, it is not bad for it.
GLP-1 drugs, they are reducing malignancy. That itself is a biggest proof of that don't require any data.
Yes, sir.
So what these drugs are doing, they are reducing the glucose levels.
Yes.
What bigger proof than this you want?
Agreed. Sir,
so our focus should be, we should treat patients and teach everybody to glucose levels in the blood.
Sir, that will, in fact, a simple 15 minutes exercise will reduce everything. Endometrial, breast, all these fat, colon, and most of the cancers.
So prevention of cancer is in the reducing the glucose levels in the blood.
Probably one of the things, yes.
Not probably, the proof is there. You are
problem, sir, the only thing is, yes, but randomized study nahi aaya, isliye retrospective data, that is the only problem.
Aditya will tell you. Yeah, I would like to add, there was a calorie study which was a large RCT done where caloric restriction was studied as one of the interventions. It clearly showed that inflammation is reduced, metabolic parameters are, but the question, was the cancer endpoint prevention reached? No. So therefore still caloric restriction has not been officially said that it prevents cancer, but yes, it improves inflammation. Now coming to the other point, even GLP analogs are reducing malignancy, but whether that study is powered enough to give a conclusion? No, not yet.
That is a problem.
It is not yet.
Sir, you need a 30-year study to prove it. At 30 years, there will be, so the best way, these studies, epidemiology takes years and years to get it. And people, so the best way is to get a retrospective data. The good thing about GLP was, for so many years, we believe aspirin reduces cancer. And aspirin is basically good for everything, for your heart, everything. This drug was better than ecospirin in those patients who were taking both. So it was a good data separation. What it tells you is, it is one of the contributing factors for cancer. And not one thing, because it was even, but multiple things like exercise, what you said, glucose, a fat reduction. So all this will contribute. We have problem for us is a proper randomized study will take years to get it in this. But yes, this is something we have started using ecospirin, and we have started using mutation tests for all our patients even in early stage. If they are, you see now next 100 patients you see your cancer, tell them to do a NGS. If your PIK3 comes positive, this is not uncommon. 10 में से 2 से 3 में आएगा. So probably they have proven in colorectal. But if this mutation, in this mutation, if they are reducing in colorectal, why it will not in others? Because we don't have a data. So the Aditya, what he said is we don't have a data in a randomized because we don't know the set of patients where this will be useful. And now we are having an idea that this mutation, which is 1/3 of all cancers, will have advantage. So this may not work everywhere, aspirin, but it will work in those where the cancer is directly related to this mutation. So we are trying to segregate our patient where this may work. Maybe not in entire population. For those, this mutation is present. So you are trying to segregate or make it more personalized now. That was the take-home message here. So thank you again for a patient hearing.
Thank you, sir. True to your trademark wit, you could make everybody laugh, and it was one of those sessions where I am pretty sure everybody was paying attention to detail. There were many facts which not many of us knew. Thank you, sir. It was wonderful. And I would like to request the chairpersons to kindly felicitate our speaker, Dr. Bharat Vaswani, sir.
Chairperson, Dr. Nataraj Basappa is a PCMD of Eastern Railway, and he has got almost 34 years of experience. He belonged to 1990 IRHS batch. He is an orthopedic surgeon, and his key areas of interest are trauma, joint replacement, pain management, regenerative medicine, ozone therapy, and functional medicine. Thank you, sir. Dr. Sajeev, sir, to please felicitate Dr. Manjunath, sir, the CMS Solapur Central Railway. He belonged to 1991 batch, and he has got more than 33 years of clinical experience. Request the chairpersons to take the seats on the dais.
With this, we have come to the end of oncology session, and the next session will be a neurology session. The chairpersons for the neurology session are Dr. V. Kannan, sir, Dr. Sajeev N.K. sir, and Dr. Muruganandam, sir. I request Dr. Bimal Prasad Padi, sir, to please come on to dais and give his talk on management of status epilepticus in special situations. I request the chairpersons to kindly introduce the speakers.
So, Dr. Bimal Prasad Padi, he has done his MD DM Neurology, and he is working at Bombay Hospital Institute of Medical Sciences, Mumbai. He is a chief consultant and head of the Department of Neurology, Care Hospital, Nampalli, Hyderabad. His expertise is in stroke neurology, acute stroke intervention, epilepsy, and refractory seizure disorders, and advanced training in botulinum toxin application in neurology for movement disorders, spasticity, dystonia, chronic migraine, and neuro rehabilitation. Actively involved in multidisciplinary stroke care pathways and evidence-based neurological practice. And his key achievements are invited faculty and speaker at numerous national and regional neurology conferences, CME programs, and academic forums, author and co-author of multiple publications in peer-reviewed journals, active participation in neurology training programs, workshops, and continuing medical education initiatives, contributor to advancing awareness and contemporary management strategies in stroke and epilepsy care. Over to you, sir. Thank you.
Good afternoon, everybody. Thank you, Chairperson, for the kind words. At the outset, I should thank the management for giving me this opportunity to present in the platform. So status epilepticus is the second most common neurological emergency after stroke, associated with high morbidity and mortality, and it requires immediate recognition and treatment. As the time gap, like time is brain in stroke, every minute lapse in treatment of this epilepsy can cause brain damage. What is status epilepticus? Status epilepticus is the continuous seizure activity lasting for 5 or more minutes or recurrent seizures without recovery of consciousness. Previously, the time frame was more than 30 minutes, but it is revised to emphasize on the early treatment. It is given by the International League against Epilepsy. There are two terms. It is a new term that is introduced, T1 and T2. T1 is the time when after that the epilepsy, seizure is not going to terminate of its own. So some intervention is required. T2 is after that there is a risk of permanent or neurological deficit can occur. So T1 and T2 are very important for us. These T1 and T2 are defined in status epilepticus in tonic-clonic epilepsy. But for focal seizure, that is we call as complex partial seizure, focal with impaired awareness, the T1 can be little longer, like 10 minutes, and T2 can transmitter is the GABA. All these lead to metabolic stress on the body that can cause lactic acidosis, mitochondrial dysfunction, systemic complications like cardiac instability, respiratory failure, and brain damage, that is cerebral edema. If you see the pathophysiology, no, it is not coming. If you see the pathophysiology, normally the NMDA and AMPA are inside the cell. When status epilepticus occurs, there is a stress on the neuron, so these are externalized. That causes stimulation, upregulation of the glutamate receptors. Glutamate neurotransmitter are excitatory, and the GABA is normally there on the surface, they are internalized. This is the reason why the benzodiazepine resistance occurs after some time, because the internalization of the GABA receptors. Third, the KCC2 receptors, that is for the chloride channel, they are being internalized, causing chloride accumulation inside the cell, causing cell death. we can see that there are convulsive type of status epilepticus or non-convulsive status epilepticus. Convulsive is common, but non-convulsive requires more diagnosis early, because the dangerous is there in the diagnosis and treatment. When the seizure occurs for more than or equal to 5 minutes, it is called impending status epilepticus. In this case, treatment should be started as early as possible, initially with a benzodiazepine. So if the patient doesn't respond to benzodiazepine, it is called established status epilepticus. When you have given a benzodiazepine and an anti-epileptic drug at an adequate dose, still the patient is having seizures, it is called refractory status epilepticus. When you have the seizure occurs for more than 24 hours, it is called super refractory status epilepticus. Status epilepticus can be NORS or can be FIRES. NORS is new onset refractory status epilepticus, or FIRES is febrile infection related epilepsy syndromes. These they don't respond to normal anti-epileptic medications. Something else has to be given to them. In NORS, they are without any clear-cut structural, toxic or metabolic causes. So often they are autoimmune or para-infectious in nature, and they require immunotherapy at the earliest. What are the immunotherapy we generally use? IV methylprednisolone, IVIG or plasma exchange. The FIRES, febrile infection-related epilepsy syndrome, are usually preceded by some viral infection. Usually they have fever, but that is last around 2 to 4 weeks before this onset. And at the time of seizure, they don't have any fever. Usually the children or young adults are affected, and they require aggressive treatment with anti-epileptic and immunomodulator. Sometimes ketogenic diet also help. Diagnosis is mostly clinical and supported by EEG findings. EEG may not be always positive. You have to rule out other causes like structural causes by CT scan or MRI whenever the patient is stable, metabolic causes by like serum electrolyte, thyroid, sugar, ammonia, liver function test, infectious causes by CSF and blood investigation, cultures, urine, and autoimmune and toxic causes. Lumbar puncture is a must whenever the patient has seizure for a prolonged period of time to prevent any infection. It is most important in early childhood. Biochemical, serum prolactin, if drawn within 10 to 20 minutes post-event, has a 93% specificity. Please note it is less sensitive, but it is more specific. CS examination can have elevated protein and elevated cell, but this can be seen also in infection, so there is an overlap of the both of them. EEG monitoring, continuous EEG monitoring is mandatory in refractory and super refractory epilepsy, but in normal status epileptic patient, those who are all in seizure, at least a 1 hour with sleep deprived EEG is required. Patterns you see is periodic discharges, burst suppression, non-convulsive status epileptic features. Early seizure control is required for better outcome. Prolonged seizure may cause higher morbidity and mortality. Complications like hypoxia, hypothermia, hypotension, metabolic disorders, and rhabdomyolysis because of the prolonged seizures. Arrhythmia, there may be drug-related like arrhythmia, hepatotoxicity, renal toxicity, or propofol infusion syndrome. You have to support with airway, breathing, circulation, temperature regulation, hemodynamic stabilization, and whenever required, nutritional support and ketogenic diet. Guidelines for management. If there is an IV line is not available, IM midazolam is the drug of choice. Usually it is given in the childhood age group. When IVSS is available, preferred drug is IV lorazepam 4 mg. But alternative, IV diazepam, rectal diazepam, IV midazolam, IM midazolam can be given. The important is adequate single dose should be given, not avoid repeated small doses. If seizure persists, go to the second line of management. These are the doses of drugs that should be given in the first line of management. Here, drugs can be given in the second line of drugs are levetiracetam, valproate, fosphenytoin, or lacosamide is the new drug. Levetiracetam has side effect of renal dysfunction and there may be mood changes. Valproate has liver toxicity. Fosphenytoin can cause hypotension, but lacosamide is the new drug. It is neutral to both liver and kidney, but it cannot be given those who are having arrhythmia. These are the drugs can be given. Levetiracetam commonly we use, but sometimes what we use is around 1 gram. It should not be used. At least 3 to 4 gram of levetiracetam should be given unless there is a patient is renal toxicity is there. Those who are having CKD up to 3 grams safely can be given. Fosphenytoin can be given 1500 milligram. If it is not available, phenytoin can be given up to 1000 milligram. Valproate can be given up to 2 to 3 grams, and phenobarbital can cause hypotension and respiratory depression. So be careful in that thing. Lacosamide can be given up to 200 to 400 milligram. If the still patient is having seizures, then third line of treatment is given. Here, midazolam infusion, propofol infusion, or thiopentol or phenobarbital can be given. Here the patient need to be shifted to ICU for further management, as the patient may require intubation and ventilation also. Here continuous EEG monitoring is required and airway and hemodynamic stability is required. These are the infusion doses can be given for third line management. Regarding refractory status epilepticus and ketamine, ketamine is given when intubation can be avoided because it is conscious anesthesia. It is an NMDA receptor antagonist, targets mainly excitatory pathway, doesn't cause hemodynamic or respiratory compromise like phenobarbital, useful in the non-intubated patients. Management of the super refractory, those who are lasting for more than 24 hours, here the immunomodulators are more important than along with continuous anti-epileptic medication like IV methylprednisolone, IVIG, or plasma exchange. Therapeutic cooling, ketogenic diet, and surgical resection in rare cases. Summary: this first line is benzodiazepine, second line is anti-seizure, third is anti-anesthetic agent, fourth is other drugs like ketogenic diet, hypothermia. Mortality occurs in 10 to 30% depending upon the etiology. Long-term sequelae like cognitive impairment, epilepsy recurrence, psychiatric comorbidity. Follow-up should be mandatory. They should not stop medication as a abroad dose. This is the summary, same thing. And in special situations, main is pregnancy. So why it is important? It can be detrimental for the patient and the baby. So usually the cause is eclampsia, metabolic derangement, or sudden drug withdrawals. Benzodiazepine is the drug of choice because it is short-lasting and less side effects. Avoid valproate and phenytoin as much as possible because these are teratonic. Preferred drug is levetiracetam and lamotrigine. Ideally, lamotrigine is the safest drug, but it has build-up effect, so it takes some time and has some side effect of the cutaneous manifestations. When there is eclampsia, magnesium should be added. In pediatrics, mainly the febrile seizures, CNS infection, metabolic errors. First line is lorazepam or midazolam. Sometimes diazepam rectal can be given. Second line is levetiracetam, valproate, supportive with glucose correction. And elderly, usually they are because of the stroke, dementia, drug toxicity. Management, the lower benzodiazepine dose should be given, otherwise patient may cause serious orthopedic complications. Avoid excessive sedations and hypotension. In renal failure, adjust levetiracetam. In hepatic failure, adjust valproate and limit benzodiazepine doses. Preferred is lacosamide, fosphenytoin. In post-cardiac arrest or hypoxia, mechanism is global ischemia and cortical hyperexcitability. Their management continuous EEG, propofol, midazolam infusion. Prognosis is usually guided by the EEG. If there is a myoclonic jerk, the chance of prognosis and recovery are less. In encephalitis, usually the antibody like NMDA, LGI, or GABA. Management again the immunomodulator, immunotherapy. Anti-seizure drugs alone is not sufficient. Infection, usually herpes infection, bacterial meningitis, tuberculosis. Management is treatment of the infection along with anti-epileptic medications. In stroke, Acute symptomatic stroke is called when the seizure occurs less than 7 days, and more than 7 days it is called remote symptomatic or scar epilepsy. Preferred drug is levetiracetam. Avoid hypotension to prevent the cerebral hypoperfusion. In brain injury, again the levetiracetam is the drug of choice. Other drugs can be used like phenytoin and carbamazepine or oxcarbazepine also. Usually the cortical irritation because of the hemorrhage or edema is the usual the cause. Avoid benzodiazepine as cause oversedations. Drug withdrawals like alcohol, benzodiazepine is the first line of management. Correct metabolic derangements, propofol for the refractory cases. What are the emerging drugs? Brivaracetam, but it is less effective than levetiracetam, but less mood fluctuations. Immunotherapy like monoclonal antibodies for autoimmune encephalopathy. Continuous EEG by AI-assisted interpretation. Ketogenic diet, novel metabolic modulators. All these are being important, and registry is maintained. What is bridging the global gap? Normally, when the stroke patient, when there is remote, that can be thrombolized through WhatsApp or through the mobile. Same thing can be managed here also. Those who are remotely placed, we can guide them with EEG technologies. Now, smartphone-based EEGs are available. When the patient we cannot give IV levetiracetam if somewhere it is not available. Even nasogastric syrup levetiracetam or tablet levetiracetam in powder form can be given. It can work. Telemedicine is useful in management of the stroke epilepsy patients. This is very important for us. Seizure mimics and malingering. Up to 20 to 30% of refractory status epilepsy cases may be ultimately PNES. Clinical clues like forced eye closure, fluctuating asynchronous movements, preserved awareness, lack of post-ictal confusion, normal EEG during events, strongly suggest PNS. But EEG may be normal later on. Early recognition prevents iatrogenic harm. Sometimes, and these patients never had seizure in night, and they usually have seizure when somebody is around. Alone, they will never have, and they don't have any injury mark. Sometimes what happens when the patient is we think this patient is having a seizure, we give some benzodiazepine, patient seizure stops, we think it is a true seizure. It may not be, because anti-epileptic, when you are giving like benzodiazepine, that causes brief arrest in the movement that can mimic a seizure recovery. Persistent movement without EEG correlation by video EEG is a strongest identification mark. Fluctuating non-stereotypic semiology, preserved pupillary and autonomic response like blood pressure, heart rate not fluctuating, absence of post-ictal encephalopathy, and CPK level and lactate normal during seizure or post-ictal can be a clue. What is malingering? Actually, there are PNEs and malingering are two different things. Malingering is for gain. Patient wants some gain. It's a conscious level. Patient is fully conscious and he or she wants gain for job, money, or something else. PNES, they are psychiatric patients. They don't do purposefully. They have some psychiatric manifestations and they are involuntary. Neurological disorder associated with some psychological distress, abnormal functional brain networks. They require multidisciplinary care with neurologist and psychiatrist. Malingering, you cannot treat. Key home messages: early recognition saves neuron. Treat within 5 minutes as early as possible. Don't wait for 5 minutes. Stepwise escalation, benzodiazepine, anti-seizure drugs, anesthetic, advanced therapies. Continuous EEG is essential. Detect non-convulsive status epilepsy and guideline for therapy. Tailor to special circumstances like pregnancy, pediatric, elderly, and comorbidity. Sometimes what you do is pregnancy, we stop the medication. Don't do that thing. We are not doing that. Should not be done. Follow-up matters for cognitive recovery, seizure prevention, and rehabilitation. Thank you for the kind patience.
Hello. Thank you, sir. It was very elaborative, very informative actually. As a physician, a senior most me, still I feel a lot of new information for me. So thank you. I think this topic is very much relevant to us in our railway settings. That too, our last two slides are very important for us. The malingering and the pseudo-seizures, very often we are facing the situation we don't know how to rule out. But the background we can have some ideas because many of the people have some agenda behind the scene actually. Still, it's very informative, sir. A lot of slides are very, very attractive. So congratulations, sir. Very good presentation, sir. Thank you.
Thank you, sir. Thank you very much. I am also visiting neurologist to railway, sir.
Let me introduce myself. I am a chief physician from Southern Railway Central Hospital. People won't forget. I am the last organizing secretary, last conference. And greetings from the vice chairman of RAPI. I am the vice chairman RAPI. So I congratulate the organizing team for the excellent arrangement. Thank you for the opportunity. Because tomorrow I may not be available. That's why I am just delivering today itself. Thank you.
Thank you, sir.
That was a very informative session about status epilepticus. Yes, Bimal sir is our go-to man in deciding all the fitness cases about seizures, sir. He has vast experience. It was our special request that he talk about his experience in managing this pseudo seizures versus seizures.
He covered almost everything actually. Nothing is left.
Right. I would like to request the next speaker, Dr. Atikur Rahman sir, who will be speaking on stroke EVT outcomes, a tribute to Igas Moniz. It is the centenary year of his Igas Moniz. So I request the chairpersons to kindly introduce the speakers.
Good evening all. I am here just introducing Dr. Mohammad Atikur Rahman. He has done MD Medicine, DNB Neuro, and interventional neurologist and stroke specialist. He is consultant interventional neurologist and stroke specialist, Rinchi Hospital, Banarja in Hyderabad. His key achievements are Interact 2 trial ICH outcome with blood pressure management, DIAS 2 trial for ischemic stroke, diagnostic cerebral catheter angiography, neurologist perspective, Delhi course 2013 Stroke and Neurointervention Foundation, iatrogenic stroke registry based study, IAN 2012, infants in MCA territory and outcome patterns, 16th annual conference of Indian Academy of Neurology, 23-26 October 2008, New Delhi. Stroke management, cerebrovascular diseases, carotid intracranial stenting, emergency neurology, medical complications of neurological disease. It is over to you, sir.
Good afternoon, everybody. Thank you, chairpersons, for kind introduction. And I am thankful for the people of Indian Railways and South Central Railway and Association of Physicians of Railways. Thank you for giving opportunity to speak on this. Stroke, endovascular therapy and outcomes, it is a recent advances. The thing is, previously we used to have nihilism, that once the stroke happens, we used to think nothing can be done now. That's the over for the patients. We don't have many options to give to the patients. So now the endovascular therapy has came from 2015. So that is the important thing which we want to tell you. So stroke is sudden decrease in the blood flow to the part of the brain, eye or the spinal cord that is leading to the hypoxia and leading to the neuronal cell death. So this is the definition for the stroke, and the stroke present with the heterogeneous symptoms and with the different mechanisms as a heterogeneous mechanisms. So sudden onset headache, decreased consciousness, seizures, difficulty in vision, speech, swallowing, weakness, asymmetrical or symmetrical weakness in the face or the extremities and the imbalance. These are the various heterogeneous symptoms. So most of the time what happens is there is no uniformity. So recognition of the stroke is very difficult for the common people. So health stroke awareness programs as conducted by the Indian Academy of the Neurology for various. So that is like a Be Fast. So this Be Fast is a very simple mnemonic for the people who can understand in the common public. So B is for the balance, E is for the vision and the eye, and F for the facial weakness, A for the arm weakness, S for the speech, and T for the time. So this Be Fast is a simple mnemonic for the people of general public. So recognizing the symptoms is very important, and as I told you, the heterogeneous mechanism of the stroke, it is important for the management part. What are the different mechanisms is a TOAST classification. That TOAST classification suggests of the large artery atherosclerosis disease, cardioembolic stroke, small vessel disease, and stroke of undetermined causes and stroke for the unknown causes, and cryptogenic stroke. These are the mechanism for the stroke to understand that. Basically, stroke is a clinical diagnosis. So when the patient comes with sudden onset of weakness and speech difficulty or any vision problem, it is a clinical diagnosis. Why we do the imaging is to exclude the hemorrhage. It is not that key to diagnose the stroke. So stroke diagnosis is done by clinical symptoms, and the imaging is for the excluding hemorrhage and to assess the degree of the brain injury. That is very important for the thrombectomy, mechanical thrombectomy, to assess the how much brain injury is, how much the brain the component is survival, that is ischemic part, and the total infarct core, that is to be differentiated by the assessment of degree of the brain injury. Identify the vascular lesion. So whether there is a large vessel occlusion or whether it is a small vessel occlusion, we have to identify and then take the call for the management, and distinguish between the irreversible infarct and the salvageable infarct. This is very important. If the irreversible infarct is more, then the treatment will be, lot of failures will be there, and the outcomes will be poor, and the MRS score, that is a modified Rankin score, will be the high. So stroke imaging is done in a window period for IV thrombolysis or mechanical thrombectomy. Brain imaging to be done within 20 minutes of arrival in the emergency department. So it is the class of recommendation is 1 and level of evidence is B, and it is only for the exclude of hemorrhage, assess degree of brain injury, identify the vascular lesion, and distinguish between the irreversible infarct and the salvageable brain. So advancement of the imaging technologies and better understanding of stroke pathophysiology lead to paradigm of shift from the time window to the tissue window. So previously we were used to tell that as early as we have to treat the patient, that window period is only 3 hours, and then it extended to 4.5 hours. Now the time window for the treatment for the stroke is extended up to 24 hours. So it has shifted from the time window to the tissue window. So we are having lot of technological advances, so we can treat all the stroke patient with the extended time window, seeing the tissue window. So artificial intelligence, AI assisted by the image analyst, automated perfusion analysis, decision support, and personalized medicines will help in. This is a software which will help us to analyze automatically without involvement of the many radiologists or anything. So this AI assisted is very important, and AI improve accuracy, faster decision making, enhance patient selection, and increase access to the care. So there are two types of AI enhancement for this is rapid iSchema View, a powered platform for the automated perfusion analysis and decision support. So this will give how much is the perfusion is salvageable brain is there. If it is salvageable brain is more, then we can even extend the time window for the treatment of IV as well as the mechanical thrombectomy. So this software is very important. And E aspect is the in the CT scan, we see how much area is involved. So there are 10 points in the aspect score. It is a Alberta stroke early CT score is there. And if the points is less than 6, the outcomes will not be good. But this E aspect is also done by the artificial intelligence, and it is also very software is available which we can do it. So clinicians identify the patients who may benefit from the reperfusion therapies as IV thrombolysis or mechanical thrombectomy even after the time window period. These studies have shown that Dawn and the diffuse trials have shown it. So how the stroke revascularization has been evolved over the centuries. So initially it was in the 70s, single case reports was done in 1976, and then in the 1993 few cases has been done. But the most important study which was done is the NINSTIAL, neurological disorders in 1995, presented in the New England Journal of Medicine. So this has given the window period of 3 hours after the stroke onset. So then in the 2008, then ECAS came, then it has extended the time window period from 3 hours to 4.5 hours. And this was continued till the clear study came for the endovascular approach. This endovascular approach is after seeing the salvageable brain. So we are able to now have the lot of technological advances to see how much is the salvageable brain, and we can go ahead with the endovascular therapy. DAWN is the trial which has shown in 2018 has done seeing the salvageable brain from 6 hours to 24 hours time window has been extended, and diffuse 2018 6 to 16 hours was given for the time window. So patients came with that out of the time window. Also as given was IV thrombolysis also by seeing the salvageable brain tissue. So now the treatment evolution from nihilism to optimism, for the quality of life, it is better to err on the side of being an optimist and wrong rather than a pessimist and the right. So we have to take efforts to give the better functional outcomes. What we are doing here is to have a better functional outcomes. So the primary treatment is like less than 4.5 hours. IV thrombolysis is the choice if the small vessel disease is there. If the large vessel occlusion is there, if the patient is in the window period, we have to give the IV thrombolysis and take immediately for the thrombectomy, because the patient should not be denied for the primary treatment. Even if we are taking the patient for the mechanical thrombectomy, if the patient is in the window period for the IV thrombolysis, you have to give the IV thrombolysis and then take the patient for the mechanical thrombectomy. But don't wait that till the effect is seen after IV thrombolysis. Do the IV thrombolysis, take for the mechanical thrombectomy. Now the thing is, if the patient is in the more than 4.5 hours and less than 6 hours, see for the IV thrombolysis and mechanical thrombectomy. Also with the salvageable tissue assessment like perfusion studies, you have to do it in 6 hours to 24 hours and do for the IV thrombolysis and mechanical thrombectomy as the large vessel occlusion is there. So this is the recent advances which is applicable here, and now the future. Future is for the photomodulation of low-level laser therapy, which will enhance the blood flow and also angiogenesis, reduce inflammation and oxidative stress, promote neuroprotection, and improve cognitive function. As I told you that we should know the mechanism of stroke to treat the secondary prophylaxis and whether this occlusion is because of stenosis or any other mechanism. Always it is very challenging to tell the attendants about the decision, to take the decision regarding the stroke treatment, because always we find difficulty that the complication may occur after IV thrombolysis or mechanical thrombectomy. So we have to be very clear. So this is the visual aid. What you are seeing on the right side is the visual aid to tell the patient, if you treat the patient in less than 60 minutes, I required only 2 patients to get 1 patient benefited. So if you patient treat between the 60 minutes to 90 minutes, I required 4 patients to benefit only 1 patient. If I required 3 hours, 4.5 hours, then I required 21 patients to treat 1 patient to be benefited. So these things are very important for the physicians to understand that once the patient comes, you have to be very active. It is not that the window period has been extended for 24 hours, but the early you treat, the benefit is more, the functional outcome will be more. The early you treat, the greater benefit you give to your patients. I told you, everybody should keep this in the emergency room. Why I am telling is because this all green is like a complete MRS score, that is functional quality of life, is very good. MRS score is only 0 to 2. MRS is modified ranking score. It is a functional outcome in the patients. So this much of patients will be benefited if you give in the window period. And what are the white is there patients are there, that is are like no benefit. Only 2 patients will be having the complications. So it is very good visual aid for the patient and patient attendants to tell that this is the result of our treatment and what are the standard treatment we will be giving it. If your patient is getting complication, that is a different issue, but the benefit of the treatment is more. So why we are seeing the new options or new challenges we are seeing for the endovascular therapy is when you treat the stroke patient, it is when all the variables are taken care. Stroke units, if you take all the variables, patients when treated in the stroke unit, it will be benefited in 14%. If you treat the patient with RTPA, it will be 30% patient will be benefited, taking out all the variables. And when you do the endovascular therapy, 50% patients will be having better outcomes when you treat it. So why this is very important is when you have a large vessel occlusion, basilar artery is having only 30% of opening with the IV altiplase. So opening recanalization of vessel is only 30% in the basilar, and terminal ICA is only 6%, and M1 is 30%, and M2 is 44%, and tandem ICA is only 27%. Because of that reason, the mechanical thrombectomy has been came in the picture. The thing is, the more you delay, the less is the hypoperfusion will be area, hypoperfusion area will be more, so outcomes will be poor. So always when you do the imaging, try to see the collaterals also. So if the poor collaterals are there, the outcomes are also very poor. Endovascular therapy outcomes is the experimental or observational to trials to Cochrane studies, systemic review articles, and meta-analysis. Patients eligible for IV altiplase. This is a very important slide. Everybody should understand that patients eligible for IV altiplase should receive IV altiplase even if the endovascular therapy are being considered. In patients under consideration for mechanical thrombectomy, observation after altiplase to assess for clinical response should not be done. So it is class of recommendation 3 and level of evidence is B. And it is from the stroke 2018 ASA guidelines. So whatever the studies which are shown here, selecting studies, Hermes studies, and these are all showing the benefit. And when the patient is transported directly to the thrombectomy capable center, the number 2 benefit from the reperfusion, despite large ischemic score, is likely to be further increased. In 2015, there are few studies, the 8 studies came immediately. So all these studies had extended the time window from 6 hours to 24 hours, and most of them has been given the benefit of the outcomes, functional outcomes. And in conclusion, the synthesis IMS3 and MR rescue is negative either as substitute for initial treatment. So previously in the endovascular therapy trials, people are given without doing the IV thrombolysis. They are treated directly with the thrombectomies without doing it. So recanalization rate was very less in the initial studies, like 25% to 41%. So after the stent retrieval therapies, the recanalization rates has increased drastically to the extent is like 59% to 88%. Like TC2B3 is the stent. TC is the thrombolysis in the cerebral infarction. That is 2B3 is the good recanalization in the stent retrieval trials. So MR clean, escape, sit, IA fibrinolytic drug was used. Extended is no IA fibrinolytic drug therapy was used. So initial studies from 2015 to 2018, the recanalization was poor. Now the recanalization rate is very important. So as I told you that life-altering decision in minutes has to be taken. So visual aid has to be explained to the attendants and the patient so that they can take the proper decision. These are again all the endovascular therapy with the latest guidelines. They have shown that outcomes are very good with the early mechanical thrombectomy with the stent retrieval. You can see this, the MRS score 2 is seen in the 11.5% good functional outcome compared to the medical management. So this is very important. This is the visual aid which has to be explained to the attendants and the patients. These only 4 patients will be not benefited, will be having the complications, and other patients will be getting benefited. All the white are having the no benefit, but green is having the good functional recovery. They are joining their previous work also. These are the complications related to the symptomatic intracranial hemorrhage and also the hemicranectomy. These patients, even after doing this, after the endovascular therapy, these are having the patients are getting better with this. So whatever facility we are having, whatever studies we are having, we have to act locally and do the best for the patients. So this is one case. We will be finishing it immediately. This is the young lady came with the sudden onset of the right-sided weakness. Aspect score was 6, and what next is we have seen that there is a superior branches occluded MCA, and then thrombectomy was done with the microcatheter, clots were removed, and this was the outcomes for the patients. And this is the second patient with the sudden onset of weakness in both upper limb and lower limb, visual blurring. There is a complete obtudation. Sensorium was decreased. Aspect score was 6. You can see this is the complete basilar occlusion is there. So mechanical thrombectomy was done with the microcatheter with the stent retrieval. We are able to recanalize the vessel, and this is the clot which is seen in the here. So this is the third case with the rescue stenting. This is the patient came with the sudden difficulty in the giddiness as well as ataxic hemiparesis. So cerebellar infarct was there in the right sided. So there was a critical stenosis on the left vertebral artery. So what we have done is we have done the DSA. Sorry. Over this. So over it. This is the right vertebral artery. There is a complete thrombosis is there. This is the left vertebral artery. There is a critical stenosis is there. We have done the rescue vertebral artery stenting. So the important take-home message is stroke a clinical diagnosis. Imaging is essential to rule out ischemic versus hemorrhagic large vessel occlusion, diffusion, perfusion images has to be done. Treatment change from time-based to the tissue-based. Endovascular treatment of large vessel occlusion and acute ischemic stroke proven benefit is less than 4.5 hours to the 24 hours. And stroke unit 14% is the benefit, IV thrombolysis 33%, and endovascular treatment is the 50% improvement is there. Thank you for that.
Hello. Thank you, sir. As we are running short of time, we will not be taking any questions. I request the chairman sirs to kindly felicitate our speakers for this session. Dr. Bimal Prasad sir and Dr. Atikur Rahman sir, may please come on to the dais. Dr. V. Kannan, Dr. Sajeev Itke and Dr. Muruganandam will be facilitating our speakers.
Call upon Dr. Kalyani Madam, PCMB Southern Railways. PCMB ACR. So please felicitate Dr. Karnan. Dr. B.
He has presented papers in national conferences like APRCON, and he is also in state APRCON.
Welcome Dr. Kalyani Madam to speak way back on the dais, the challenge demonstration. Dr. Nimla Madam, please chair the session for the next one.
Dr. Narayan Swami, sir. Sir. I'll start off. Now, this I request Dr. Beatrice and ma'am to kindly come on to the dais to give her talk on Till That Change the Plan, Oral Innovation in Action. I request the chairpersons to kindly introduce the speaker.
Good afternoon, everybody. This is Dr. Beatrice Sani. She is MBBS, MD, and DM Endocrinology, Additional Professor and Head of the Department of Endocrinology, Nizam's Institute of Medical Sciences, Hyderabad. Key achievements are Subject Expert, Technical Working Group, Telangana NCD's program, Dr. Anil R. Sheth's Award in 2021, Endocrinology Society of India, WBHUS Gold Medal in DM Endocrinology 2016, API Gold Medal in 2012, authored various articles in international and national journals, authored a chapter in endocrinal disruptor chemicals. Now going to the...
Thank you, ma'am, for the kind introduction. Very good evening to all of you, and thank you for having me here. So I'm going to be talking about a molecule which has created so much excitement, and it has in fact percolated almost all of the specialities. I saw a lot of excitement in the oncology field with GLP-1 RAs. I was fully expecting the neurologists also to talk about it. So right now what I'm going to be talking about is oral semaglutide. So this is a sponsored talk by Novo Nordisk. But what I'm going to be talking about is only the science behind it. I'm not here to promote any molecule. So we'll start with why molecular origin matters, especially now that we have generic semaglutides in the market. Why is it important to consider the originator and what is so different about it? So we'll talk about the rDNA technology that is being used for making semaglutide, both the oral as well as the injectable preparations by the originators. So what is rDNA technology? You have the gene of interest which is identified and cloned, and the cloned gene is now inserted into a DNA vector which is again transferred to the host cell, and then you have the cell culture, then you have the processing, then you have the purification, and then you have the product for use. So you have three important components here, that is the quality, consistency, and the purity of the molecule which has to be considered. And now oral peptides have always been a challenge in science because any peptide is going to be digested by the stomach acid. So how do we get an oral peptide to work in the body? So that is when this innovation comes in, and that is the SNAC technology which is being used for oral semaglutide. So SNAC is salcaprosate sodium, which is an absorption enhancer, and it is going to protect the semaglutide tablet from being degraded by the stomach acid. So there is a coating of SNAC around the semaglutide tablet, and that is one of the reasons why we tell the patients not to break the tablet and have, because the SNAC coating is very important for the molecule to work. So this is a patented delivery system. So we have semaglutide, we have multiple other GLP-1 RAs as well. So we had the exenatide, we had liraglutide, we had dulaglutide. But of all these GLP-1 RAs, semaglutide has consistently shown a decrease in an efficacy in both glycemic control as well as weight reduction. So we'll look at the scenario or the use of semaglutide in the present day practice, especially with diabetes and weight management. So type 2 diabetes, as you all know, it rarely occurs in isolation. We have a multiple other complaints coming along with the patient. The patient comes in a full package. So you have obesity. So the concept of diabesity, that is diabetes plus obesity, is now catching up, especially in the Indian setting where we have the thin fat phenotype. So our BMI may be normal, but still we have central obesity, we have increase in the visceral fat, thereby an increase in the risk of diabetes at an earlier age, and an increase in the risk of diabetic complications as well as at an earlier age. We have multiple other complications, MASLD, CKD, CVD, and most of the times we would have missed the bus by then. So about 50% of patients are still undiagnosed in India, and even among those diagnosed, only 50% or hardly 50% have reached the HbA1c as well as the weight targets, and about 90% still live with overweight or obesity along with type 2 diabetes. And now when they come to us, it's just not going to be only type 2 diabetes, it is not de novo, there is going to be a history there. So you may have 32% of patients already having CVD, 40% already having CKD, and MASLD, dyslipidemia, hypertension. So we have the entire package coming to us. So this is where we need to look at molecules which are going to take care of all of these risk factors. So basically to reduce the risk of the CKM syndrome or the cardio-kidney metabolic syndrome. So if you look at GLP-1 RAs as such, they do have effects on the central nervous system. This is primarily how they are going to act for obesity or weight management, where they're going to act at the appetite regulating centers in the hypothalamus, and they're going to reduce the appetite. They're going to act on the liver as well. They're going to reduce the hepatic steatosis. They act on the kidney as well. There are multiple studies now showing renal protection. There is an improvement in the EGFR or a lesser decline of the EGFR, and a reduction in the albuminuria. And these are pleiotropic molecules. So they're not just going to control the sugars or reduce the weight. They're also going to have anti-inflammatory effect, antioxidant effects. And they are going to also have, to a certain extent, effect on beta cell preservation as well. So you have multiple organs or end organs on which these GLP-1 RAs are going to be acting. They're going to be acting at the level of the brain. There is neuroprotection. There is going to be a reduction in the appetite and thereby weight loss. They're also going to act on the blood vessels. They also improve the endothelial function. They're also going to reduce the inflammation, antioxidant effect. They're going to reduce the hepatic steatosis. They act on the pancreas. So that is the main area where they're going to act. So they have receptors on the beta cells as well as the alpha cells. So they're going to improve the insulin secretion and reduce the glucagon secretion. And they also act on the kidneys and the heart, giving us cardiac and renal protection in patients with type 2 diabetes. Now let's look at a hypothetical clinical case situation, and I'm sure all of us would be seeing these kind of patients in our practice. So this is Mr. Ramesh, an uncontrolled diabetic, type 2 diabetes and cardiometabolic risk. So this is a person who's working at a call center, which means there's going to be night shifts. He has HbA1c of 8.3%, a BMI of 28, which means he falls into the obese category. The cutoff for Indians is going to be 25, and he has a BP which is not really well controlled, and he also has dyslipidemia. He's already on metformin, rosuvastatin and telmisartan, but he has difficulty in losing weight, and he has poor glycemic control despite trying all of the lifestyle measures and metformin. So how do we approach this patient? So remember that diabetes as such is growing, and the cost of complications is again growing. So the projected increase is about a 46% increase in type 2 diabetes, and I'm sure all of you will agree when I say that the age of onset of type 2 diabetes has come down, and now which means that the next decade we are going to be handling more of type 2 diabetes complications as such, more than an incidence of type 2 diabetes. Now in India especially all of us work in the government center, so we need to look at what really drives the cost of therapy in type 2 diabetes. It is not the pills, it is the complications that drive the real cost of diabetes. So if you look at it, it's about 1.8 times higher when somebody has diabetes with complications, and when they get hospitalized it becomes much higher, about 2.4 times the cost, and if they have more than 3 comorbidities, it's about a 48% increase in the cost that we're looking at. So why is GLP-1RA a logical add-on? Because you know about the ominous octet in diabetes. So GLP-1RAs are going to target about 7 out of these 8 pathophysiological defects of type 2 diabetes. So they're going to improve the insulin secretion, they're going to reduce the glucagon secretion, they're going to reduce the hepatic glucose production, they improve the incretin effect, the appetite regulation is again set better, there is going to be a decrease in the lipolysis, and an improvement in the glucose uptake in the liver as well as in the skeletal muscles, thereby also reducing the inflammatory effect as well. Now we know that semaglutide, oral semaglutide, the first one approved was Rybelsus. So it is now indicated even as first-line therapy for patients with type 2 diabetes. Now if you look at the change in treatment of type 2 diabetes over the last 1 decade, probably 10 years ago, the first line was always metformin. But now we have so much literature to support the use of GLP-1RAs as well as SGLT2 inhibitors as even first-line therapy. And even if your HbA1c is well controlled, even if the patient is on metformin, still you add SGLT2 inhibitors and GLP-1RAs in those patients with increased CV risk, primarily because of the cardiac and the renal protection that these molecules give us. So if you look at oral semaglutide, it is approved for more than 18 years of age. It is in fact first line. It could be even considered first line, and as monotherapy or as combination therapy with metformin, and it can be used even in the hepatic, and I'll talk about the hepatic and the renal impairment patients in a short while, and it is cardiovascular safe. So if you look at, it's not only the Indian guidelines, but if you look at almost all of the guidelines, ADA guidelines or the European guidelines, they have told us one thing, that it's going to be oral semaglutide. It works in terms of weight reduction, in terms of glycemic lowering, and in terms of cardiac and renal protection. So how does this SNAC help us? So SNAC is the coating around the semaglutide tablet. So it is going to in fact neutralize the acid around the semaglutide tablet and prevents the degradation of the molecule. So if you look at the data that we have regarding oral semaglutide, so Rybelsus as such, if you look at the real world studies and if you look at the RCTs, in the RCTs there's about a 1.5% HbA1c reduction, But in the real world studies, you see much higher reduction, about 2.7%, which is quite good, which is one of the reasons it's considered as a high efficacy molecule. So about 2.7% HbA1c reduction, and this again depends on what the baseline HbA1c is. If you have a patient with a higher baseline HbA1c, when you start this molecule, you're going to have a greater reduction. And if you look at the weight reduction, again, in the RCTs, you have about 5 kg weight reduction, and it's much higher in the real world studies. Again, the baseline BMI is what's important. If you have a patient with a higher baseline BMI, you have a better weight reduction when you start these kind of molecules. And when you start the ribelsis molecule, the semaglutide, oral semaglutide, earlier on, you have better HbA1c reduction. About 8 out of 10 patients do achieve an HbA1c of less than 7%. So you look at the other molecules. Now we have DPP-4 inhibitors, which are quite affordable, SGLT2 inhibitors, which are again quite affordable. Why do we need another molecule? So this is where you look at GLP-1 RAs versus DPP-4 inhibitor and versus SGLT2 inhibitor. So if you look at DPP-4 inhibitors, there is a 75% greater reduction in HbA1c when compared to DPP-4 inhibitor, and a 4 times greater weight loss. So DPP-4 inhibitors are weight neutral, whereas GLP-1 RAs is going to give you weight loss. And SGLT2 inhibitors, again, already we have cardiac protection, renal protection. Now why do we need another GLP-1 RAs on top of this? So this again, you have about 1.1% additional HbA1c reduction, because these two molecules are going to act by different pathways. And you have again additional weight loss of about 5 kgs. SGLT2 inhibitors, about 2 to 3 kgs weight loss you have. And it may be a little higher in certain patients, but about 2 to 3 kgs. We have a little more with the GLP-1 RAs. And what about with insulin? So we have results from the Pioneer 8 study, which has shown that when you add with insulin, about 6 out of 10 patients do achieve a HbA1c of less than 7%. And there is no body weight gain, which is one of the concerns when we start patients with insulin. And hypoglycemic events are similar. Again, adjust the background insulin when you start the patients on semaglutide. And there is a reduction in the insulin dose as well when you start the patients on semaglutide. So how do you start oral semaglutide? Ask the patient to take it on an empty stomach as soon as they wake up, with about 120 ml of about half a glass of water, that is. And then wait for about half an hour. Don't eat or drink anything, because you need the tablet to go and sit in the stomach for the absorption. So about half an hour of no eating or drinking. You start with 3 mg dose, and after a month increase it to 7 mg, and again after 1 month you increase it to 14 mg if you require additional glycemic control or weight reduction. Now all this really depends on how the patient can tolerate the medications. So you probably have to go slow for somebody who's not tolerating the medications too well. And potential side effects, especially the gastrointestinal, has to be explained to the patient. Smaller meals have to be advised, because it is going to reduce the appetite as well as increase the satiety as well. So how do you adjust other medications when you start oral semaglutide? Metformin, SGLT2 inhibitors, thiazolidines, and alpha-glucosidase inhibitors as such do not cause hypoglycemia. So you can safely add these drugs and no dose adjustment is required. But when you do start the patients on oral semaglutide in somebody who's already been on a sulfonylurea, look at the baseline HbA1c. If it is more than 8%, 9%, then you can straight away go ahead and start the oral semaglutide without adjusting the background sulfonylurea. But if the HbA1c is less than 8%, patient has history of hypoglycemic events, adjust the background sulfonylurea depending on the HbA1c. Again, DPP-4 inhibitors, stop the DPP-4 inhibitors, because both are going to act in the same pathway. So you start only the oral semaglutide, stop the background DPP-4 inhibitor. DPP-4 inhibitor metformin combination, continue only the metformin, stop the DPP-4 inhibitor. The patient is on insulin, again depending on what the baseline HbA1c is. So if it is more than 8 or 9% uncontrolled diabetes, you add the semaglutide and then ask the patient to monitor the sugars and adjust the insulin dose. If it is less than 8% history of hypoglycemic events, reduce the insulin dose by about 30% and then add the oral semaglutide. So what about other drugs that the patients may be already on? So the patient is on statins or PPIs, beta blockers, antiplatelets, or patients with CVD with other drugs, there is no interference, so you can safely give the drug. Patient is on warfarin, do monitor the INR. Patient on metformin, furosemide, rosuvastatin, no dose adjustment is likely required. Patient is on levothyroxine. Again, studies have shown an increased area under the curve when you give semaglutide along with thyroxine. So you have to monitor. As of now, we have not had any issues as such. We didn't have to adjust the dose. Only if the patient loses weight, then yes, the dose of thyroxine does come down, but there is no direct interference. So generally what we do in practice is give oral semaglutide and after half an hour, ask the patient to take the levothyroxine. Or the other option would be to shift the levothyroxine to the night. So about 3 hours after the last meal of the day, ask the patient to take the levothyroxine. So what is the role in cardiometabolic syndrome? We're talking about this patient who's having many metabolic risk factors. He has uncontrolled diabetes, uncontrolled hypertension, dyslipidemia, obesity. So we have to look at how early intervention is going to target the metabolic risk factors in this patient. So if this patient, let's say, hypothetically had a high cardiovascular risk, which he has, of course, he has dyslipidemia, he's overweight, he has coronary artery disease, hypertension, or type 2 diabetes. So this patient now is coming to you with an established CV disease. So what data do we have to support the use of oral semaglutide in this? So we have two studies, the Pioneer 6, which is a CVOT study for semaglutide, oral, and the SOUL study again, which is for oral semaglutide. So both have shown that there is a significant reduction in the MACE or the major adverse cardiovascular events, and it is a little more in the Asian subjects which were enrolled in the SOUL study. And based on the results of the SOUL study, now CDSCO has also approved oral semaglutide for primary cardiovascular prevention in patients with type 2 diabetes. So these are the different breakthroughs that this oral semaglutide has achieved, especially in terms of the CVOT, the SOUL study, which had shown significant results. So the SOUL study, about 800 patients from India. It was about a 4-year study. So this was basically to look at how oral semaglutide is going to have an effect on the 3-point MACE. So here we see that the number needed to treat is only 50, and there is an early separation of the curves. And what does this mean? It is just not glycemic control which is important here. This drug also has pleiotropic effects. So it has antioxidant effects. It does stabilize the atherosclerotic plaque. So all of this is going to have an effect on the coronary artery disease. Now if SGLT inhibitors already in place, we do have cardiac protection, then why again a GLP-1 RA? Now again we do see that there is a 2 times increased protection. So there is actually a residual risk that you see after adding SGLT2 inhibitors. There is still a residual risk. So to take care of the residual risk, again we can add a GLP-1 RA for better cardiac protection. And if this patient, let's say, had CKD, now what is the data for CKD with oral semaglutide? So it can be used even in mild to moderate renal impairment, and up to a GFR of 15, you can still use oral semaglutide. There is a 38% slower decline in the eGFR when you start patients on oral semaglutide. So you see the metabolic benefits. There is a significant reduction in the HbA1c, a 5 to 7 kg weight loss, and a 4.2 centimeter waist circumference reduction, and a reduction in cardiovascular risk markers like a lower LDL cholesterol, a lower total cholesterol and triglycerides, and inflammatory markers like hsCRP going down as well, and a reduction in the systolic BP as well. So for cardiometabolic syndrome, how does oral semaglutide fare? You see a reduction of about 27% MACE reduction, especially in Asians. And then you have about 26% reduction in the urine albumin creatinine ratio, and you have weight reduction up to 7 kgs, and you have a reduction in the cardiovascular risk markers, a reduction in the systolic BP as well. So now, why do we consider oral semaglutide a good fit for this patient? Well, this is a patient who needs glycemic control, who needs weight reduction, who likely has a high risk of cardiovascular disease. So hence, in these kind of patients, oral semaglutide would be a good fit. So that would be the end of my talk. So thank you for patient listening.
That was a wonderful talk, Doctor. Actually, when I was doing some Google search, that pills that changes the plan, I got the contraceptive emergency pills only in Google. So I thought, because in oral innovation, you never given in hyperglycemia also. So I just want to know what is the topic about, and it was telling emergency pill. So that's why the gynecologist was called, I think. And when I started looking at it is something else, it is semaglutide. Okay.
Luckily, I'm not that gynecologist. Thankfully, I'm the endocrinologist who's talking about the other pill.
That was a real wonderful talk, actually. Thank you.
I have a question.
Yes, ma'am.
You said we should not break semaglutide in half when we take it. What happens if you break it?
The snack coating. So you need the entire snack coating for that molecule to be preserved in the acidic pH of the stomach. So we see patients when they say you start them on 3 mg, they tolerate well. And then you go to 7 mg, sometimes they have vomiting. So they tend to break the tablet and have. So that should not be done.
That's exactly what I have been doing because... So I was taking 3 mg, I was comfortable, then I was taking 7 mg and I was having a troublesome nausea. So I've been taking it, half of it every day. So I think that...
So better than that would be take it alternate days because the half-life is quite long.
Okay, thank you.
This can be given in obesity also without hyperglycemia.
It is not approved for obesity without hyperglycemia.
Okay.
Only the injectable preparations are approved.
Nice talk, madam.
So we do have oral semaglutide, which is not really, they do use the snack, but it is only part of it. They have their own innovation. And we do have the initial phase 3 studies which they have presented to the CDSU. But clinical experience we are yet to acquire with those molecules. That's a very good question, sir, because one thing that you have to rule out before starting any sort of GLP-1 RAs or the dual agonist is retinopathy, but not all retinopathy. It is unstable retinopathy or maculopathy where there is a risk of progression of the retinal disease. Pancreatitis, there are studies showing, see the clinical trials have not shown an increase in the pancreatitis. But if you look at the real world studies, yes, there is a marginal increase in pancreatitis risk. So choose your patients carefully. Now, if the patient has already had history of pancreatitis, those would not be good candidates for starting these molecules.
So, madam, very nice talk. So you said about decreased absorption. What about decreased intake itself?
Of course, it's going to decrease the intake because the appetite goes down.
Satiety decrease. So there is one proverb like that. What we eat is different. What is advised is different. One proverb goes like this: king's breakfast, ministerial lunch, poor man's dinner. The proverb goes like this: king's breakfast, king size breakfast, ministerial lunch, poor man's dinner. But what we ate, Indians are quite opposite. You don't take breakfast or you skip the breakfast, a small box of a lunch or a king size dinner. So that's what we practice, but what we advise is different. So I advise, one take home message is, please follow king's breakfast, ministerial lunch, poor man's dinner. Okay, with this we will head the first session, then we'll go to the second session. Yeah. That's all? Okay, right. Okay, thank you.
Irritable bowel syndrome.
This is the end of the session, ma'am. The other talk, due to paucity of time, has been shifted to tomorrow, ma'am. Yes, ma'am.
Okay, right. Thank you.
Yes. No, you'll be felicitated, ma'am. You'll be felicitated. Yeah, I request the chairpersons to felicitate the speaker for this session.
laparoscopy. She belonged to 1989 IRHS batch. Thank you, madam.
Dr. P.S. Prasad, former DG RHS, for his exemplary contributions to railway health services. We cordially invite Nirmala Madam or PCMD SCR and Dr. N.V.B.K. Sai Sir, Chief Cardiologist and Organizing Secretary of APRCON, to kindly grace and bless the occasion. Thank you. Dr. P.S. Prasad, sir. Dr. P.S. Prasad, sir, is a retired DG RHS in 2014. He is instrumental in getting IRHS cadre development, and he has developed a super specialty hospital at Patna ECR. He has acquired MBA Health from BITS Pilani at the age of 67. This shows education never stops. And he belongs to the batch of 1977 IRHS batch. He's a good academician, administrator, and he's very instrumental in developing IRHS. Thank you. Fully developed because of this. Thank you.
that is the reason why we got the cath lab. I couldn't do it during my tenure as DG, but that was initiated. A foundation stone was laid with the help of the then dear Mr. Srivastava, whom I knew personally also. And then it being material during my stay, but later on normally setting up the centers takes a lot of time and energy in government setup. Everybody knows that. So I'm so glad that Sai is continuing that tradition of developing that center. He has done so many procedures. I keep in touch with him. I keep talking to him in between whenever he has some problem, in general, administrative problems mostly. I give him advice from outside. So I'm so happy that South Central Railway has got a good cardiac center, cath lab, where he is doing almost everything now, including pacemaker insertions, all procedures. That saves a lot of money for railways. People don't realize it, the accounts or the general administration. Otherwise, say even if it does 10 cases a month, it easily saves railways about 20 lakhs. Congratulations to Sai and congratulations to South Central Railway. Thank you.
Thank you, sir. One of the important on all India level, our retired DG RHS's contribution, Dr. P.S. Prasad sir's contribution is the very policy of giving extraordinary leave and study leave to IRHS doctors within 2 years of service. So that was the greatest decision sir has taken with the chairman of the railway board's concurrence, and that policy was changed. Before that, doctors were required to work for 5 years to get a study leave and at least 2 or 3 years to get an extraordinary leave. So once sir convinced the then chairman of railway board, the entire policy changed and people started taking extraordinary leave right from Baroda level onwards, that is first to 2-3 months service onwards. This has produced a dramatic change, sir, over 10 years. And now we find among the ADMOs and DMOs, there are so many specialists, sir. And of all the people who have gone and studied, maybe 20% have not returned back to the railways, but 80% have returned back to the railways. And now among the ADMOs and DMOs, if we see, there are specialists of all subjects. All subjects are there. Some super specialists are also there with your policy, sir. This is one of the greatest policy you have taken, and it has helped hundreds of students. Now people, IRHS doctors, after joining the probation service, within 1 month, 2 months also, there are many candidates who have gone on extraordinary leave and done their MD and they have come back. This is one of the greatest decisions you have taken. 20% have gone, that's okay. But at least 80% have come back and joined the IRHS. Thank you so much, sir.
Thank you, sir. Thank you for your kind words. And it's a custom of our APRCON to felicitate our seniors. The APRCON 2026 organizing body takes immense pride and privilege in felicitating our esteemed senior physicians, Dr. S. Mahapatra sir, MD CH Lalaguda X, and Dr. Anjaya sir and Dr. Savita Gangude madam, whose dedication, clinical excellence, academic contributions, and lifelong services have greatly enriched the medical fraternity and inspired generations of doctors. Their commitment to patient care, teaching, mentorship, and advancement of medicine continues to remain a guiding force for the young medical community. We now welcome Dr. Kapil Sarde sir and Dr. Tripti Pisal madam to kindly join us on the stage and proceed with the felicitation ceremony. Thank you. We request Dr. Srikant Mahapatra sir, Dr. Anjaya sir, Dr. Savita Gangude madam to please join the stage. Yes, sir. Senior physician and neurologist. He belongs to 1979 IRHS batch. Thank you, sir. Now we request Dr. Kapil sir to felicitate Dr. Srikant Mahapatra sir. He is a senior consultant physician and retired as MD CH Lalaguda. Dr. Tripti ma'am to felicitate Dr. Savita Gangude ma'am. Ma'am is retired as ex-ACHD JRH Mumbai. As Dr. Kapil sir to accept Dr. Shashank Malhotra sir, Dr. Anita Jaiswal madam's felicitation awards. Thank you. Guru Sakshat Parabrahma Tasmai Sri Gurave Namaha. We would like to, all these are the... it gives an immense pleasure for us juniors to felicitate our seniors, and it has been following as a custom in our APRCON 2026. We request our senior physicians to give a few words of wisdom for us. Thank you.
Good evening to the august audience and also the dignitaries who have attended this conference. And I am very much deeply honored and as well as very much humbled by this felicitation which was bestowed on me, and to say a few words. And I am very much thankful and I give my gratitude to the organizers as well as to the entire team members for having successfully conducted this CME program. And as a physician and as a neurophysician, as an administrator, my journey was like a clinician, much more than anybody else. The CME program is not only to enlighten our people, but also give inspiration to the younger generation. As the advancement in the field of medicine is going on with new technologies and new diagnostic tools, at the same time, I just emphasize on the soft skills which should keep pace with the new developments and technologies. The soft skills, nothing but the empathy, the so-called the human touch. That is what required now. And it should not be like a mechanical, or it should not be like a just procedural and sophisticated type. But at the same time, some sort of inculcation into the younger generation to have the soft skills development, ethics, and with a human touch, little bit of history taking, examination, and the other things with which you can corroborate. And now with the advent of AI technology, the doctors who practice and take an aid of AI technology, they are placed at a higher level when compared to the people who don't make use of the AI technology. So nothing in the future is going to overtake us. No machine or no technology is going to overtake so nothing is substitute for a man, and nothing is substitute for a human touch. So thank you very much for the organizers, especially for Dr. Sai and team, and our younger generation and all other dignitaries who have attended, and the team who have really successfully organized. So I am very much thankful and grateful to you. Thank you.
So I am thankful to all the organizers for this kind gesture, which was not expected. And Dr. Sai told me that, sir, we are organizing, felicitate you during your APRCON. So I was pleasantly surprised and agreed. And what I can say, during my tenure as the medical director, I was acting as the CMD, and many young people, young doctors in fact, they approached me that we are applying for DNB and please allow us. And just before that, I had a talk with GM because I was anticipating this. And GM told me that you allow your people to go. I told that I will have the shortage of doctors. He told, in any case, we are running short of doctors. And if there will be some more shortage, what is there? And let more qualified doctors come to our unit. So you allow people to go. So I told them that, yes, you can all go. But your job is to get a seat. If you get a seat, you are getting released. Because GM has agreed, so naturally, I want that you should all prosper. And they have, many of them has joined, has went for DNB and they have completed their job. And some has gone even for super specialty, what I heard today. So the department has, actually everybody has praised Dr. Sai, and they think he deserves it because the cath lab mainly was pending for many years. It was, when I came in 2014, the building was under construction. It reached construction, remained unused for many years, and there are some questions why the asset remains unused. We tried a lot for its use, but we were not successful during my tenure. But after all, Dr. Sai has taken the interest and has made it successful, so all kudos to him. And the organization in the APRCON is very well organized, beyond my expectation. And so many delegates, I was not expecting that so many people has come, and it is a real nice event. Thank you very much.
Respected Prasad sir, Nirmala ma'am, Dr. Sushma and other my senior and junior colleagues. I never expected that I'll be speaking this side because for last 18-20 years I was looking after as a secretary RAPI and felicitating retired physician, but this has come prematurely though it was my decision. And it's good that the tradition is being continued by our younger generation, the baton which we have handed over to the younger generation last year in Chennai. I'm so happy that so many new faces, new young physicians have joined through the railways policies and DNB for the IRHS. So there is no dearth of physician all over Indian Railways. That is the policy made by our seniors DGRHS, and then it was approved by Railway Board and National Board. So we have a lot of physicians. So I expect that our physicians will do quality work as well as they will shine on academic front. As far as this APRCON is concerned, Dr. Sai and his team has taken lots of effort to make it successful, and this is the highest number of delegates ever since the foundation of a physician's body. So I congratulate their team under guidance of Dr. Nirmala, and I know that it is very difficult to organize such a conference on large scale, but they have done so far the job very successfully. Thank you very much for giving me honor. Thank you so much.
Thank you, Mahapatra sir. One more point I would like to add. At the fag end of the day, it just slipped off my mind. During PS Prasad sir time, one more great achievement was the sponsorship in All India Institute and Central Institutes for the doctors. Subsequently, the railway doctors wrote the entrance, and with huge ranks also they got the seats, with big ranks, which no one can ever have dreamt earlier. Because getting into All India Institute and PGI Institute, one should get within 3, 4, third rank, fourth rank during my time. But then, with the sponsored seats available in Armed Forces Medical College and All India Institute of Medical Sciences and PGI, many of our railway doctors benefited, and with I should not say bad, but big ranks also, they got seats which otherwise they would not have got on normal terms. So, it gave a lot of benefit to the Indian Railways, and by this many physicians and many super specialists developed in the system. Thank you so much, sir.
Thank you, sir. Thank you for your words of wisdom. Now the next GBM continues. Thank you.
कॉर्डलेस माइक चाहिए
कॉर्डलेस I request maybe check this. Many of the executive members have left, but I request whosoever are left to be present at the meeting to discuss a few important issues regarding the GPM. So I request Sai sir to please come on the dais. I request Dr. Tupti also to have a seat.
Hello.
So issues to be discussed, first is the apology. So one of our founder president of RAPI and our first founder president and who developed RAPI, who formed the RAPI, and later on many conferences occurred and
much more work occurred during his tenure as a president. That is Dr. R.B. Pandit. He left us to the heavenly abode. So I request all the members present here to offer condolences to him and observe 2 minutes silence for the same. Next point of discussion is future conference venue. So I request Dr. Sai sir to please advise us regarding the same.
Next conference venue, any takers from other zones? No, so far no one has come forward, sir. But if the chair permits, I would like to say a few points what our experience in conducting this conference. So of late, what we have found is all the pharma companies and all, they are not funding before the conference. So they say that after all this execution of bonds and all, they come and take the pictures here, they come and take the stalls, they come and take the pictures of the stall, then they submit to their offices, and then they release the funds after say 1 or 2 months. So this is causing a problem in organizing the conference of this magnitude. And for this present conference, I have to share with you all that myself and my wonderful physicians, we accumulated about 8 lakhs amongst ourselves. We contributed to 2 lakhs each to run the show till today. Because we have to pay advances. We have to pay advances to the catering and other logistics. From PCMD office, the support came in the form of officers' rest house and accommodation and transport. But then we have the other events which you all know when such a magnitude conference happens, catering and all, that we have to pay advances. Otherwise, nobody will come forward to do without an advance. So this aspect also should be considered in mind. When Dr. S.B. Gupta sir was conducting conferences, I don't know how the situation was, whether the pharma companies were giving before the conference their sponsorship or after the conference. We have asked so many times, none have come. I think nobody has come forward. Jyotsna and Ragam Mehta are directly dealing with them, but still, so far we did not. Only after the conference. All the companies are coming forward after the conference only.
And the other thing is, I think we have to build up the funds of our kitty. If our kitty is good enough, then I think the seed money can be provided to the organizers. They can return the money later, but I'm sure that seed money is required, and it may be to the tune of at least 10 to 20 lakhs if we want to organize a good conference. So we shall try in each and every conference that we shall save money and increase our kitty for future conferences. That's what I feel.
Sir, no harsh feeling, but from last year conference, Chennai conference, actually no contribution in our fund. It was 3.5 lakh which was handed over by Dr. Savita ma'am. That only we have utilized, not to the extent, but yes, 2.5 lakh was utilized. And rest all contributed by Dr. Sai sir and team. So we need to contribute from each and every zone. We have separate PAN card, we have separate account for the APR body. So everyone please try to contribute. So beforehand we can give money before the conference to be organized.
With the advent of all these indents, going to store department is becoming day by day difficult for us to get the sponsorship from the pharma companies. But still, in 6 months or almost 1 year in advance, we have to start pushing them and giving them letters 3 months in advance. And especially if it is near the financial end, year end or calendar year end, there is problem. So whosoever is going to conduct this conference, they have to start their groundwork, accumulating money 6 months in advance. That groundwork has to be started 6 months in advance. And I think those who have not organized any conference so far, NWR, NER, NCR, ECR, they may start thinking about it.
I think we have got our last chairman, Dr. Sushma, secretary cum treasurer also. She is in NER, so I think she shall ask her physicians to organize a meeting at NER, Gorakhpur. Yeah. Second, Dr. Gupta's. That's the only.
Everything was going on. I was just thinking कि NER का नाम बता and yes, okay, I don't know because I have not attended that, and after going through this conference, the moment I put my foot here in IRIFEM, I thought there is one similar in Lucknow also, but then that is in Lucknow. I am sitting in Gorakhpur, and it is just 3.5 days that I joined there. So it is too early for me. But before I conclude my tenure there, I promise you that I will try to have one conference there. It may not be the next, but next to next, yes. So it is too early for me to commit now. But before I said, that's what I'm telling now. There are still 2 years for me, and I'm planning to stay there. It is for everyone. If anybody wants to visit there, I will be there for 2 years. I'm not trying to shift from there, okay? So that is one thing. So it is too early for me. I cannot commit now. But definitely it is in my mind, and if possible, because at Lucknow, because similar arrangements might be there, I haven't visited there, I haven't even seen the place there, okay? But if it is there, then I think once you have a good auditorium and the place of accommodation, then at least 50% job is done. And rest can be, of course, managed. And academic feast is readily available with doctors, very expert in their own fields, and having the lectures is not that difficult. That is my opinion. So I think somebody for this year, but maybe next to that I will, yeah. Yes. बना दीजिए.
Because we don't have any such auditorium, and coming to this place, I found that such a comfortable accommodation that I doubt I'll be able to provide there. So that's the main issue. Sir, I am at Patna only, but we don't have such a. So that will add to the expenses also. Is it? That will add to, because we don't have a railways auditorium there, sir. Yes. At the same time, accommodation is it's a new zone. We don't have such a large accommodation, and that too particularly in Patna, sir. नहीं you. Sir.
Almost, because I have conducted in 2005 in Vizag, which was a divisional hospital, because that time Dr. Nagaswaram was my PCMD, he wanted me to do it here. Because those time only physician used to come. Dr. D.K. Das was a physician, he was DGRHS, so he came. Otherwise, I find no PCMD and here, because now it has a trend that all the PCMDs, all the DGRHs, all the people should come. So your arrangement, your everything is going to be
good, sir. You raised this point. It was on the tip of my tongue. I wanted to ask this question in this forum. Now, previously, APRCON means it was only confined to physicians. But now what I find is PCMDs, when they write letters to the other zones, the other PCMDs are nominating so many CMSs who are non-physicians, so many I am not against any general duty doctor or any non-physician. But what happens in such a thing is the number gets doubled and we have to take care of so many CMSs and all. The logistics become difficult, the cost escalates. And and there is no registration fees. And we have to. And this is what happens. There's a financial crunch.
Also,
so let the House take a decision on this matter. Sushma Madam is PCMD North Eastern Railway. Please tell something.
Health is no more in your area, like health inspectors are there to take care of them. So it becomes very difficult actually. And regarding this company, it happens in all the conference, only railway. Even outside, they don't give money up to 6 months, because I have been treasurer in some year, they don't give.
Then should we conduct webinars from next week?
It's a very important point and very valid also. And since last 2-3 years, when I'm seeing the conferences are being arranged, even at Perambur also, what I observed is there is too much of, satkar. So that is not the aim. हाँ, hierarchies and all, वो इतना ज़्यादा की ज़रूरत नहीं है. What we want is, we want it to be focused on academics. And this another point, from which we always deviate, railway working of physicians. That should be the point of discussion. And with another, means I'm happy that at least few of physicians are listening and some are really very young. In our own days, treating the patient we used to take pride in that. मेरा patient मेरे पास रहेगा, till end रहेगा. आज तो with the everybody is thinking कि कब ये मेरे पास से private में चला जाए, तो कोई headache ही ना रहे. And even railway board's policies are also pro referrals. They are giving something, liberalizing everything. So patients want to go to that chakachak hospital, corporate hospitals. And another trend which is seen, physicians are facing it. The patients who need to be taken care of, though they are our parents, our elder relatives, nobody wants to stand beside patient. सबको अपने काम पे जाना है. तो if the patient is admitted in private ICU, they are very happy. आपको वहाँ खड़े ही नहीं रहना है. जब कभी फ़ोन आएगा तब चले जाओ, तब तक आप अपना काम करते रहो, आराम से रहो. यहाँ अपने हॉस्पिटल में we ask them to come, be there with your patient. And in Mumbai, what I have seen is, if there are 4 persons in the family, all 4 are going on, they are going for work outside. And if they don't go on work, then they are removed from their job. Then they have to search another. That is also a genuine problem. But, all that has resulted, and plus the attitude of our physicians. Nobody want to stand for that patient, you know. पहले कैसे था कि हम लोग अगर पेशेंट ने कहा कि मुझे प्राइवेट भेज दो तो कहीं हमारे मन में टिस उठती थी कि मेरा पेशेंट क्यों मुझसे बाहर जा रहा है, ही इज़ नॉट लाइकिंग माई ट्रीटमेंट, ही वॉन्ट्स टू गो आउट टू अदर कॉरपोरेट हॉस्पिटल. अभी ऐसा नहीं है. तो मुझे ऐसे लगता है कि with so many physicians coming in railways, the standard of quality of to our patient should improve. एक फिजिशियन 2 फिजिशियन रहते एक हॉस्पिटल में जितना ट्रीटमेंट होता था उससे आज ज़्यादा होना चाहिए. मोर पेशेंट शुड, आवर OPDs शुड बी फ्लडेड पेशेंट्स, आवर वार्ड्स शुड बी फ्लडेड विथ पेशेंट्स. 50% से ऊपर ऑक्यूपेंसी ही नहीं जाती है बहुत सारे हॉस्पिटल में. That should change with so many physicians there, na, that should change. And change has to begin from us. हमसे ही शुरू होना है. So let us take this decision. We may not ask for others. We can ask for only physicians. And we would like, and let us start it from next time only. If we conduct in Patna, it's fine for only physicians. And let everyone support that. Yes, this is physicians conference, academic, and another thing is working of railway physicians in our railway hospital. That should be more focused. आपको बाकी पे भी मिल जाएंगे. But because of experience physicians, their opinion on different cases which we handle find difficult too. That I'm talking of younger physicians. That should be discussed more. Let them come more problems, how to tackle these. And the physician conference, railway physicians conference should be for that only. That is my opinion. Now, Dr. Sai and Tim will decide what they want to say.
When we are sending letter, that time the suggestion should be given that only APR members to be nominated. And if not APR members are nominated, apart from the zone which is organizing the conference, there should be registration fee. If APR decides that in the GBM, if we decide that non-APR member ke liye fee hoga, conference registration fee, so then the number will automatically come down and some money will come to the kitty of APR. Yeah. So this has to be passed in GBM if it is means like everybody. That I suggested last time that all the new physicians are to be member of API, and I was sitting with the receipt. Where is receipt? To make the members new members, because
it has been circulated, the form has been circulated for new membership, QR code has been given. See, sir is even upset. Morning mein there were so young physicians. Now currently there is not a single young physician. I have got receipt book, I have got check book, I have got a passbook, everything, but not a single person has paid.
Tomorrow morning, you should be sitting there in the registration counter or in the front row. Whosoever comes, pakdo usko karo. Last time we did that. 33 new members I have created before giving charge. 1,000 rupees, not big amount.
And same point which I would like to highlight, which you said, we will announce that those who are not members are not allowed to come for next conference.
Yes, that is to be.
That is one point that
and that is to be decided in the GBM itself. It has to be compulsory. That person has to be APR member to attend the conference.
So with suggestion of all the members available here, all the physicians available here, I propose that all the physicians should be nominated for the APR conferences. Only physicians should be nominated for the APR conferences, not GDMOs. If GDMOs are nominated, it should be for their respective zone only. And with permission of chair, it is approved. So I request Sai sir to approve that.
I approve this policy.
We can request all the senior physician of the zone. Like if I am in East Coastal, I have 3 physicians, it should be my duty to motivate them and get them here. Because it is not the question of 1,000 rupees they will not give. They think that we have to motivate them, and because so all the senior physicians of the zone, they can have the list of their physicians in their zone and they can request and motivate them.
Sir, actually no one stayed back. We don't know their names. We don't know from which zones they are.
But going back, we will have their list, and they are pretty junior. They are working under us. We can get it done. Yeah, because but now I think because we don't have a now A in API earlier there should be a railway chapter used to be there, but now it is not there. So we can have our A if somebody wants there, because now it is not a compulsion.
Be the member of APR and preferably of API also.
Sushma, I think if we are associated with API, either you say now we have dissociated with API. If we are associated with API, and if we feel
valid and
that
important
API
topic,
is API is a part of API, which we mentioned last time also, that have been written to API.
Sir, yes, of course. Last time we did the correspondence, sir, and actually API did not respond to our requests. Even we asked them that our one member from APR should be there, railways from should be there, opted like from armies. They have one member, physician member from armies. So like that, they should have one railway member from railway physicians also. That was also we put last time, but it didn't go further, sir. We did the correspondence.
So what is the status of API? It's not a part of API.
I'm not saying that it's not the part, but if it is a part, then there are no signs that it is a part, because API is not owning up. It is not even responding to our request, the latest which we wrote.
API office is in Mumbai only.
Yes, sir. We talked. After talking with them only, we send the letter, Dr. Savita. And you again do the...
We carry forward that,
yes,
sir.
Yes, you carry forward it.
We do the correspondence
yes, we
with
did
API.
Yes. Yes, sir, please.
Definitely,
yes,
sir.
Yes. Yes.
Okay.
Because last time was also it was decided, and after talking to everyone, the letter was sent, but there is no response. Let us take it further. Again, you do the follow-up, and yes.
Okay.
Yes, that you will get.
We will carry forward that correspondence which was done by
Yes.
Mate madam and Savita ma'am,
Yes.
and we'll see to it that
Yes. That was the clause which we kept till today. It is true till today because we haven't changed it yet. So, and it is all, of course, advice to all the younger physicians that they should be member. Why not? They have to be member of our parent association, है ना? वो तो होना ही है.
So, Kaushal sir, I think you are giving it a thought about conducting a conference next year. So, I matlab, okay. So regarding conference venue, few sir has come forward, and further communication with regarding confirmation will contact with sir, and if he is ready, then we'll decide the venue within coming 1 month. So. Yes, like ma'am said ki NCR, NWR, NER, ECR and ECOR. These are the 5 zones with whom I will coordinate and talk to the senior most physician there, and I'll coordinate, and if anybody of them is ready, I'll declare the conference venue within 1 month. So
Yes, we have to have some contribution to improve our kitty finances in our kitty. We should have a contribution, otherwise we cannot.
So few points to be discussed. Audit of the year. So we received last year we received amount of around 3,04,000. 3,04,000 मिले थे. तो उसके बाद तो कुछ हुआ नहीं, ज़्यादा खर्चा भी नहीं किया है हमने. उसके बाद एक कॉन्फ्रेंस हुई है. तो ऑडिट हम वी आर डूइंग द ऑडिट दिस मंथ एंड ये कॉन्फ्रेंस का खर्चा वगैरह का ऑडिट जो है वो नेक्स्ट ईयर के कॉन्फ्रेंस जब होगी वहाँ पे वो खर्चे का सब ये बताएंगे. यस यस वी आर फाइलिंग. यस. So any other subject with permission of the chair? Any other subject you want to talk on?
Introduction.
New physicians, they can introduce themselves. Yes. New members here present here. I think Dr. Karthik is there, na? So you introduce yourself.
Respected dignitaries and on the stage and off the stage, and my HOD ma'am and my in charge ma'am. Myself, Dr. Karthik Reddy Konutala, and I did my DNB General Medicine in JRH, Jagjeevana Railway Hospital, and I'm presently working in Health Unit Rayagada, which is going to be a new division under East Coast Railways. Yes. Thank you. Sir, already I transferred the amount, sir. Yes, ma'am. Yes, ma'am.
Good evening, respected seniors. Myself, Dr. Hussain. I am posted as DMO Bangalore. Previously, I was in ECR. I had been in touch with Kaushal sir, and then I was in Western Railway I did my DNB in JRH, where Savita ma'am was my HOD and Trupti ma'am was my consultant. And now I am in Southwestern Railway as a Bangalore, DMA Bangalore.
Good morning, all of you. You have been seeing me since morning. I am Dr. M.V. Aditya Kumar. I am Senior DMO Nephrologist and Physician. I did my MD in AFMC Pune in 2016 and I have completed my DM in Nephrology in 2024 from Kurnool Medical College, Kurnool. Presently, I am looking after, presently I am working in Lalagoda as Nephrologist and Physician. Thank you.
Good evening, everyone. I'm Dr. Jyotsna, working as DMO Central Hospital, Lalagoda. I have done my DNB from Sri Gokulam Institute, at Salem. post MD, I had joined as assistant professor in Gandhi Medical College. Later, I had joined Railways. My first posting was in Central Railways with Mate Madam, and later I was transferred to South Central Railways. Thank you.
Good evening, everyone, and MD East Coast Railway, Dr. Pradhan sir and Sai sir, well organized this one. Myself, Dr. Mangilal from East Coast Railway, working as Senior DMO, Visakhapatnam. I did my MD, INHS Ashwini, Kolaba, Mumbai. So currently I am working as a Senior DMO, Physician, Visakhapatnam. Thank you.
Good evening, everyone. I am Dr. Vishwanath. I am DMO working at Central Hospital, Central Railway, Baikala. I have done my MD from Army Hospital, RR, Delhi, and post that I have got posted at Central Hospital, Baikala.
Okay, then we close the meeting then. Not yet decided. We'll give the next conference venue within 1 month after discussion with all the zones.
We have to write to Railway regarding something, because now for going to conference on duty, only for patient they are only recognized. You are being a physician in the railway, you have to manage cardiology, you have to manage rheumatology, you have to manage all sort of RSSDI. So there are lots of associations which have not been recognized by railway. So your accounts can only you have to go to API. So API you don't want to do it. I should go for the conference of my own interest. One, let us sponsor one conference, let the region decide to because the conference fee is of India is highest. If you go to some other conference like APRCON, go and it will cost equal. The decision should decide to one year you go to RSA, next year you have to
Dr. Pradhan, there was one circular from Railway Board Aditya showed me once regarding addition of extra body, professional bodies for recognition. I think you have that circular. Yes, please share in the APR group. We have to write. We didn't write back to the Railway Board to add up all these things. So yeah.
I'll tell you one details. The proposal which we did in Central Railway we asked each and every doctor of our Central Railway, not our now, previous. So there are 140 doctors in Central Railway, and we circulated amongst them that everyone has to write down which conference they want to go on duty. And we have taken feedback from each of them. Some doctors have given two choices. But our PCMD and myself, we sat down, and for every doctor we allotted one conference according to their preference. They have given 2 or more according to their preference. Because alternate arrangement also to be done. If there are 5 physicians and 5 are asking for the same conference, we cannot allow them. But you were allowed 2 to go for that, and then 2 for another, and 1 for another later. So that we did the whole exercise, and every doctor is covered in Central Railway for at least one conference of their choice for this year, 26-27. When every doctor is covered. Now you will ask what about GDMOs? Even for GDMOs, we wrote down that whatever is the local IMA conference is going on, they should be nominated on duty. Means they will get registration fee also for that, and of course whatever is the on duty CL because they will get socially. See what? So those who are really interested can take the homework from central railway and can implement in their own railway. And even if you even one or two is do this homework, then even collectively we can ask DG sir replicate it everywhere. So all doctors will be covered only at least for one conference. It's not restricted, it should not go for 4 conferences, but that will not be on duty nominated by PCMD. That will be on their own expenses and all, their own leave and own passes, but one on duty. So because there in railways, there is no of funds for training. We see people going abroad and getting training. We don't know what extra they are doing in their work after training. But they are getting training on railway account, and why doctors should be spared? Rather, doctors should be updated regularly. If a health unit doctor is sitting there for years together, not attending any conference, how will we expect him to update his knowledge? Even if he is a GDMO, he needs to update his knowledge. Rather, he has to update in all fields. At least as a physician, physician take topics सुनूंगी, but वो जो health unit में बैठा उससे तो delivery में रिजल्ट क्या हो रहा है वो भी देखना चाहिए, तभी कुछ देखना चाहिए उसके सामने तो सभी पेशेंट आ रहे हैं. So this is my suggestion that you can ask your own railway, get that homework and get it implemented in your railway also. Because I have joined now in India, I will try to do it in India.
Madam, your finance may be very in central railway that they listen to you because finance is looking at the railway board circular. So railway board all some 78 ka. But they are telling only those bodies which are approved by railway. IMA is approved, API is approved, nothing else is approved for you. Surgeon ka hai, but for physicians you have only API approved, nothing else. You can't go to RSHDI, you can't go to APRCON, you can't go to critical.
Yes.
CL क्यों लेके जाए? एक कॉन्फ्रेंस हम डी हुए, हम कोई भी कॉन्फ्रेंस है CL लेके क्यों जाए?
We have made a proposal which is approved by PCMD and then again further approved by AGM, because AGM is in our medical matters, he is in charge of medical department. So it is approved by AGM. Once it is approved by AGM, now finance doesn't have any say in it. What is the role of finance is, we have, of course, and we have done it for the this lower slab of the registration fee, because you will see that registration fee also ranges from say 50,000 to 35,000 for the same conference. No, it's not even early, but because it is not possible decide 1 year in advance. But at least when the conference is there, then 3 months in advance, that is what we said. 3 months in advance, at least you should ask for the permission for that conference, that your willingness, that so I am going to APRCON, and then whatever is the slab registration fee, I should get it, and they say yes, and then you deposit the fee and you will get the fee refund. Yeah. So, of course it is, listen, of course it is reimbursement, because railway can put their money in APRCON account. You know how billings are done nowadays, you have to make third party account and all. It is very difficult, cashless. No more it is now. Everything has changed now. So you have to just take the approval of PCMD. Yes, GMO to hai, comprehensive approval is there. You have to show it and that I am going. And this is the registration fee, and the sanction of that registration fee, you have to put deposit the amount and you will get the refund. Refund you will get when you attend the conference and show the certificate that yes, you have attended, this is the certificate, then you will get your reimbursement of that. So that way, well,
Dr. Pradhan, you are the best person. Dr. Pradhan, you are the best person to conduct the next conference because you are MD of Mancheshwar Central Hospital. Kindly think over. My suggestion is that because we are ending the meeting without any next year venue.
Because in East Coast area we are sort of physician, so who will work? Basically, I have a, like, though it is a central hospital, it is less than a divisional hospital. So I have a ADM of probationer is there. So who will hear this thing? So you have to talk to my PCMD. But here in the central, because you have called all the PCMDs, at least you should have PCMDs here so that they should give the EA. They should take the EA.
ठीक है, one last
I'll give right in the.
ठीक है सर, बस
I'll give.
sir, okay sir, we'll discuss on this. And one last point was there, one new zone is coming up, that is South Coast Railway. So it was a suggestion from the Joint Treasurer, Dr. Shrikant, that Dr. Mangilal, Senior DMO, Walter, he has volunteered to work as a zonal member. So with permission of chairperson, I will add him as a zonal member of APR. So thank you. Yeah. Thank you so much.
చేంజ్ చేయాలి.
मुदाकरात्तमोदकं सदा विमुक्तिसाधकं कलाधरावतं सकं विलासिलोकरक्षकं मुदाकरात्तमोदकं सदा विमुक्तिसाधकं कलाधरावतं सकं विलासिलोकरक्षकं अनायकैकनायकं विनाशिते
On behalf of South Central Railway, Central Hospital, Lalaguda, it's our proud and prestigious moment and pleasure to invite you all for the inaugural function of All India Railway Physicians Conference 2026, organized by Central Hospital, Lalaguda, Secunderabad, South Central Railway. This conference is scheduled for 2 days, 15th and 16th May, started today morning at IRIFM campus with 150 delegates registered from all over India. We extend a warm welcome to our Director General, Dr. Jagdish Chandra Sir, and Madam Mrs. Dr. Usha Chandra. We welcome our Mrs. Vandana Srivastava Garu, our beloved General Manager, Mrs. Our General Manager is on the way due to some unknown work. We welcome all the PHODs, PCMDs, DRMs, PCMOs, CMS, CHDs, and madams, all the delegates and their families to this wonderful cultural inauguration and the cultural program. As there is some delay in the arrival of our GM, now we will proceed for the cultural program. Our cultural program starts with the Ganesha Stuti. I invite Mrs. Shravya Subramaniam, a classical dancer who is trained in Kuchipudi since 19 years under her guru Srimati Srilata Prasad. She holds a bachelor degree from NIFT Hyderabad and masters in performing arts from Central University. And now she is pursuing PhD in performing arts in Central University. She performed her Arangetram in 2015 and received CCRT scholarship. Shravya is a gold medal awardee of Nataraj Ramakrishna Award, a Doordarshan graded artist, a fellow of Indian Raga. She is being trained in Karnas and Natya Sastras under the Dr. Padma Subramaniam. She has presented over 70 solo and group performances and curates the Dvi Festival, which takes place in bringing the world-class artists to Hyderabad. 13th June, this 2026, marks the 4th day edition of the Dvi program. She has founded dance school Ajay, the dance chapter in Film Nagar, Hyderabad. Now I invite Srimati Shravya Subramaniam to give her performance. Please give her a welcome.
Namaste everyone. A very good evening to all. I am Shravya Subramaniam, a proud daughter of Dr. Padma. Upon her invitation and the invitation of all my beloved uncles and aunts over here who have been in railways for very long, I'm here today to share my art with you all. The first presentation of this evening is titled Tandava Ganampatim Bhavaye, a vibrant composition by the renowned Sri Balakrishna Prasad on the dancing form of Lord Ganesha. The piece begins with a poem describing the majestic form of Lord Ganesha, who bears Kapitta Hastas, grants boons, dances through various postures, removes obstacles, and even performs Navarasas before his own father, the Lord of Dance, Nataraja. The composition vividly portrays the four-armed dancing Ganapati and includes an intricate jati in the middle, showing Ganapati dancing amidst rhythmic patterns, musical instruments, and melodic swaras. An invocation filled with energy and devotion invites the audience to meditate upon his joyous cosmic dancing form. With this, I begin today's presentation. Thank you. Hope you all have a wonderful evening.
ఇరుకపిత్తాల ధరించి చిరుల పంచి ఇరుకపిత్తాల ధరించి చిరుల పంచి కరణభంగిమల్ వడి మార్చి ఇరుల ద్రుంచి కరణభంగిమల్ వడి మార్చి ఇరుల ద్రుంచి నర్తనాధీషు సముఖాన నవరసాల దరువులొనరించి నర్తనాధీషు సముఖాన నవరసాల దరువులొనరించి కరుణించు దంతిముఖుడు తాండవ గణపతిం భావయే తాండవ గణపతిం భావయే తాండవ గణపతిం భావయే అఖిలాండ కోటి బ్రహ్మాండ నాయకం 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 తాండవ గణపతిం భావయే ఖండిత స్వదంత పాశాంకుశ ప్రచండ కుఠారధర చతుర్భుజం ఖండిత స్వదంత పాశాంకుశ ప్రచండ కుఠారధర చతుర్భుజం 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 తాండవ గణపతిం భావయే అఖిలాండ కోటి బ్రహ్మాండ నాయకం తాండవ గణపతిం భావయే బాలస్వరూపం భవానీ సూతం బాలకృష్ణనుతం భావతీర్థం भावतीतं बालस्वरूपं भवानीसूतं बालकृष्णनुतं भावातीतं कालकण्ठसुतं नागाभरणं कालातीतं करुणानिलयं कालकण्ठसुतं नागाभरणं कालातीतं करुणानिलयं मूलाधारस्थितचिन्मूर्तिं मोदकप्रियं मोक्षदायकं मूलाधारस्थितचिन्मूर्तिं मोदकप्रियं मोक्षदायकं
यत्तां ततकुकुडीं कुतडीं कुतझें
तदैतय्यतय्यत्तं ततकुकुढिं कुकुझं तदैतय्यतय्यत्तं ततकुकुढिं कुकुझं तदैतय्यतय्यत्तं ततकुकुढिं कुकुझं त्रुगुर्तकताहतनं तरिततकुधीनतं ताळवाद्यसुस्वरजति विलसितताहतनं तरिततकुधीनतं ताळवाद्यसुस्वरजति विलसितताण्डव गणपतिं भावये अखिलाण्डकोटि ब्रह्माण्डनायकं ताण्डव गणपतिं भावये ताण्डव गणपतिं भावये ताण्डव गणपतिं भावये भावये
That was a graceful performance with fluid and elegance in every move. Every beat felt and every expression lived. Thank you so much, Shravya. Such a wonderful performance. And
Divya, I just want to know, I think this we have introduced as a Kuchipudi dance performance.
It is Kuchipudi.
But let us know just from the audience, do they know any other dance forms from our culture? Ma'am, would you like to try, ma'am? Any other dance forms you know, ma'am?
Can anyone list other major classical dance forms of India? We will give pass marks even if you mention 6 also. Please no ChatGPT. Our budget did not permit for arranging jammers. So, no cheating.
We need at least 6, ma'am.
Bharatnatyam. Bharatnatyam, Odissi, Manipuri.
Madam, 3 more.
3 more. Can I say ballet or it should be Indian?
Yes.
We need at least 5, ma'am.
Kathak. Sir, we want single person to say 6.
Bharatanatyam, Kuchipudi, Mohiniyattam, Perini.
That's a nice answer, ma'am. We have a small token of appreciation for you. Thank you, ma'am.
Okay, now let's call upon Dr. Mahendra sir, ex-CMS, to perform his song. Sir, please welcome.
Hello. Good evening, everyone. Respected GM ma'am, respected all PCMDs. एक मोहम्मद रफ़ी नहीं, महेंद्र कपूर जी का गाना पेश कर रहा हूँ। और मेरा नाम महेंद्र है। मैडम ने कहा कि मिसेस ने कहा कि आप महेंद्र कपूर जी का ही गाना पेश कीजिएगा। ये गाना जिसमें वो अपने माशूका से कुछ गुजारिश करता है, लेकिन मैं समझता हूँ मैं आप लोगों से इस गाने के थ्रू कुछ गुजारिश करना चाहता हूँ। पेश है। बहुत पुराना गाना है, बहुत मधुर गाना है, बहुत मज़ा आएगा।
got it.
एक बार लोड कर लो, नहीं तो फिर मैं बाद में गाता हूँ, नहीं तो गाने में फिर रुक जाएंगे तो। So let's give another person chance. Give another person a chance. Till that time it will be loaded. Otherwise it will be breaking. Like I won't be able to sing. I won't be able to sing.
Okay.
Ask someone else. Then after I'll ask you to load it.
Divyaj, I think just in the meantime when the karaoke gets loaded, I think we'll just ask an audience one question.
Anybody is having their birthday today? Please don't have any expectations. We are not having any cake. Would just like to know. Anybody having birthday at least this week? In plus or minus 10 days?
When is your birthday, sir?
We have one.
Sir, when is your birthday?
When is your birthday, sir?
3rd of May.
3rd of May.
3rd of May.
Please bring him here, ma'am.
Ma'am, can you just come forward to receive your advance birthday gift?
Can we all wish him happiest birthday to this youngest soul?
Advance birthday wishes. Okay, I think our performance is ready. Sir, are we ready to start?
Ready. I don't know whether the system is ready or not.
Huh?
लुटाता रहूं, तुम मुझे देख कर मुस्कुराती रहो, मैं तुम्हें देख कर गीत गाता रहूं, तुम मगर साथ देने का वादा करो, मैं यूं ही मस्त नगमे लुटाता रहूं। कितने जलवे फिजाओं में बिखरे मगर मैंने अब तक किसी को पुकारा नहीं। तुमको देखा तो नजरें ये कहने लगी, हमको चेहरे से हटना तुम मगर मेरी नजरों के आगे रहो, मैं हर एक शय से नजरें चुराता रहूं, तुम मगर साथ लेने का वादा करो, मैं यूं ही मस्त नगमे लुटाता रहूं। मैंने ख्वाबों में बरसों तराशा जिसे, तुम वही संगे मरमर की तस्वीर हो। तुम न समझो तुम्हारा मुकद्दर हूँ मैं समझता हूँ तुम मेरी तकदीर हो। तुम मगर मुझको अपना समझने लगो, मैं बहारों की महफिल सजाता रहूं, तुम मगर साथ देने का वादा करो, मैं यही मस्त नगमे लुटाता रहूं। मैं अकेला बहुत देर चलता रहा, अब सफर जिंदगानी का कटता नहीं। जब तक कोई रंगी सहारा ना हो, वक्त का फिर जवानी का कटता नहीं। तुम मगर हम कदम बनके चलते रहो, मैं ज़मीन पर सितारे बिछाता रहूं, तुम मगर साथ देने का वादा करो, मैं वही मस्त नगमे लुटाता रहूं, तुम मुझे देख कर मुस्कुराती रहो, मैं तुम्हें देख कर गीत गाता रहूं। Thank you very much.
Thank you, sir. That was a great beginning for a musical cultural night today, sir. Thank you for your performance. So, Divya, what what do we have
Looking
next
for a
now?
reliable laptop at a budget-friendly
Let us
price
welcome our
point?
youngest
Sahas
performer
Zero
of the
Waste
day,
provides refurbished
Kumari
laptops
Adya,
that offer a smart and sustainable alternative
for
for
her
buying new
Kuchipudi
laptops.
performance. Yes, we
Every
know
laptop
again
goes through
Kuchipudi
30
performance,
quality checkpoints
but
to
this time
ensure
with very
performance,
tiny feet.
functionality,
Please
and
give some
reliability.
attentive presence.
Visit our website
Let's all welcome her with a grand round of
for assured
applause.
quality and affordable refurbished laptops.
Okay, issue with loading. So we would like to know. I know we take care of everybody, but we are very poor at self-care. Many of us, I know that. So we have an interesting question. In this hall right now, who is sitting with a mobile with the least battery? Anybody with less than 5%? Nirmala madam, I don't think you are having that. Anybody with less than 5%?
Anyone with less than 10%?
Less than 5%. We haven't response. Please. How much? We need proof. Please come to the stage, sir.
So what's your battery percentage? So you're watching YouTube, that's not fair, sir. We're doing such a wonderful cultural program. Okay, sir, is 38%. 38 is not low.
My
Anyone
voice
else?
is audible, right? The back seats. I said less than 5%. Less than 10%. Sai, sir. Less than 10%. Less than 15%. Where is Dr. Harish, our ophthalmologist? What's your battery percentage? Sir, to all of you, I would like to share this experience. Once a week, I get call from him. See, he's a colleague, right? Obviously, we think that it is something important. Every time, whenever I take his call, Madam, sleeping charger unda? Do you have sleeping charger? Once I was sick and I got his call. So I thought, it feels good, right? Our colleague is trying to check on us, how you are doing. So with that so much happiness, I took his call. And what all I got to hear is, Madam, sleeping charger unda? I got so pissed off. I said, Harish, I'll organize some fundraising and I'll gift you one sleeping charger. So today I was sure that he's going to win. Awesome, your battery is full, Harish. So basically your battery is low only at work.
Looks like everybody's charged up now.
Nobody is having any low battery mobiles. What about our loading, please? Okay, let us welcome Adya now.
అలమేలు మంగ ఈ పచ్చల కడియాల పణతి చలంగ వచ్చెను అలమేలు మంగ ఈ పచ్చల కడియాల పణతి చలంగ వచ్చెను అలమేలు మంగ వచ్చెను అలమేలు మంగ బంగారు చేది వినీలు బంగారు చేది వినీలు పూని శృంగారవతులు వేవేలో రాగా బంగారు చేది వినీలు పూని శృంగారవతులు వేవేలో రాగా రంగైన విల్జామరలు వీవా రంగైన విల్జామరలు వీవా మాంగల్యలీల సొంపగు జవరాలు మాంగల్యలీల సొంపగు జవరాలు వచ్చెను అలమేలు మంగ ఈ పచ్చల కడియాల పణతి చలంగ వచ్చెను అలమేలు మంగ పలుకుల తేనియలోలుగా పలుకుల తేనియలోలుగా చెంత చిలుకలు కలకల పలుకా పలుకుల తేనియలోలుగా చెంత చిలుకలు కలకల పలుకా ప్రబల గెలుపు పావలు ముద్దుగులుక మీటి కలికి చూపుల మొనలు తడుకని చిలుక వచ్చెను అలమేలు మంగ ప్రబల గెలుపు పావలు ముద్దుగులుక మీటి కలికి చూపుల మొనలు తడుకని చిలుక వచ్చెను అలమేలు మంగ ఈ పచ్చల కడియాల పణతి చలంగ వచ్చెను అలమేలు మంగ రంభాది సతులెల్ల చేరి రంభాది సతులెల్ల చేరి ఎదుట గంభీర గతులను మీరా రంభాది సతులెల్ల చేరి ఎదుట గంభీర గతులను మీరా నటనారంభములను మేలు కోరి నటనారంభములను మేలు కోరి కొలువ అంభోజాక్షుడవు వెంకటేశునొయ్యారి అంభోజాక్షుడవు వెంకటేశునొయ్యారి వచ్చెను అలమేలు మంగ ఈ పచ్చల కడియాల పణతి చలంగ వచ్చెను అలమేలు మంగ ఈ పచ్చల కడియాల పణతి చలంగ వచ్చెను అలమేలు మంగ వచ్చెను అలమేలు మంగ వచ్చెను అలమేలు మంగ
Wow. They say young hearts have purest emotions. emotions. It is so lovely to see those emotions turned into dance form. Thank you so much, Adya, for immersing us in the beauty of classical dance. Let us give her a big hand for talent shown by such a young girl.
Now we have Dr. Shishir Kumar Raul, who would like to present Shairis before us. But I was just saying this, very apt for this cultural event tonight. मुस्कुराहट के साथ आपका स्वागत है यहाँ, खुशियों से रोशन हो आज का ये समा. वेलकम डॉक्टर शिशिर सर.
Put your shoes on. Raise the volume.
Good evening one and all. Respected DG sir, ma'am. DG sir, मैडम के लिए आज इवनिंग में हमारी सबकी तरफ से दुआ है. सर हर सुबह आपको सलाम दें, हर फूल आपको मुस्कान दे. हम सब की दुआ उसी की दरबार में है. खुदा करें आपकी हर कामयाबी को वो नई आसमान दे. यहाँ चेहरे नहीं इंसान पढ़े जाते हैं, यहाँ मजहब नहीं ईमान पढ़े जाते हैं. यहाँ चेहरे नहीं इंसान पढ़े जाते हैं, यहाँ मजहब नहीं ईमान पढ़े जाते हैं. मेरा भारत इतना प्यारा है मेरी दोस्त, यहाँ एक साथ गीता और कुरान पढ़े जाते हैं. हम अपनी जान की दुश्मन को हम जान कहते हैं, मोहब्बत की इस मिट्टी को हिंदुस्तान कहते हैं. हम अपनी जान की दुश्मन को हम जान कहते हैं, मोहब्बत की इस मिट्टी को हिंदुस्तान कहते हैं. और ये जो दीवार में सुराग है, ये जो दीवार में सुराग है वो साजिश का हिस्सा है. ये जो दीवार में सुराग है वो साजिश का हिस्सा है, मगर इससे हम हमारे घर का रोशनदान कहते हैं. टूटने और बिखरने का चालान मांग लिया, हम तो हालत से शीशा का बदन मांग लिया. टूटने और बिखरने का चालान मांग लिया, हम तो हालत से शीशे का बदन मांग लिया. हम भी खड़े थे तकदीर के दरवाजे पर, हम भी खड़े थे तकदीर के दरवाजे पर. लोग दौलत पे गिरे, हम तो पतन मांग लिया. कुछ रास्ता लिख देगा, कुछ मैं लिख दूंगा. तुम लिखते रहो मुश्किल, मैं मंजिल लिख दूंगा. कुछ रास्ता लिख देगा, कुछ मैं लिख दूंगा. तुम लिखते रहो मुश्किल, में मंजिल लिख दूंगा. आंख में समंदर और दिल में आग लिख दूंगा. तुम तूफान लेकर आओ, मैं चिराग रख दूंगा. मेरा पर काट लो, कुछ फ़ायदा नहीं. मेरा पर काट लो, कुछ फ़ायदा नहीं. मैं ज़मीन पर भी बैठा ना, ये आसमान लिख दूंगा. सुला चुकी थी दुनिया थपक थपक के मुझे, जगा दी तेरी पाजीब ने खनक खनक के मुझे. सुला चुकी थी दुनिया थपक थपक के मुझे, जगा दी तेरी पाजीब ने खनक खनक के मुझे. कोई तो बताओ मैं इसका इलाज क्या करूं, परेशान करता है दिल धड़क धड़क के मुझे. ये राज मोहब्बत की है, ये राज मोहब्बत की है, छुपा लेंगे. ये राज मोहब्बत की है, छुपा लेंगे. तुम आओ तो सही, ये जख्म दिल हम सिला लेंगे. तुम आओ तो सही, ये राज मोहब्बत की है, छुपा लेंगे. तुम आओ तो सही, जख्म दिल हम सिला लेंगे. तुम आओ तो सही. माना कि शहर मशहूर है मेरा अंधेरों की शहर, माना कि शहर मशहूर है मेरा अंधेरों की शहर. हम तो चांद को भी आंगन में उगा लेंगे. तुम आओ तो सही. कुछ लोग हर मोड़ पर रुक रुक कर सोचते क्यों हैं, इतना सोचते हैं तो घर से निकलते क्यों हैं. कुछ लोग हर मोड़ पर रुक रुक कर सोचते क्यों हैं, इतना सोचते हैं तो घर से निकलते क्यों हैं. मैं ना जुगनू ना दिया ना तारा हूँ, मैं ना जुगनू ना दिया ना तारा हूँ, लेकिन ये चमकने वाले मेरे नाम से इतना जलते क्यों हैं. नींद से कोई रिश्ता में नहीं है सालों से, नींद से कोई रिश्ता नहीं है मेरा सालों से, लेकिन ये सपने आकर मेरे छत पे टहलते क्यों हैं. मोड़ तो होता है हर दीवाने को संभालने के लिए, मोड़ तो होता है हर दीवारे को संभालने के लिए, लेकिन लोग आकर यहाँ फिसलते क्यों हैं. ना पीने का शौक था, ना पिलाने का शौक था. ना हमें पीने का शौक था, ना हमें पिलाने का शौक था. हमें तो सिर्फ नज़र से नज़र मिलाने का शौक था. ना हमें पीने का शौक था, ना हमें पिलाने का शौक था. हमें तो सिर्फ नज़र से नज़र मिलाने का शौक था. मगर कमबख्त हमारी नज़र उस नज़र से मिल गई जिससे नज़र से पिलाने का शौक। नज़र से नज़र को चाहने लगे हैं, नज़र पे नज़र का निशाना लगा है। नज़र पे नज़र को चाहने लगे हैं, नज़र पे नज़र का निशाना लगा है। कुछ पल, इन पलकों में हमें रहने दीजिए, यहाँ तक आते आते हमें जवाना लगा है। ये राज हर दिल भी रोएगा, महफिल भी रोएगी, हर दिल भी रोएगा, डूबेगी कश्ती हमारी तो साहिल भी रोएगा। महफिल भी रोएगी, हर दिल भी रोएगा, डूबेगी कश्ती हमारी तो साहिल भी रोएगा। इस दुनिया में इतना प्यार मोहब्बत बांटो मेरी दोस्त, हम जाने के बाद हमारे आशिक तो क्या, हमारा कातिल भी रोएगा। जहाँ तेरी याद न आए वो तन्हाई किस काम की, ये बिखरे रिश्ते नौ बना दे वो खुदाई किस काम की। जहाँ तेरी याद न आए तन्हाई किस काम की, बिखरे रिश्ते न बना दे खुदाई किस काम की। बेशक हम सबको जाना है मेरी दोस्त, बेशक हम सबको जाना है अपनी मंजिल तक मेरी दोस्त। जहाँ से ये अपनों दिखाई ना दे वो ऊंचाई किस काम की। तेरी रोशनी से वहाँ चांद रूठा बैठा है, तेरी रोशनी से वहाँ चांद रूठा बैठा है। जब चाहा मैंने तुझे तो टूटते हुए तारा देखा है। तेरी रोशनी से वहाँ चांद रूठा बैठा है, जब चाहा मैंने तुझे तब टूटते हुए तारा देखा है। तेरी जैसा महक यहाँ किसी भी फूल में नहीं है, यकीन कर मेरा मैंने हर बाग देखा है। कसर किसी ने नहीं छोड़ी, सच कसर किसी ने नहीं छोड़ी। बस तेरा खुरेदना बाकी है, तेरे बाद मेरा बिखरा घर समेटना बाकी है। कसर किसी ने नहीं छोड़ी, बस तेरा खुरेदना बाकी है, तेरा बाद मेरा बिखरा घर समेटना बाकी है। मैंने सोचा इससे ज़्यादा बर्बाद में क्या हो जाऊंगा, मैंने सोचा इससे ज़्यादा बर्बाद में क्या हो जाऊंगा। फिर याद आया अभी तो उससे और किसी के साथ देखना बाकी है। आखिर में 2 लाइन। अपनी मंजिल भुलाकर जिया तो क्या जिया, अपनी मंजिल भुलाकर जिया तो क्या जिया। दम है तुझ में तो उसे पाकर देखा, अपनी मंजिल भुलाकर जिया तो क्या जिया। दम है तुझ में तो उसे पाकर देखा। लिख दे खून से अपनी कामयाबी की कहानी और बोलो किस्मत को, दम है तो उसे मिटा कर देखा। हंसना और हंसाना कोशिश है मेरी, हर कोई खुश रहे ये चाहत है मेरी। हंसना और हंसाना कोशिश है मेरी, हर कोई खुश रहे चाहत मेरी। भले मुझे कोई याद करे या ना करे, हर अपनों को याद करना ये आदत है मेरी। गुड नाइट, गुड नाइट।
Thank you, sir. Everyone's smiling faces are showing that everyone enjoyed your shayari, sir. Thank you. Now, let's have some audience questions before we are ready for our next performance. So, can we have the questions, please? Okay, so the just clue for these answers are wherever we go, we don't forget our profession. So, can anyone guess this? Who am I? Related to our profession, who am I? Ma'am, you would like to give a try? Who am I, ma'am?
Medical student, madam.
I think more specific, ma'am. Let's have the answer. This is a PG restaurant. Lots of coffees to stay awake, books to read, but always feeling sleepy. Okay, so let's have a next question again. Who am I? Always on toes, ready to treat. That's a clue. Right, ma'am. On-call doctor. Nirmala, ma'am. Ma'am, prove that she is the PCMD of SCR. Next question. Okay, this one. Always sleepy, but having coffees, but still sleepy. Who am I?
Night duty doctor or night of doctor?
Let's have the answer.
Okay.
Correct, it's night duty doctor. Ma'am, again you prove that you're admin putting duty rosters, ma'am. Next question. Okay, who am I? Always writing, but do not know what they're writing. Or either orders from their seniors or their professors. Right, ma'am. PG resident is the right answer. Intern.
Okay, I'm Doctor.
Who answered all the questions actually?
Okay. Dr. Mamta Sharma, PCMD Center.
Thank you. So we have a next performance ready. Doctor.
Let's call upon Dr. Akshata for a wonderful dance performance. She is IRHS doctor, but right now pursuing her PG in dermatology at our Central Hospital, Lalaguda.
அப்படின்ற
ਤੈਨੂੰ ਸ਼ਰਾਰਤ ਸਿਖਾਵਾਂ ਜਦੋਂ ਨੈਣਾ
महागणपतिम्
Usually people have some impression that, doctors are very serious, studious. But what everybody forget is application of medical knowledge itself is job of creativity. How can doctors cannot be creative? Isn't it? So please, we have gathered here to celebrate our own talent and spirit. Let it be problem with the loading, problem with the music system, problem with electricity. I mean, these are all nothing new to us. In all the constraints we are working, so let us not down our spirit by these small issues. And sitting there is very easy, but among all of us, maybe all of us may not enjoy the song. Some like only song, some enjoy only dance, some only classical form, some only mass beat. But coming here onto the stage and performing something is really not a small thing. So whether it is your cup of tea or not, whether someone, especially doctors, out of their busy schedule is coming here and performing, and still you are just sitting and looking like some, Parkinson's patient kind of expression is not at all justified. So please, I request everyone, whether you like or whether you don't like, because we did not do any auditions. Whoever we perform, we just allowed, because we want to celebrate the spirit, not just something to impress others. So attending this program is actually at your own risk, but still, please let us clap hard and let us encourage our own colleagues.
Now we have another classical performance by Mrs. Shravya. Please welcome, ma'am.
For the second performance, I will be presenting a Javali. It's a musical composition that focuses mainly on expressions, storytelling, episodes, narratives, and likewise. The present Javali is in Telugu, Sarasamul Ade Tanduku. It portrays a young heroine, a young woman, who's caught between desire and social propriety. Her lover arrives under the cover of night, seeking to meet her, when she is overcome with fear and anxiety that people in her house might discover him. Torn between longing and fear, she attempts to send him away through persuasion, pleading, reasoning, and with command, revealing the emotional conflict between love and restraint. As the song proceeds, we will witness various conversations between the heroine and the hero. Later in the song, we will witness a small episode in which a mother with a child steps out into the street and sees the heroine and hero, and with her eagerness, she momentarily neglects the child and peers over the wall, only to discover to her amusement that at night there's a man and woman. Excited by the sight, she enthusiastically calls her neighbors to witness the scene, however, is put away. This playful Sanchari, which is an episode, introduces humor, social commentary, enriching the dramatic texture of the composition Javali. Thank you.
సమయమీది కాదుర నా సామి సరసమూలాడేటందుకు సమయమీది కాదుర నా సామి సరసమూలాడేటందుకు సమయమీది కాదుర నా సామి సరసమూలాడేటందుకు 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 సమయమీది కాదుర నా సామి సరసమూలాడేటందుకు విరసముతో నా ఇంటి వారలున్నారు విధి తప్పక కనుగొన్న కూడిన వేళ నాతో సరసమూలాడేటందుకు విరసముతో నా ఇంటి వారలున్నారు విధి తప్పక కనుగొన్న కూడిన వేళ నాతో సరసమూలాడేటందుకు సమయమీది కాదుర నా సామి సరసమూలాడేటందుకు నిగ నిగ వెన్నెల కాయుచున్నది నిక్కముగా నిడుల చేసేది తగదురా నిగ నిగ వెన్నెల కాయుచున్నది నిక్కముగా నిడుల చేసేది తగదురా ఈ విధిలో వచ్చువారున్నట్టున్నది నిన్ను చూస్తే నవ్వి తిట్టుదురు గనుక సరసమూలడేటదుకు శ్రీకాంత నీకేల ఎంత దూరము శ్రీనివాస నిన్ను ఈ వేళ పూర్యకు సరసమూలడేటదుకు సమయమీది కాదుర రాసామి సరసమూలడేటదుకు సమయమీది కాదుర రాసామి సరసమూలడేటదుకు సమయమీది కాదుర రాసామి సరసమూలడేటదుకు సమయమీది కాదుర రాసామి సరసమూలడేటదుకు
What a mesmerizing. And you know, everything is dance, but they say to watch a classical dance, we need very attentive presence. Dance is dance, but why we say that we need so much attention to watch a classical dance? Anybody know? Because while not just expression, while watching a classical dance, we have to appreciate rhythm and the precision of the footwork and details of the gesture and the graceful postures, and more importantly, expressions to understand their emotions. All these at once. So that's the reason they say we need very attentive presence for a classical dance. Whoever watched that performance with such presence, only they know that it is such an enchanting performance. And for those who do not know her, she is very busy with her dance institute and her PhD and all. She is here just because of her mother, our respected CMS Hyderabad Padma Madam. She is daughter of Madam. Only because of her, today we have that wonderful experience. Thank you so much, Padma Madam and Shravya. Now let me call upon Dr. Manjunath Sir, CMS Sholapur, to perform a song. Sir, please welcome. Meanwhile, we young doctors have some questions for the seniors. Mahita?
Let's just take some advice from your seniors. DJ sir, if you don't mind, I think you're the right person to ask this question. If you could remove one challenge in healthcare instantly, what would it be?
You have asked a very difficult question.
ఇక్కడ చేయరే వెళ్ళేటప్పుడు పాడతారు సార్ ప్లీజ్ సిట్ ఫర్ ఫ్యూ మినిట్స్
I can say station calls.
Thank you, sir. Next, we have one more question for our seniors. What is one quality today's young doctors should develop beyond clinical knowledge?
Sir, please don't tell soft skills. We have been hearing that from our seniors a lot. Yes, so anything other than soft skills.
Karate and martial arts.
Madam, we did not expect that.
Nice. Ma'am?
History take.
Again, back to our basic skills, which is very important.
Excellent patience.
Yes, sir. That's one thing I think all of us doctors should have. Any other answers, ma'am? Sir? Ma'am, what is one quality today's young doctors should develop beyond clinical knowledge? Patience listening. Yeah, that's right. Okay. So let's all learn from this as young doctors and hope we become more better doctors.
Thank you so much, sir. It was very soulful singing, sir. Thank you for showcasing your talent on this stage. Now we welcome our duo, Dr. Shanmukapriya and Dr. Harish, for a wonderful performance.
പുഞ്ചിരി തഞ്ചി കുഞ്ചിക്കോ മുന്തിരി മുത്തള ചിന്തിക്കോ മുഞ്ചണി വന്ന ചുന്ദരി വാവേ താങ്കുന്നക്ക തകതിയാടും തങ്കനിയാവേ
जिया चले जा चले नैनु तले धुआं चले रात भर धुआं चले जानू ना सकेरे जिया चले जा चले नैनु तले धुआं चले रात भर धुआं चले जानू ना सकेरे जिया जले
रूप सुहाना लगता है चांद पुराना लगता है तेरे आगे ओ जानम अरे रूप सुहाना लगता है चांद पुराना लगता है तेरे आगे ओ जानम ओ तू भी क्या चीज है हर दिल अजीज है दिल चाहे देखें तुझे हम हरदम रूप सुहाना लगता है चांद पुराना लगता है तेरे आगे ओ जानम रूप सुहाना लगता है चांद पुराना लगता है तेरे आगे हो जानम छैया 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 चल छैया 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 चल छैया 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 चल छैया 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 चल छैया 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 सारे इश्क की छाव चल छैया छैया सारे इश्क की छाव चल छैया पाँव जन्नत चले चल छैया छैया पाँव जन्नत चले चल छैया चल छैया 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 छैया
वो यार है जो खुशबू की तरह, जिसकी जुबान उर्दू की तरह, मेरी शाम रात मेरी कायनात, वो यार मेरा सैया सैया। चल छैया 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 छैया, चल छैया 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 छैया, चल छैया 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 छैया, चल छैया 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 छैया।
Thank you, Dr. Harish and Shanmugapriya ma'am. Again, this is a perfect example for professional justification. We had an excellent treat for our eyes and ears by an ENT specialist and ophthalmologist. Thank you. Next.
Now let us welcome our nursing brother, Anshul brother, to walk the stage. Actually, his is wildcard entry for this program. He was seen performing by someone somewhere, so he was caught up and now he is here. Brother, you know railway conduct rules. If administration says something, he has to come. Please welcome brother. As it is still loading, we have one more question for anybody. After these many years of services, is there anything or any case which still gives you tachycardia? After these many years of service, either some case or some situation. Manita.
Ma'am, your answer. Ma'am, please identify and then answer.
Dr. Anjana Malhotra, replants.
Dr. Kalyani, PCMD, Southern Railways. For a physician, always it is tachycardia, and you can feel your heart in your mouth whenever you are getting a call in the midnight that fetal distress. Then the physician distress starts.
Yes, madam. We agree. Madam, our question is, after these many years of service also, what is one thing that still gives you tachycardia, which increases your heart rate?
Kalya ma'am, just an addition to answer.
Anybody else have anything to share?
Ma'am, tachycardia not for you, also for physicians also, ma'am, when you have a call in emergency in gynecology, ma'am. Are we ready for the performance?
Our cardiologist Sai sir, every time he used to say ki, you know how it feels when we are in cath lab and when we passing that through the artery, and he used to say, but now I am sure if we ask him the same question, he doesn't say cath lab. He say organizing such conference gives me tachycardia. He was so tensed in last 1-2 days that I'm really wondering what would be the report if we do Holter monitoring to the sir for last 48 hours. Sir was really tensed, but sir, we want to let you know everything is going well. Please relax.
Okay, now we just have a song performance in between by Dr. Sandhya ma'am, senior DMO from Railway Factory.
Sabha ko pranam. In the spirit of not practicing and just singing, I'd like to present a song.
The song is called Moh Moh Ke Dhage.
madam. Such a soulful singing. Thank you so much, madam. And now this is going to be our last performance for tonight. Whoever is hungry, please, just for their information, this is last performance. We call upon to the stage our nursing brother, Anisant brother. Please welcome, brother.
Say D, say I, say S, C, say O, disco, 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 disco. तो झूमो, तो नाचो, तो झूमो, तो नाचो, हाँ मेरे साथ नाचो, गाओ. Oh, I am a disco dancer. I am a disco dancer. Oh, जिंदगी मेरा गाना, मैं इसी का दीवाना. तो झूमो, तो नाचो, आओ मेरे साथ नाचो, गाओ. I am a disco dancer. Oh, I am a disco dancer. Yeah. ये लोग कहते हैं मैं तब भी गाता था जब बोल पाता नहीं था. ये पाँव मेरे तो तब भी थिरकते थे जब चलना आता नहीं था. हो नगमों की मस्ती है मेरी जवानी में, है डांस मेरे लहू की रवानी में. यहाँ मेरी हार, यहाँ मेरी जीत, ओ यही मेरे गीत. तो झूमो, तो झूमो, तो नाचो, हाँ मेरे साथ नाचो, गाओ. I am a disco dancer. Hey, I am a disco dancer.
Wow, brother. Wildcard entries are always powerful, isn't it? Now you might have understood why he was ordered to perform in doctor's conference. Very rocking performance, brother. Thank you so much. Now, let us proceed towards inaugural function. Much for your patience and versatility of all our participants. Thank you.
అమ్మ 7 ఉన్నాయి. 7.
Before leaving you in...
We just want to introduce ourselves. I'm Dr. Mahita, DMO from Central Hospital, Lalaguda.
MD physician and very good Veena player who did not show any spirit to participate today. Myself, Dr. Divya Yamini, Senior DMO, Central Hospital, Lalaguda. Thank you so much.
We hope all of you have a wonderful evening. So let's just continue with our inaugural function. Thank you.
Thank you.
A very good evening to you all. Now we will proceed with the inaugural function. At the outset, we invite our chief guest of the evening, our Director General Railway Health Services, Dr. Jagdish Chandra, sir, onto the stage. I request Dr. Sai, CSS1 cardiologist, to escort our DG sir onto the stage. PCMD. I request our PCMD madam to felicitate sir with the shawl, memento. Our GM sir is on the way. Please, big round of applause. I request our PCMD madam to be seated on the stage. I request Dr. Chelagiri sir to come onto the stage to felicitate madam. I request Dr. Chelagiri CHD sir to come and felicitate our PCMD madam, Dr. Nirmala Rajan, patron of the conference. We take the opportunity to invite additional DG IRFM Sri Shanti Rajagaru onto the stage. I request Dr. Suvarna Jyoti to come onto the stage and felicitate sir. Welcome you, sir. I request our Chairman and Organizing Secretary of the conference, Dr. Sai, Chief Cardiologist of Central Hospital, Lalaguda, to come onto the stage. I think he is waiting. Okay. I invite Dr. Kapil, Senior DMO Baikula, Secretary of Railway Physicians Association, onto the stage. I request Dr. Jyotsna to come onto the stage and felicitate sir. Dr. Kapil. Sorry. Shall I invite the Organizing Secretary, Chairman, Dr. Sai onto the stage. I request Dr. Mahati to felicitate sir. Mahita. Now from the audience, we extend a warm welcome and our greetings to Dr. Usha Chandra Madam and also Srimati Vandana Srivastav Garu. I request Dr. Priya and Jyotsna to offer flower bouquet to Madam. I request all the dignitaries to participate in the inauguration lighting of the lamp. I request Shiva, Eno, to coordinate. I request our Chief Health Director, Dr. Chelagiri sir, to come on to the stage. I request Dr. Jyotsna to come on to the stage. All the dignitaries to participate onto the stage.
Manasa smarami mahaganapatim 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 मनसा स्मरामि महागणपतिं वसिष्ठवामदेवादिवन्दित महागणपतिं वसिष्ठवामदेवादिवन्दित महागणपतिम् महादेव सुतं
Dr. Sai, Organizing Secretary and Chairman of the conference, to give his welcome address. Thank you, sir. Now invite our PCMD Madam, Dr. Nirmala Rajara, to address the gathering.
Thank you, Padma. Now Sai has given welcome and our CHD is going to give thank you, so there's very little left for me to be said. So I'll take from both of them. First of all, welcome to you all for this conference. And I was going to say warmly welcome, then I thought warm may not be a good word because it's so warm in Secunderabad anyway. So heartily welcome. So I heartily welcome you all to this conference. I remember that the first APRCON was at Baikala in 1994. At that time, I was very young and enthusiastic, running around, and it stayed in my mind. And now I am very privileged to be able to host this conference now in 2026. And I hope you all enjoy your stay and enjoy the conference, and forgive us for any shortfalls, if there are any. Now I have to also infringe on Dr. CHD by saying thank you. First of all, I should say thank you to our DGRHS for so readily agreeing to come to Hyderabad in May, where it's so hot. So thank you so much for that. And our thanks to our general manager, who first said, okay, go ahead, so readily. If we had not said that, we could not have held the conference. So thanks to both of them. Thanks are also due to DG IRIFEM, because Madam very readily gave us both the auditorium, the venue, and also she has spared us 14 rooms for us to host our PCMDs. So Madam is not here today, so ADG is there in her place. Welcome, sir. So thanks are due to all of them. And we really had a tough time finding accommodation for everyone because we have more than 100 delegates. So we have kept our delegates in 4 places: IRIFEM, IRISET, Sitara, and at ORH. So this is the first time we have had so many delegates. I think this is going to be the largest conference ever so far held by the Indian Railways. In addition to the 100 outstation delegates, we also have our local doctors who will be more than 50 in number. We have a large number of physicians. Actually, in South Central Railway, we have 16 physicians in the zone. After some time now, we are going to be releasing a souvenir, and in that souvenir, you will see the photos of all 16 of them. So therefore, perforce, we had to, I pause here to welcome our General Manager. Welcome, sir.
We welcome our beloved General Manager, Shri Sanjay Kumar Srivastava. A big hand to him. Please welcome. Sir, we welcome you onto the stage. I request Dr. Sai, cardiologist, to fill state, sir. Sir.
That we have 16 physicians in our zone. So perforce we have had to post some of them in health units, but they are not any the less because they are working in health units and not in hospitals. All 16 of them have been involved in this conference, and we can see the photos of all of them in the souvenir that we are going to bring out right now. So there's nothing more to say except that I hope you have a good time and go back with happy memories. Welcome again. Thank you.
Thank you, madam. Thank you, madam. I take this opportunity to invite our additional DG ARIFEM, Sri Shanti Raju Garu, to read out the message of DG ARIFEM.
So, namaskar everyone. Respected Director General, Indian Railway Health Service, General Manager, PCMD, PHODs, DRMs and HODs of South Central Railway and the delegates. Srimati Aparna Garg, DG ARIFEM, was eager to be part of this function. Unfortunately, due to some engagement, she couldn't attend this program. It is my responsibility as ADG ARIFEM to deliver her message to this August gathering. Respected delegates, esteemed doctors, physicians and dear colleagues, it is a matter of great pride for ARIFEM to have such a profound gathering in its precincts. We became the nodal centralized training institute for Indian Railway Health Service with effect from Thursday, 16th January 2025. Though the foundation course for doctors started here in 2024 itself, the then PED Health and DGRHS put their seal of approval on this arrangement. The campus has seen more than 250 passionate and aspiring doctors since then. Event of this magnitude further reinforces the resilience and camaraderie of the railway family to which we all belong. Service to nation and to the organization, Indian Railways, is paramount. Financial health of the organization, physical health and capacities of all its HR constitute the foundational pillars on which its success and identity rests. ARIFEM personifies this by building the competencies of these three cadres: health, finance, and personnel. It fulfills the training needs of IRAS, IRPS, and Indian Railway Health Service officers. It is both a privilege and a profound responsibility to stand before those who dedicate their lives to the science and art of healing. Medicine is not merely a profession, it is a calling that binds knowledge with compassion, precision with empathy, and science with humanity. From the earliest days of civilization, the physician has held a sacred role in the teachings of Hippocrates, often regarded as the father of modern medicine. We find the timeless principle, I quote, "Wherever the art of medicine is loved, there is also a love of humanity." Similarly, the ancient Indian text, Charaka Samhita, reminds us that a physician must combine knowledge, skill, purity, and compassion, emphasizing that healing is as much about patient's spirit as it is about the body. Across centuries, these ideals have remained unchanged, even as medicine itself has advanced in ways once unimaginable. Today, you stand at the intersection of cutting-edge technology and timeless ethical duty. You interpret complex diagnostics, harness innovations, and make decisions that can alter the course of lives with moments. Pause for a moment and reflect on this sentence and internalize the important role each of you will play in the lives of millions. Be patient to treat a patient. Have time to talk and heal the affected, the wounded, injured, and the one who is suffering. You are his God. Renowned physician William Osler once said, I quote, "The good physician treats the disease, the great physician treats the patient who has disease," unquote. This distinction is more relevant than ever, an age where data can sometimes overshadow the human story. Each patient you encounter brings not just symptoms, but fears, hopes, and a unique narrative that requires understanding beyond textbooks. Modern leaders in medicine, such as Atul Gawande, have also reminded us that the challenge is no longer just to prolong life, but to improve its quality. The measure of success is not only survival, but dignity, comfort, and meaning. As physicians, you navigate uncertainty daily. You make decisions under pressure, often with incomplete information, balancing risks and outcomes. In those moments, it is not just your training that guides you, but your integrity. That trust society places in you is immense, and rightly so. You are entrusted with life at its most vulnerable. Yet, amidst this responsibility, it is equally important to acknowledge the human behind the healer. Burnout, emotional fatigue, and moral dilemmas are real challenges in today's medical landscape. Ancient wisdom again offers guidance. Self-discipline and mindfulness are not luxuries. They are necessities for sustaining the healer's journey. Invest in them. Such gatherings encourage shared learning. As we look to the future, the role of the physician will continue to evolve. Artificial intelligence, personalized medicine, and new therapies will reshape healthcare. But no innovation can replace the fundamental human connection between doctor and the patient. That bond, built on trust, empathy, and understanding, remains the cornerstone of healing. In closing, I invite you to carry forward the wisdom of the past and the promise of the future. Let your practice be guided not only by evidence, but by empathy, not only by protocols, but by purpose. Because in the end, medicine is as much about curing illness as about caring for people. So this is the message by Srimati Aparna Garg. At the end, I would like to tell one real experience. I think for the first time, ERIFEM's 150-seater capacity auditorium is full, brimming full, and that's the great thing, all because of ERIFEM became the nodal CTI since 16th of January 2025. It is great. Thank you very much. The Government of India allowed Indian Railway Institute of Financial Management to be the nodal CTI, health and personal. Thank you one and all for this great opportunity. Namaskar.
Thank you, sir. Thank you very much, sir. And we also thank our DC Madam for providing us such a beautiful ambience for our conference. Now I invite the Treasurer of Railway Association Physician, Dr. Tripti, Senior DMO, Western Railway, to present the report.
Good evening all. Good evening, sir. So I am Treasurer Dr. Tripti on behalf of Association of Physicians of Railways. Want to inform that this is 21st Physician Conference held at Hyderabad. Last year it was in Chennai with almost 75 delegates. This year we had 150 delegates all over Indian Railways, and it has been very nice, smooth. The conference has focused on all fields of internal medicines, from basics to the recent advances, including AI in medical, almost all fields where we can have good diagnostic skills. All eminent speakers were from different super specialty hospitals, as well as all our railway physicians who are very good and knowledgeable. Also, we are looking forward for such kind of full of knowledge conference in future. In the evening, we had a general body meeting where we have decided for the venue for the next meeting, probably any railway or NCR. Thank you.
Thank you, Madam. Now it's time for us to invite our beloved General Manager, Sri Sanjay Srivastava, sir, to give his valuable address.
Respected DG Railway Health Services, my colleagues and friends, हमारे साउथ सेंट्रल रेलवे के लिए बड़ी ही गर्व की बात है कि डीजी साहब ने जो है साउथ सेंट्रल रेलवे को इस कॉन्फ्रेंस के लिए चुना। और नॉर्मली क्या है कि रेलवे में हम जो भी काम करते हैं दूसरों के लिए करते हैं। ये एक अकेला ऐसा डिपार्टमेंट है, इसमें जो भी काम करते हैं हम अपने लिए करते हैं। जो हेल्थ सर्विसेज का जो डिपार्टमेंट है वो हमारे अपने ही लिए काम करता है। और ये जो है इसकी हमारी एक जो सबसे बड़ी जो मुझे कहना चाहिए जो ख़ास बात है कि हम लोग कई बार सोचते हैं कि जो हेल्थ सर्विसेज हैं वो बेसिकली हमारी केवल फिज़िकल हेल्थ का ही ध्यान रख रही हैं, लेकिन उसके अलावा जो है रेलवे की फाइनेंशियल हेल्थ भी जो है हमारी हेल्थ सर्विसेज से पूरी तरीके से प्रभावित होती है। मैं अभी डॉक्टर साहब से बात कर रहा था तो डॉक्टर साहब बता रहे थे कि हमारे कितने अबाउट 1.2 मिलियन एम्प्लॉयज़ हैं, और आप देख लीजिए 4 एवरेज अगर हम लें तो 48 लाख, और इतने ही बल्कि इससे ज़्यादा पेंशनर्स होंगे। तो हमारा बेनिफिशियरी बेस ही 1 करोड़ से ऊपर का है। और अभी इसमें और कुछ और भी ऐड होने वाला है, जैसे शायद बहुत जल्दी कुछ उसमें डिपेंडेंट पेरेंट्स का भी कुछ ऐड हो सकता है। तो हमारा जो बेनिफिशियरी बेस है वो इतना बड़ा है कि अगर हमारी जो ये हेल्थ सर्विसेज का डिपार्टमेंट इसको नहीं संभाल रहा होता तो 2-3 जोन का पूरा बजट जो है हमारा पूरा हेल्थ सर्विसेज में ही जा रहा होता। तो जो उस पॉइंट ऑफ व्यू से भी देखने की ज़रूरत है कि हमारे जो हॉस्पिटल्स हैं वो कॉरपोरेट हॉस्पिटल्स के पूरे कंपैरिजन में होने चाहिए, क्योंकि जो कॉरपोरेट हॉस्पिटल्स में एक तो जिस तरीके का जो उनकी कॉस्ट है और जो उनकी जो एथिकल प्रैक्टिसेस हैं वो भी कई बार जो हैं बड़ी क्वेश्चनेबल हो जाती हैं। तो उसमें क्या है कि हमारा जो अगर अपना डिपार्टमेंट रहता है तो एटलीस्ट हमें एक ये ट्रस्ट रहता है कि जो भी बताया जा रहा है वो रिक्वायर्ड है, और वही टेस्ट हमें कराने हैं, वही हमारे जो प्रोसीजर्स रिक्वायर्ड हैं। और अगर हम किसी को पूरी तरीके से, जैसे काफ़ी जगह हमको आउटसोर्स करना पड़ रहा है आज की तारीख में, उसकी कॉस्ट भी बढ़ती जा रही है और उसमें हम पूरी तरीके से संतुष्ट भी नहीं हो पाते कि जो बताया गया है एक्चुअली वही रिक्वायर्ड है, उससे कम रिक्वायर्ड है, ज़्यादा रिक्वायर्ड है। तो मुझे लगता है कि उस तरफ भी हमें देखने की ज़रूरत है कि जो हमारे जो रेलवे हॉस्पिटल्स हों वो पूरी तरीके से कॉरपोरेट हॉस्पिटल्स की बराबरी में हों। और मुझे पूरी तरीके से यकीन है कि जो आप लोगों की कॉन्फ्रेंस हो रही है वो उसमें बाकी चीज़ों के अलावा इस चीज़ पे भी मंथन करेगी कि हमारा जो रेलवे हॉस्पिटल्स हैं उनका किस स्टैंडर्ड तक लाना है और किस तरीके से हम ऐसा करें कि हमारे जो आउटसोर्सिंग के बिल्स हैं वो कम से कम हो सकें और हमारे एम्प्लॉयज़ को भी और हमें खुद भी अच्छी से अच्छी सुविधा मिल सके और हमें कहीं बाहर किसी दूसरे हॉस्पिटल का मुंह नहीं देखना पड़े। तो मुझे लगता है कि हमारे DGRHS साहब भी इस विषय में काफ़ी इंटरेस्ट लेते हैं और वो जो है इस विषय में हम लोग इस कॉन्फ्रेंस के बाद जो है कुछ एक अच्छे निर्णय पे पहुंच सकेंगे। धन्यवाद।
Thank you so much, sir. Now I invite our Director General Railway Health Services, Dr. Jagdish Chandra, sir, to give his valuable address.
श्री संजय कुमार श्रीवास्तव जी, महाप्रबंधक साउथ सेंट्रल रेलवे, मैडम श्रीवास्तव, डायस पर उपस्थित ADG IRFM, PCMD SCCR Dr. Nirmala CHD and Organizing Secretary Dr. साई, हॉल में उपस्थित पूरब से पश्चिम तक, उत्तर से दक्षिण तक हमारे प्रमुख मुख्य शिक्षक, PCMDs, CMDs, MDs, CMSs, physicians all over the Indian Railways, students of this Lalagoda hospitals, and ladies and gentlemen. पहले तो मैं चाहूँगा कि साउथ सेंट्रल रेलवे के लिए आपकी तालियां हो जाएं। उन्होंने एक बहुत ही अभूतपूर्व कॉन्फ्रेंस का आयोजन किया है और बहुत ही शॉर्ट नोटिस में हम लोग कभी हाँ कभी ना, कभी होगी कभी नहीं होगी, मौसम ठीक नहीं है, परिस्थितियाँ अनुकूल नहीं हैं, अरेंजमेंट हो पाएगा कि नहीं हो पाएगा, आपने सबको मात देते हुए एक अभूतपूर्व गैदरिंग यहाँ पर इकट्ठा की। आप सभी को बहुत बहुत आभार और धन्यवाद। जैसे कि GM साहब ने कहा कि ये जो मेडिकल कॉन्फ्रेंसेस, हालांकि रेलवे का और डिपार्टमेंट दूसरे के लिए काम करते हैं, पब्लिक के लिए काम करते हैं, लेकिन हमारा विभाग जो है हमारे अपने रेलवे एम्प्लॉइज़ के हित में उनकी ज़रूरतों की और उनके स्वास्थ्य की आवश्यकताओं की पूर्ति के लिए दिन रात लगा रहता है और इस चीज़ को बखूबी आप लोगों ने कोविड काल में सिद्ध किया है। चिकित्सा विभाग का हमेशा एक मिशन स्टेटमेंट रहा है कि हम जो भी हेल्थ केयर नीड हैं, चाहे वो प्रिवेंटिव, प्रोमोटिव या क्यूरेटिव हेल्थ केयर हो, मैं कहूँ तो टोटल हेल्थ केयर हमने बहुत ही इफ़ेक्टिवली और कॉस्ट इफ़ेक्टिव रूप में और इथिकली हमेशा देने का प्रयत्न किया है। और उसका जो विश्वास है, GM साहब ने जैसे मेंशन किया कि जो परिवार की जो फीलिंग होती है, जो हमारा बेनिफिशियरी, हमारा मरीज, हमारा कर्मचारी जो फेथ हमारे अपने डॉक्टर्स के ऊपर रखता है, उतना शायद किसी कॉरपोरेट या किसी बड़े हॉस्पिटल में वो नहीं रख पाता है। इसके पीछे एक दिल का लगाव या कनेक्ट कह सकते हैं आप, जो हम लोगों ने हमेशा मेंटेन रखा है। मेडिकल साइंस बहुत तेज़ी से तरक्की कर रही है और दिन प्रतिदिन इस विधा में भी नई नई, जिसको आप कटिंग एज टेक्नोलॉजी कहते हैं, वो आ रही है। और हम लोग, हमारी जो पूरी फ्रेटर्निटी है, हमेशा इस बात में लगी रहती है कि हम इसके साथ, रादर इसके आगे चलें। अभी एआई का दौर आ गया है और इस एआई को हमारे हेल्थ केयर प्रोफेशनल्स, रेलवे हेल्थ केयर प्रोफेशनल्स ने बखूबी इसके साथ जेल किया है और एक्सीलेंट साबित करने के लिए हर फील्ड में हम लोग आगे बढ़ रहे हैं। कोई भी मॉडर्न टेक्नोलॉजी या हेल्थ केयर सिस्टम आप कह लीजिए, तो इंफ्रास्ट्रक्चर डेवलप करने के लिए, ह्यूमन रिसोर्स डेवलप करने के लिए एक कॉस्ट लगती है। हम रिक्वेस्ट करेंगे हमारे एडमिनिस्ट्रेटर्स से, प्रशासन से, कि बेहतर से बेहतर सुविधाएं देने के लिए हमारी कलेक्टिव कोशिश होनी चाहिए टू डेवलप आवर इंफ्रास्ट्रक्चर इन फॉर्म ऑफ हॉस्पिटल्स, हेल्थ यूनिट्स, adding up newer modalities, newer equipments, newer technology, so that our beneficiary can have faith and confidence in our system। और हमारे जो हेल्थ केयर प्रोफेशनल्स हैं उनका भी कॉन्फिडेंस और मनोबल जो मॉडर्न टेक्निक, गैजेट्स, मशीन्स और वर्किंग एनवायरनमेंट इम्प्रूवमेंट होने से बढ़ता है, जिससे कि वो और भी बेहतर तरीके से अपनी सेवाएं दे सकते हैं। कॉन्फ्रेंस एक सतत शिक्षा कार्यक्रम है जिसमें कि सभी डॉक्टर्स, हमारे जो एक्सपर्ट हैं, जो हमारे सीनियर्स हैं, हॉल में मैं देख रहा हूँ बहुत ही वेटरन्स लोग भी हमारे बैठे हुए हैं, उनसे हमारा इंटरेक्शन होता है, उनसे गाइडेंस मिलती है। और इसके अलावा जो भी विश्व में नई तकनीक या नई ट्रीटमेंट की मोडेलिटीज़ आ रही हैं, उनके बारे में ज्ञानवर्धन और ज्ञान का आदान प्रदान होता है। ये मेडिकल साइंस की एक ही बहुत मैंडेटरी एक्सरसाइज है जो कि हम लोग कर रहे हैं। एंड मैं धन्यवाद देना चाहूँगा साउथ सेंट्रल रेलवे। शायद ये मेरी तीसरी गैदरिंग है जिसको मैं बैक टू बैक अटेंड कर रहा हूँ। 2 times I think I assumed this position, and इसके अलावा जब मैं PCMD था तो I have attended। यहाँ के जितने भी डॉक्टर्स हैं, they are highly talented, not in medical profession, but culturally they are very rich. You must have witnessed today's evening very scintillating cultural program. Everybody, every doctor is power packed. On the stage you cannot recognize whether he is a medical profession or a pure artist or accomplished profession. So heads off to the team of SCR। अगली टीम, अगली जो कॉन्फ्रेंस के लिए ऑलरेडी अभी अनाउंसमेंट हो गया है, और हमारी बेबी मैम, शी इज़ स्माइलिंग, डॉक्टर सुषमा माटे और एनसीआर से आई थिंक हु हैज़ कम, कैन यू रेज योर हैंड? सो दीज आर द 2 probable zones. So I will request start preparing to host another grand event. So all the best to you. And finally, I would like to thank GM Saab and his team of officers of South Central Railway and team of doctors from SCR for organizing such a grand conference. Thank you very much.
Thank you so much, sir. Now I request all the dignitaries to participate in the souvenir release. Dr. Sai, sir, to coordinate. తీసారా Thank you, madam. Thank you, sir. Now I request Dr. Chelagiri, sir, our CHD, to propose vote of thanks.
Today we are coming to the end of this program, that is the vote of thanks. I first of all thanks our beloved DGRHS, Dr. Jagdish Chandra ji, sir, and Madam Usha Chandra also for attending this program. Thank you, sir. From beginning you supported for organizing this wonderful event. I thank you very much, sir. Secondly, thanks our beloved GM sir, Sri Sanjay Kumar Srivatsav sir, and Srimati Vandana Srivastava madam. Thank you very much, sir, for attending this program and making this function a grand success. I thank Srimati Aparna Garg madam, even though she is not there, or represented by ADGM sir, Sri Shantiraj. Thank you, sir, for attending this program, sir. I thank Dr. Sai, organizing secretary, who has done day and night work for success of this program. I thank Dr. Nirmala madam, PCMD, backbone for this organizing this this one. She has all the time helped in all the, even almost 2 months, every week she is conducting the meetings and calling all the doctors how to organize. So for nearly 2 months, madam has continuously interacted with our doctors to make this program successful. I thank all the PHODs and DRM sirs and all the PCMDs and CMSs sir who have come here. I thank all the delegates and their families who came in a large number. And today's program, cultural program, as our DGs are appreciated. So wonderful cultural program they have performed. I thank all the artists and our doctors. They also worked very hard to make this cultural program success. And I thank one and all for this program. Thank you, sir.
Thank you so much, sir. We come to the end of the inaugural session. I request all the dignitaries to please take the seats in the audience. Thank you so much, sir and madam. Before proceeding to dinner, we have a small special program. I request our Director General, Sir, Dr. Jagdish Chandra, Sir, and Madam Usha Chandra to come onto the stage. I request our PCMD, Madam, and Dr. Sai, Sir, to come in and conduct the felicitation program of our DG, Sir. I request our DG, Sir, and Madam to come onto the stage. Dr. Jagdish Chandra, sir, belongs to 1987 IRHS batch, served railway for 39 years, joined Indian Railways Medical Services in October 1987 at Perambur as a senior resident. And he worked in Northern Railway, Southern Railway, East Central Railway, and now in the position of elevated apex level 17 post of Director General Railway Health Services since 16 June 2025. Sir, it's our pleasure to honor you. And Madam. Music. Dr. Jyotsna and Dr. Mahita to coordinate. I request our PCMD Madam and Dr. Sai Sir to conduct the felicitation.